some more answers. A very good morning to all of you. Welcome back to this committed audience. We are committed to learning more and more and more about this health issue that covers the skyline of our lives like dark clouds. But efforts like these in learning more, they are the silver lining so that we can hope for prevention, better cure, and better rehabilitation. I welcome you all to the first scientific session for today. I request Dr. Reggie Paul, consultant neurologist, Kochi, to kindly chair the first session. I also request Dr. Sheba Ninan ma'am to please co-chair the first session for the day. They say the best learning is when the foundation is strong. So we must keep revising and re-revising the primary pathology and the symptoms of what we talk about as dementia. I would like to invite Dr. Matthew Varghese sir to kindly talk about the basic symptomatology in dementia. Sir is a senior professor of psychiatry at NIMHANS, Bangalore, and he has had over 200 publications, including Dementia India Report to 2010, and he has also published Dementia in India in 2020. I request sir to kindly start the sessions for today.
So what is in the program is Global Perspectives, which was covered yesterday very efficiently by our ADI Vice Chair, Meera. So I saw the program and I said that I'm not going to repeat that. And I looked in the program and I said the only thing that is not covered, one of the things that is not covered is how to evaluate and deal and manage with behavioral and psychological symptoms of dementia. So just to tell you all that that is a change in the topic. Good morning everybody, and thank you very much for being here, though we are half an hour late. People are still milling out outside, I think. But it's great to be back in Pune. Amit and Ronnie and a few of us were remembering our last sojourn here. I think it was 2011 or so, when I think Ronnie and colleagues had just sort of started their dementia facilities, but I understand that it's grown, and probably Ronnie has got one of the largest dementia care facilities in the country, because he's got, in addition to mentally ill people, he's got almost 500 people in Pune itself. And then of course he's got branches in Cochin, Goa, Nepal and other places. So it's really grown. And from what I knew of Ronnie way back, when he first trained with us in the Richmond Fellowship Society in Bangalore, and he thought of starting rehab centers, must have been some 30 years ago. That it's fantastic. And it's fantastic to see lovely 2-day conference organized after a 5-year gap post-COVID. So thank you very much to all of you for coming here, and thanks for being here this morning. So now, when I do a clinical presentation, I usually tell people that we must remember with dementias the ABCs of dementia. Now, though the cognitive symptoms are the most prominent and talked of for diagnosis, what bothers the caregivers equally is the activities of daily living and the behavioral symptoms. Because all of us know that by the time somebody is in a moderate state of dementia, he or she is not able to do a lot of the IADL and ADL activities. And in the severe stage and the very severe stage, they become fully dependent on the carers at home. But today we're going to talk about the B, which is the behavioral symptoms. And you'll see that the interventions that are suggested for all these ABC symptoms are more or less the same. You don't sort of specifically go targeting one or two, just sort of target all of them together, because relatives can't really make out, which is because of what. So the various definitions of BPSD, we call it short for BPSD. Basically, they are the neuropsychiatric symptoms of dementia. These are the so-called non-cognitive symptoms of dementia. So it's defined, the definition that stands is the one by the International Psychogeriatric Association, which says symptoms of disturbed perception, thought, mood, or behavior that frequently occurs in patients with dementia. And there is a heterogeneous range of all kinds of symptoms and behaviors. And these non-cognitive symptoms, it's now recognized that it occurs even in probably as early as MCI. There's a concept called minimum behavioral symptoms or behavioral impairment called MBI, which is a concept that has come up together with MCI. So it can be any time preceding even 2 years before the dementia, but very commonly in the moderate and severe stages. Now, the importance of behavioral symptoms is because, first of all, we have to remember that it's part of dementia, though it's not part of any of the diagnostic categories. In the DSM and the latest ICD-11, behavioral symptoms have been brought into the as an inclusion term to say that with or without behavioral symptoms. But the importance is that it causes a high cost with not just family carers, but also with the health system, because that is what causes people to be admitted to facilities, causes people to be institutionalized, and causes people who are in institutions and also in homes to actually burn out because of looking after the persons with dementia. You saw very beautifully how that is portrayed yesterday in 2 of the movies, especially in the latter one where Professor Agashe acted so well. I mean, that is a typical case of how a person with aggression and difficult behavior would behave. But the important thing is that they are recognizable. You can understand why it happens. Relatives and family carers can be taught to understand what happens, and more importantly, it's treatable. So, in terms of looking at how common it is, it's present in over 2/3 of people with dementia. Most of the prevalence studies show that it's very, very common. And the common ones are things like delusions, that is, having false notions that somebody is trying to harm them or somebody is trying to steal things, or the people outside are trying to do something. Wandering behavior, many times wandering is related to, as you saw yesterday, people saying that I want to go home. They might be at home, but they say every morning they get up and say, I want to go to my house. And then whatever you do, that doesn't stop. And then, of course, agitation, which is something, again, that you saw in the movie. So, as I said, they develop early and they go on. And you can see probably higher rates of depression and anxiety and retardation. So some mood symptoms may be much more common in vascular dementia rather than Alzheimer's dementia, but that's really not very clear. Now, causes, to this audience, I don't really want to go too much on the causes, but basically they occur, it's not willful behavior. That's the important thing to mention. Because many carers think that it's willful behavior. He or she is doing it on purpose, Sometimes he is fine. Why is he behaving like this now? He can say this and he can remember this, but at this point of time he is being stubborn. So it's not willful behavior. Though sometimes there might be some stubborn behavior which seems willful. That is possible. But basically they're because of brain changes, chemical changes. Many times it's because of medicines that the person is on. Sometimes giving some drugs can cause confusion. Urinary tract infections can cause problems and confusion. Pain can be an issue because of pain they might have behavioral symptoms. So it could be biological. It could be personality, like somebody mentioned yesterday. It could be exacerbation of somebody's personality, or diminishing. It could be because of life events. A daughter or son who was in the house leaves home, and then they miss that person, and then the whole thing starts. Where is my daughter? Where is my daughter? They go on, saying that. Or you change house. This is something that happens with carers in cities. For 3 months they live with one daughter, then for 3 months they'll live with another son in Chennai, and then 3 months later they'll come to Mumbai. I mean, it's unavoidable because the sibs have decided to look after, the children have decided to look after this person. But for the person with dementia, each environment is confusing, and it takes a few weeks for the person to sort of get back to familiar surroundings. So it could be because of the environment, because of stimulation. And as I mentioned yesterday, during COVID, a lot of people were incarcerated in their homes, especially old people. And I know in places like Kerala, if you are living somewhere else, the police wouldn't let you go and visit your old mother or father who's living somewhere. I remember my mother-in-law they were living in Kottayam, but just 8 kilometers away was where my brother-in-law was. He was not permitted to go and visit till he had to tell the police, hey, I have to go and give medicines to my mother, who's 90. She didn't have dementia, but the point is that she was just isolated in the house. So, what you get today is not what you will get after 2 months. So, don't think that if today somebody is aggressive, that will be the state even 2 months later. So, this is important for carers and also important for medical and mental health professionals, because don't think that if you're given some medicine this month or done some intervention this month, you have to continue it for life. No. You hope and pray that the behavior that is there this month changes next month. So there is a lot of waxing and waning in different phases and from month to month. And as I mentioned just now, recent emergence, so somebody who's fine for 3-4 months, 6 months, and suddenly this person starts behaving belligerent and irritable and all that, then you must think of a lot of physical things, like for example electrolyte disturbances. Low sodium is something that we have seen, which we miss many times. Low sugars, people who are diabetic, who have got low sugars or have very high sugars. Certain drugs that are given and toxicity as a result. Interactions between different drugs. So for example, in Parkinson's disease, you might give triacylphenidal. Now, triacylphenidal is notorious to cause confusion states. Sometimes, some antidepressants, many people just simply write tricyclic antidepressants. Especially, I see non-psychiatrists doing that, because we psychiatrists are very careful about writing tricyclics. But they give some small dose, 10 milligrams, 25 milligrams, and that can cause a problem. Inactivity. So I say, one of the prescriptions that I put on my prescription pad, I write drugs, then I say, hey, this is also very important, and that is, I always write for everybody, exercise. Half an hour exercise, brisk walk outside the house, if possible morning and evening. And I also write daily activity schedule. I ask them to make a timetable. Sadly, very few people follow that part. Though I say this is very important, they're happy. It's simpler to give medicine. So simpler for doctors to also write medicines. So we are all very trigger happy and writing medicines all the time. The moment somebody comes, put them on medicines. Yeah, so like I said, you must look for urinary tract infections, pneumonias, constipation. Yes, I mentioned pain, but constipation is something that really bothers people with dementia. They have not gone past motion for 2-3 days. They're really restless. I mean, normal people get restless, isn't it? So people with dementia definitely will get restless. And of course, recent things, many times when you have, in addition to doing all the blood parameters, one of the things that we do is to also, if you get recent emergence, especially with some neurological signs, gait disturbances, incontinence and all that, you look for subdural hemorrhage, because they might have fallen somewhere, or they may not have fallen somewhere, they might have just banged their head somewhere, and the atrophic brain, it's very easy for somebody to get a subdural hemorrhage. You don't have to have a head injury. Just for severe shaking of the head can cause subdural hemorrhage sometimes. So these are things that so it's very important that when you have recent emergence of behavioral symptoms, to go to a doctor and for the doctor to figure out what's happening. Now, there are various instruments to assess. I will not bore you with this long list, but remember the common instrument that I use to assess BPSD, the common one that all of us use is the Neuropsychiatric Inventory of Cummins. Cummins is a neurologist from California who's made this very popular. The less popular one is the one designed by Barry Reesberg, who's a psychiatrist from New York. That's called the Behave AD. Then there are a whole bunch of other things, there's one for agitation, one for depression, one for pain, one for sleep. There's so many different instruments. Don't bother too much about it. So the commonest used one, Neuropsychiatric Inventory, contains simply 12 items, and you don't have to go through the whole process of rating it 1 to 4 and all those things. If you just tick off which is present or not, it's simple enough. So there are different versions of this NPI. There is a nursing home version, there is a clinical version, and so on. And there's ratings of severity, frequency, and all that. Again, that's all for research, so don't really bother about it. And the time taken, if you have done an interview with the patient, you can just tick it off and fill it in just about 10 minutes. If you're using it for a research study, it might take you 20 minutes or more, depending on level of psychopathology. I mentioned the Behave AD. Again, if you've done a clinical interview, so the NPI assesses in the last 1 month, while the Behave AD assesses in the preceding 2 weeks. This is a little longer, the 25 items with 7 subscales, and the subscales are basically this, almost similar to what the NPI is. But if you've done a clinical interview, a psychiatric interview, you can easily sort of check this boxes and fill it up. So these are the usual symptoms: paranoid delusions, hallucinations, activity disturbances, aggression, sleep rhythm disturbances, affective mood changes, fear, anxiety. So similar in both the NPI and the Behave AD. And these are the common symptoms. As you can see, apathy is a big problem, and many times apathy you can do little about. Apathy might be okay for the carers at home because it's much better than irritability or aggression. But the thing is that you cannot get the person out of that chair. They just sit, they continue sitting the whole day, or they lie down and they just continue lying down the whole day. Sleep is a big issue, and we can do something about sleep, fortunately. Irritability, motor behavior, just spacing up and down, being restless, getting up and down, sitting up and getting up. Delusions very common, especially in the mild stage and moderate stage, when they start losing their memory and they say, the servants have stolen my things. The jewelry that I kept here is missing. People in the next door house are, saying something, and so on. Appetite disturbance is a big issue. I mean, feeding people you saw yesterday how getting something into the person's mouth is very difficult. Sometimes if you have things like a frontotemporal dementia, you might have appetite for all kinds of things. They pick up everything that's there and put it in their mouth, especially things like sweet and all kinds of odd objects because of hyperorality. And of course, depression is pretty common. So overall, if you look at the more number of BPSD that is there, you will find that lower is the cognition. There is increase in severity of the symptoms. It causes early admission. It also causes, because of various reasons, it causes increased mortality. Usually when the BPSD keeps ramping up, then very soon I have seen a few patients who sort of die after some time. Of course, it causes increased caregiver burden. And if you get the psychotic cluster where you have hallucinations and delusions and aggression and all that, that usually leads to rapid cognitive decline and also early mortality. Now, family members and non-formal carers, you heard very clearly, usually women are the ones who do the caregiving. And non-formal carers, as we were discussing in the last couple of days informally, it's very difficult to get some non-formal paid carer to stay at home. And the moment they find that there's behavioral symptoms, they just vanish, they run away. Whatever you do, you get the next one, And then I think the network knows, hey, don't go to that person's house because there's somebody who's difficult. So then you have to go to another agency, and then they get involved. So your sort of chances of getting somebody are really difficult. And if you have to get a trained nurse who will come, they're very expensive, anything from 1,500 to 2,000 rupees or more. I mentioned that, first of all, dementia is not recognized as an illness, and BPSD is seen as something that is willful. So there's double trouble for the person with dementia and the carer. And that leads, you could see yesterday how it's so easy to just push the person or just shake the person or just beat the person. And I don't blame carers for getting frustrated and losing it. It happens. It's like what happens with children, when the kid goes around screaming, you just give it one whack, isn't it? And then they shut up. Though we are not supposed to whack kids. But that's what, it causes a lot of frustration. And I can imagine that it's so easy to have abuse. And then of course neglect, if carers go out of the house, Amit used to have some lovely posters from his home care program where you had a lady, I still have these images of that, of a lady sitting in a cot, nobody in the house, there's urine and feces under the bed. She's just there, she's in the bed. Some people are tied up. They just lock the door and go away. That's what happens. And more than anything, most carers have morbidity themselves because caregiving causes high degree of anxiety and depression. So 30 to 40% of carers, and this is something that all of us should watch out when we see people who have family members who have dementia patients at home, they get depression and anxiety. So usually the women get depression and anxiety and the men have physical illnesses. They say that, they fall ill physically because men don't probably emote as much, I don't know, but they fall ill. They get headaches, body aches, they go to the doctor for heart problems, so usually it's seen that men who are carers have physical illnesses, women get depression and anxiety. And of course, the burden is much more in nuclear families. So if there are many carers to look after in large families which are more than 3 or 4 in size, so you have the daughter, the son, the daughter-in-law, so many people to look after. But if there's just one person in the house, as you saw yesterday, it's tough. And you have kids in the house, it's double burden. You saw that other lady who had 3 kids and this old lady who had to look after. So if you have kids below 16, bigger problem. So this is a way to assess behavioral symptoms. This is just an algorithm. There are many algorithms, but this is a sort of simple one, so I'll show you this. First of all, you describe and measure the symptoms. So what is the behavior? When does it occur? What happens? How does it happen? So you do what is an ABC paradigm. What is the antecedent behaviors? What is the behavior? And what is the consequence? So sometimes when you do the analysis, you might find that, all these behavioral symptoms start in the evening, when there's maybe sundowning. Or sometimes you might find the person gets up in the morning and that's when all the behavioral symptoms start. So you might want to link it to various things. Might be inactivity, might be constipation, might be pain, might be lack of stimulation, whatever. So you try and link it to various things. Are there depressive symptoms? Is there emotional dysregulation? Is there insomnia? Is the person sleepless? And then the person sleeps during the morning and then doesn't sleep in the night. Are there safety concerns? Are they trying to run out of the house, go in front of traffic? In what context and what triggers are there? And what is the family dynamics? Who's being angry? So if there's somebody who's patient, it's very typical, as you have with kids. If you're calm and patient, the person with dementia will also be most of the time calm and patient. But the moment you start getting aggravated, it's exactly what happens with kids. I got about 5 minutes? Thank you. Okay. Yeah, so I'll go quickly. So can you explain, try and explain what is the BPSD caused by, and then look at different pathological factors. Is it medication? Is it confusion? Is it subdural? Is it urinary tract infection and so on? Is there some medication? Is there some other comorbid illness like urinary tract infection and so on? Then in the treatment, you work on what factors you can modify. Work on the modifiable factors. Explain the non-modifiable factors to the carers. For example, some things you can't do anything about. Support carers, you provide all the support you can do. Provide comfort to the patient, and most importantly, give non-pharmacological interventions first. It is recommended in all the criteria, all the sort of programs that drugs are the last thing to be given. But like I said, we are all trigger happy. And then, of course, finally consider drug treatment. And then you evaluate, was the intervention feasible? Was it effective? Did it improve sleep quality? Did it improve quality of life? Did it improve caregiver stress and so on? And then if it doesn't, then you can again use problem-solving strategies to sort of get back and evaluate them. So there are so many guidelines, but the good one to follow might be and there are a lot of pictorial ones, you can follow the Royal College guidelines, which is the Australian, New Zealand guideline, which is important. You can follow this is the Indian Journal of Psychiatry guideline, which has come out a few years ago, 2018, by Shaji and others. You can follow that. That's also got something on BPSD management and evaluation. A lot of books and pamphlets. I particularly refer you to Swapna Kishore's website. That is dementiacarenotes.in, and she keeps updating it. She usually comes for these ARDSI programs. I don't know where she's this time, but single woman who's sort of campaigned fully for all kinds of resources about dementia, and that's really to me, that's really the best website. You have various programs like the eye care and I'll talk briefly about the eye support program that we developed for the WHO in Bangalore, and then now the eye support is being tested all over the world. So the eye support has got 23 lessons in about 5 modules, but if you look at the last one, which is dealing with challenging behaviors, is what we want to do today. And that's the 10 lessons, which talks about memory loss, aggression, depression and anxiety, difficulty sleeping, decreased judgment, walking and getting lost, repetitive behavior and so on. So you have modules which will sort of, these are self-help program which is online. The eye support manual is there online on the WHO site. So you can download it and use it. But they're making apps and making other programs that is there. There's another program that we have made based on the eye support. It's called Moving Pictures India, where you use short clips of say just 2-3 minutes describing different behavioral problems and how to handle them. So this is what happens in a particular study in 2017 in a UK general hospital. Prevalence was, as I mentioned with all other studies, 75%. Aggression, sleep and activity disturbance were the common. The common medicines that were used was antidepressants in 16%, antipsychotics in 12%, benzodiazepines in 12%, sedatives in 3%. And most of the time they were likely to die on antipsychotics because of various things with mortality. Non-drug treatments were given only in about 55% of patients. That is, psychosocial treatments were about 36% and restraint, unfortunately, in 22%. So you can see that, even in and this is one of the sort of good studies that was done. You can see that, most of the time, 25%, 30% of the time they get medicines. And these are different non-pharmacological treatments that you can look at. So there are sensory enhancement treatments, things like massage and touch, individualized music therapy, white noise, controlled multisensory stimulation called the Snoozelen method, art therapy, aromatherapy. These are all sensory enhancing or relaxing kind of techniques. Then there is a social contact therapies, which is basically individual social contact, assisted pet therapy, one-to-one social interaction, using trained persons who can look after the person with dementia. Simulated interactions, for example, family videos or things like albums and so on. Then you have behavioral interventions, which is differential reinforcement and stimulus control. Structured activities, again, as I said, very important. Recreational activities, outdoor walks, physical activities. This is something that is helpful. Environmental modifications, again, something very useful. Sometimes you change the environment, increase light, decrease light, make it quieter, um, make the wandering areas natural. For example, have a garden area where the person can actually wander. Or when the person says, I want to go home, take the person out for a drive and come back. Environmental manipulation, reducing stimulation and light therapy. Then you have various things for training and development, training for the staff, training for the family carers, and so on. So quickly going through some of this. Music therapy, okay, usually use pre-recorded instruments, music. Usually music that the person is familiar with, So sometimes they sing along, that's a good thing. And live music might actually reduce apathy. And sometimes playing and singing in groups, as Amit showed yesterday, when you do CST, you can have somebody joining in and singing some common songs or rhymes that people know. That might reduce agitation and anxiety. So music therapy is important, is good with various studies in reducing behavioral symptoms, also depression and some anxiety. So it's a useful therapy to use. Aromatherapy, so it can be just diffusion of oil in the environment or application as part of massage therapy. You can use different things like lavender, melissa, lemon balm, and so on. It's an adjunct for agitation. And various studies that have been done together with acupressure has shown that it might improve agitation or aggression. Yeah. Okay. Bright light therapy, again useful for people who have sleep disturbances together with melatonin. It may not improve depression. Touch therapy, I already mentioned that touch therapy might be useful for agitation, for wandering, for verbal aggression, and of course cognitive rehabilitation, cognitive stimulation therapy or cognitive retraining. Reminiscence therapy, again something that's useful, again mentioned by Amit, looking at through photographs and movies that you can see. Behavioral management, not very useful. Using token economy and all that is not very useful. But tailored activity programs like daily activity schedule is quite useful. And so is physical exercise. Might improve aggression, just walking, aerobic activity. Psychoeducation with the training of carers, very useful. And in fact, that is the one that is the most useful and has the long-lasting effects. Very quickly to drug management, I'm not going to talk a lot about because also I've run out of time. But yesterday you heard this, cholinesterase inhibitors, as useful for behavioral symptoms as Manjari mentioned for cognitive symptoms. So donepezil, reach the full dose of 10 milligrams. Rivastigmine, you must reach the full dose of at least 9 to 12 milligrams, divided doses. Galantamine is the other one, you must reach a dose of at least 16 to 24 milligrams, otherwise it's really not useful. Again, useful in all ABC symptoms, cognitive, behavioral and ADL. Memantine is the other drug, and memantine can sometimes be combined with galantamine or, donepezil or rivastigmine. Must get to the dose of at least 20 milligrams of memantine in divided doses. So it can be combined, combination is useful. And these are the psychotropics that are used. Psychiatrists and neurologists and geriatricians use this. Very low doses, small doses of antipsychotics or antidepressants. Usually antipsychotics, the evidence and the usefulness is only for psychotic symptoms, agitation or aggression. You don't use it for anything else. Don't use it for other kinds of behavior. And combinations of different medicines can produce more EPS or less EPS. And usually you give for a short time and try and withdraw it after about 3 months. Usually after starting the cholinesterase inhibitor. Antidepressants can be used, again, SSRIs. And usually some people have used it for delusions and anxiety and depression. but you need to be watching for hyponatremia and insomnia and other things. Other drugs, carbamazepine and valproate has been useful for mood symptoms, especially for exacerbation and mood ups and downs. Benzodiazepines can be used for insomnia, very good for REM behavior disorders, but you must watch out for sedation and falls and delirium. So with psychotropics, you start low with a second generation antipsychotic or an SSRI and then go slowly up. When you add the cholinesterase inhibitor, try and take off the psychotropic in a matter of 3 months and taper and stop very quickly. Can use benzodiazepines. So in conclusion, treatment strategies focus on symptomatic relief of various ABC symptoms. You must analyze the BPSD, start psychosocial management first, and then only move on to cholinesterase inhibitors and other drugs. Cholinesterase inhibitors, of course, are part and parcel of all dementia treatment, so that is a must. That drug you must give. Avoid psychotropics, especially antipsychotics, give only brief duration. Thank you very much.
So that we can take the question and answers at the end of the segment. So my daughter was reviewing my compare notes from yesterday and she really liked something and she looked at me and she said, AI, that's artificial intelligence. And I frowned at her and I said, no, this is your I. To get the joke, I means mother in Marathi. So technology, a double-edged sword. And we have been on and on since yesterday that it is one of the things to be blamed for our cognitive dullness. So it's going to be very challenging for our next speaker to see technology in the light of a helping tool in dementia. When it comes to introducing our next speaker, if I had the permission, I would have shared his WhatsApp number with you. They say a picture speaks 1,000 words. So his display picture just reads neuropsychiatrist, behavioral neurologist, and illuminer. I think that describes him much better than the technical description that I would have otherwise read out. I would like to request Dr. Krishnamurthy sir to please deliver the next very challenging topic.
Thank you. So, good morning, everyone. And first, thanks to ARDSI, ARDSI Pune, and Chaitanya for the very kind invitation to be here today. My topic is technology in the management and care of a person with dementia. And it's always nice to be asked to do something because that makes you put in some effort to put information together, which is what I've done for this topic. Now, in 2012, I was one of the global chairs of the World Health Report on dementia. And I actually edited the whole segment on caregiving. And what were we saying in 2012? We talked about telephones and video phones for counseling and support services. We talked about video-based psychoeducation interventions for improvement in mental health. And we started talking about social media platforms. This is what we were preoccupied with in 2012. And what did we say about assistive technologies? We said that they could improve safety, economy, support people, improve their quality of life, give peace of mind to caregivers, and we need more research to evaluate them. This World Health Report is available for you to download and read, free to web. Now what's happened subsequently? We are now talking about Amazon, Alexa, Google Home Hub. We're talking about robots, we're talking about virtual reality, artificial intelligence, and autonomous driverless vehicles. So technology has changed. Dementia has not. Caregiving has not. But technology is changing very rapidly, and technology is giving us an opportunity. And I think that we need to embrace that opportunity. How many people in this room are under 35 years of age, please? Hands up. I see quite a few hands up. How many people in this room are over 50 years of age? Hands up, please. Okay. Now, so this comes with a disclaimer and a warning. If you're over 50 years of age, you'll think all this is not possible, it's not going to happen. Okay? If you're under 35, you're going to be interested. And the challenge for the people who are younger is that the decision makers are people like me, older and slow to adapt and not willing to think. Okay? So that's another challenge that we'll all have to accommodate, but technology is exciting, and let me tell you why. Okay? So we are actually looking today for people with dementia at complex smart home systems to the 4th generation of human-like social and service robots. Now you'll say, oh, this will happen in Japan, this will happen in the US. It's not going to happen in India. It's certainly not going to happen to the ordinary person in India, right? I'm recording my talk as we speak, and my team's kitted me out to carry a kit that does its own recording. This is happening in India. There's a lot of things that are happening because as technology generalizes, technology becomes cheaper. And if you bought a car 10 years ago and you bought a car today, you will notice how much difference. You bought a two-wheeler 10 years ago, you bought a two-wheeler today, you'll notice how much difference there is. So technology is rapidly growing, technology is adaptable. The faster technology generalizes itself, the cheaper it becomes. And this is something that all of us need to wake up to as well. Now, I have a few slides I borrowed from my good friend and colleague from Singapore, Dr. Kandaya. Dr. Kandaya is working at the cutting edge of how do you use technology actively, digital technology actively. The point we need to understand, therefore, is we start with normal aging. We go through a phase of subjective cognitive impairment. We go through a phase of MCI. And then finally, we end up with dementia. And therefore, the pathology, there is a preclinical and mild cognitive impairment. There's mild dementia. And then there's moderate to severe dementia. The earliest phases are at least 10, 15, 20 years before you become symptomatic. Most of us start walking when we are in our 40s and become aware that we need to walk. Yesterday, someone was saying we should do 8,000 steps. Actually, the cerebrovascular and cardiovascular recommendation today is 10,000. It's being revised to 15,000 steps a day. Okay? So most of us start doing these things by the time the damage has already happened, right? So we're doing what we can. So you need to start walking or you need to start exercising much earlier. And this is something that you need to keep in mind. But there is an opportunity here also to think about what we've been talking in this conference. It's not just cognition that we ought to be concerned about. There are behavioral red flags, as Dr. Matthew was just talking about. And there are physical red flags. I don't know if you notice how many of us, as we get older, walk slower. We walk more cautiously. We hold on to rails when we go down steps. Those are the physical accompaniments of neurodegeneration, and they are also hallmarks of possible dementia. Important to keep this in mind. And then, of course, if you think about it, there are a very large number today of digital diagnostic tests. A very large number of clinical trials today for dementia are run by cognitive tests that are administered digitally. Okay, so it's possible. I use in my practice very extensively. So I have from autism to Alzheimer's, I have patients. My youngest patient is 1 month old with neurodevelopmental disability. My oldest patient is well into their 90s. Okay, I use cognitive tests, which are digital online tests to evaluate people. And it's possible to do. I bought a subscription with a US platform. I charge a pretty penny to do this, right? But if the Indian government put that into the ICMR toolbox, then all of us could start using a digital diagnostic test. So it's not about whether we should pay. The question always in public health is who should pay, right? And for something to be democratized, you shouldn't have to pay as a citizen. I think that's the point that you need to keep in mind. And then, of course, what has happened is that smartwatches. Now, how many of you are wearing a smartwatch? Hands up, please. So how many of you know how many steps you walked yesterday? How many of you are tracking your goals? So the whole point, the bottom line, you can do it on your phone as well. The bottom line, therefore, what if your wearable tracked those 9 things that they've been talking about from the Lancet paper, which are relevant for cognition, which are relevant for dementia? It's possible today, right? For example, my Apple Watch tells me, oh, walk 1 more minute and you would have done you'll meet your goals today. So when I park my car at night after clinic, I will go walk that 1 minute around my flat and then go in, because it told me. If it had not told me, I wouldn't do it. It's as simple as that. Wearable technology, therefore, allows you to track what you do, and this is extremely important too. And therefore, today we have another exciting development, gamification, right? You can actually use games not just to diagnose, you can use games to treat. Cognitive retraining, cognitive rehabilitation. What is our limitation in practice? Our limitation is having a trained person available everywhere, and that many number of trained man hours. That is our limitation. If I had games available on cloud, I had a trained operator, the sky is the limit. Anyone who's got access to a digital environment can do it. And today, tell me, how many elders are on WhatsApp? How many elders are on Facebook? How many elders are busy commenting to each other about everything that happened? It's a growing number. So when people tell me, oh, this is not possible in India, I say, please wake up, look at your grandmother. She's probably more proficient on WhatsApp than you are. And this is something to keep in mind as well. So your ecosystem is developing. The ecosystem is community-based users, primary care users, and tertiary care users. It includes digital diagnostics. You can digitize existing tests. You can gamify new tests. And then there's digital therapeutics, which can include psychoeducation, digital exercises, cognitive games, behavioral activities, and a digital diet. All of this is possible. All of this is already happening. Please remember, if I can't read or write today, what do I do? What does your Bai at home do if she's not coming today? She sends you a voice message. Sir, not coming today. Right? So she can't type it in, but she'll send you a voice message. So adaptability is possible, and you can concierge people through these things. So I have a team that gives them a digital test and then concierges them with the digital test, tells them how to go through the test. That's all they need. They need a little bit of help, and once you give them a little bit of help, they're perfectly all right. They can do it, and it's exciting. Now what's happening in China? Thanks to ASI's new gen drug, which is the third one that's coming out among all the exciting new drugs, dementia care is getting democratized. They've created an entire online platform. This is between government, administration, caregiving centers, and insurance. The company ASI is involved. There are digital internet hospitals for dementia. People are trained, people are taking online tests, people are being tracked, and this is happening live. Now, why is ASI interested in funding this? Anyone? I'm making the drug, I want people to use it, right? So I first need to find out who will use the drug, right? I have no problem paying for an online platform if I can identify the 50,000 people who are going to pay and take this drug. It's very, very simple. It's as easy as that. It's just market economics. And we need to learn to play to that. And therefore, it's possible to have, if China can do it, India can do it. Atmanirbhar Bharat. We need to develop our own platform, right? So the future, as Dr. Matthew was telling us, Professor Matthew was telling us, are non-pharmacological treatments, not just drugs. But here is what you need to understand about non-pharmacological treatments. They have some advantages. They are person-centered. They are culturally salient. And they meet 3 of A barriers in healthcare: availability, accessibility, and acceptability. They meet those barriers when they are present. What are the disadvantages? They are time-consuming. They are expensive. They are difficult to scale and replicate because most non-pharmacological treatments involve a specialist in a room with either one or a few people who are affected by dementia. They have soft but not hard proof. Cochrane will not accept them, but I'd say, damn Cochrane. Who's interested in Cochrane? Beyond the point. And they do not meet the affordability and accountability targets always. How can you prove that a massage helped you? You can't prove that a massage helped you. How can you prove that having lavender helped you? You can't prove that lavender helped you. But the point is that there is a general wisdom that these things can be helpful, which is what Professor Matthew was presenting. Until now, we were told, oh, there's no proof that these make any impact. It's only the drug that makes impact. Now, here's proof in Nature research that non-pharmacological therapies actually influence brain activity. And this is something that you have to keep in mind. I do something for many of my patients, which is an Ayurvedic procedure called a Shiro Abhyangam, which is a head and neck massage with medicated oil done 3 times a week for 5 weeks. Universally, both my children with autism and my elders with Alzheimer's disease calmed down, sleep better. You heard what are the 3 problems? Agitated mood, sleep and digestion. All 3 will improve with just doing natural treatments. Take my guarantee for it. I've done it for over 15,000 people. But the point is, so how do they work? If you ask the Ayurvedic doctor, he will tell you that's because the medicated oil penetrates into your brain, it's influencing through all the good properties that it has. His explanation is not one that is acceptable to us. How does it work? Probably because it changes the metabolism in your brain. What happens when somebody massages your head for 60 minutes? There is an impact on the metabolism. And Madhav Tambisetti, whom Professor Matthew knows just as well as I do, is someone who has demonstrated from Johns Hopkins that a metabolism gene is involved in Alzheimer's disease. So what are you influencing? You're probably influencing metabolism. It's the explanation that is wrong. But that it has impact is definitely there. Okay? So current drugs that we have, what do? They're only marginally effective, and even the new ones like lecanemab, what do? They wipe out the amyloid. Fine. Is it giving you impairment clinically after 1 year? The answer is no. We don't have proof that there is clinical improvement when you take these drugs. There is biological improvement, which means that we don't want to use psychotropic agents for all the reasons that Professor Matthew was just outlining, and therefore non-drug client-centered interventions are useful. Now, we were preoccupied largely until now with things like Tai Chi, things like yoga, things like reminiscence therapy, things like activity scheduling, and so on. Today, we have new neurotechnologies, which is the next part of my talk, which can actually influence the human brain. And therefore, we have to redefine our goals into activities of daily living being maintained, quality of life being improved, preventing people from needing hospitalization and institutionalization, encouraging family care, caring for the caregivers. All these have to be our revised public health goals, and we need to be working towards those goals. And the evolution of biomarkers or all this modern science that's going to cost you 26 lakhs a year is not going to change any of this. All of this is still required, whether or not you have access to the new drug. And this is something that we need to acknowledge. Now, what are the forms of non-invasive brain stimulation? I can tell you this is the most exciting space that we have today. It's changing day by day. So what we have is repetitive transcranial magnetic stimulation. What we have is transcranial electrical stimulation, which includes direct current, alternate current, and random noise. What we have is transcutaneous auricular vagus nerve stimulation. And what we have is QEEG neurofeedback. These are technologies that we are actively using in Buddhi Clinic. Our counter right now says 15,356 interventions. This was the day I started from Chennai, so we must have done some more yesterday. Now the point is, what does TDCS do? It's a form of brain stimulation. It's non-invasive, non-focal, non-convulsive. It's a very low current that's passed between an anode and a cathode for 20 minutes. The patient is fully conscious when you're doing it. What does it do? The neurons become more or less likely to fire. It either stimulates or inhibits your brain neurons. It does not trigger action potentials, and it has lasting effects because it has incremental changes over time. So as you give a person, our usual protocol is 4 sittings a week for 5 weeks. As we go through this protocol, we see changes. We see changes in the behavioral score, we see changes in the cognitive score, and very often most of our patients are doing about 30 sessions of this in a cycle. Now, there is plenty of proof with controlled trials showing that TDCS is effective. Now, hyperbaric oxygen therapy and normobaric oxygen therapy is another thing that can be very, very useful for cognitive enhancement. And normobaric oxygen therapy is very easy to do. We all have these portable oxygen machines, concentrators that we bought during the pandemic and we've put away somewhere in the corner of our house. Okay? Believe me, 20 minutes of putting yourself on that every day is actually good for your cognition. Right? And if you already have one sitting around, provided it works, you're very, very likely to benefit. Okay? So NBOT is very easy to do. HBOT requires equipment. Hyperbaric oxygen therapy requires equipment. Normobaric oxygen therapy is very easy to do. We simply combine it with the TDCS. When they are taking the brain stimulation, they are also breathing in oxygen. We do the same 20 sitting practice in our clinics. Okay? And there is a fair amount of research that shows these approaches have some benefit for human cognition. Now, RTMS, repetitive transcranial magnetic stimulation, has been around a long time. And for many years, it was thought of as a placebo. You know what the problem was? The problem was the technology. The magnetic impulse that it was generating was not strong enough to penetrate through the skull. That was the problem. Today we use a 4 Tesla magnet. Your best MRI in India is a 3 Tesla magnet. We use a 4 Tesla magnet to stimulate, and we are able to penetrate. And today we have something else called deep TMS that's come into India. Deep TMS is currently approved only for depression, but that actually penetrates about 4 centimeters into your brain. Okay, so there is a fair amount of technological development that's helping this. It's a painless, non-invasive technique. It does not require any anesthesia or sedation, and many, many applications have been developed over the years. Most recently, this paper was published where stimulating the precuneus helps cognition in Alzheimer's disease. And therefore, RTMS as a solution for dementia is today very much on. Okay. Patients with higher education and patients with mild to moderate Alzheimer's disease were more likely to benefit from RTMS than patients with lower education or with severe dementia, respectively. So this is another technology which is available. It's expensive technology. The cheapest machines are about 17 to 20 lakhs, but it is extremely versatile and can be used for a range of conditions. Now, vagus nerve stimulation was first propagated for seizure control with implanted vagus nerve stimulators. And I remember as a clinical fellow in the UK, this trial was going on then. Subsequently, it became a treatment for depression. Over time, vagus nerve stimulation, the invasive version, actually has gone out of vogue, and we don't do many VNS surgeries anymore in India. Although it's a relatively simple surgery where you put a stimulator under the chest wall and connect it to the vagus nerve in the neck. But what happened in 2017, 2018 was that Sotrix, an American company, brought out a transcutaneous auricular vagus nerve stimulator. And this is, you are stimulating the pacing, the auricular branch of the vagus nerve. Originally, the conditions for which this was proposed were epilepsy and migraine. But one thing that we have found post-pandemic with the long COVID symptoms, it actually is very, very useful when patients have clinical autonomic dysfunction. And the vast majority of people with long COVID symptoms actually have clinical autonomic dysfunction. And if you evaluate the large number of people who come to clinics saying that they have what we end up calling psychosomatic symptoms, they will have clinical autonomic dysfunction. So it's a very, very useful and interesting technique. And dead giveaways for these patients are what is called POTS, postural orthostatic tachycardia syndrome. When you take the pulse and the BP lying and standing, the pulse races up by more than 30 minutes. And that's called postural orthostatic tachycardia syndrome. And the BP falls systolic by at least 20, diastolic by at least 10. Then you are POTS positive. That's a giveaway. It's useful also in our patients with dementia who have gut health issues. It's useful also in our patients with dementia, our patients with autism who have gut health issues. And to me, there are remarkable commonalities between these conditions, one that's developmental and one that is neurodegenerative. So vagus nerve today is coming in two ways. One is as a cognitive enhancer in Alzheimer's disease, emerging evidence. Another, very, very interestingly, in the acute treatment of strokes. Vagus nerve stimulation is starting to be used in the US in acute stroke units when the person has just presented with a stroke. It helps to reduce disability. Now, neurofeedback, again, has been around a long time, but the technology is getting better and better. And basically, it helps you to monitor and self-regulate your brain activity and has shown great promise in addressing cognitive impairment and dementia. We use this extensively, less so in our adults and elders, much more so in our children and working professionals. The reason is because elders take some time to adapt to technology. They do much better with human interactions. They prefer to have the therapist doing cognitive retraining, reminiscence therapy with them rather than actually use technology. But we have some elders who prefer technology. So this is something else that we are using extensively. Now this is how we work in Buddhi Clinic. We have Ayurveda, we have yoga therapy, we have naturopathy, we have acupressure, acupuncture, reflexology. We have a physical and occupational therapy. We prescribe medication. We have a whole house of neurotechnology and neuromodulation. And we have a whole mental health team that provides psychological therapy. We are all working together under one roof. If somebody walks in, whoever they are, we do a team assessment. And we use outcome measures to score their symptoms. We then give them a care plan. We execute that care plan as we said that we would, and we track their outcomes, middle of therapy, end of therapy, each cycle. So if you take, for example, an Addenbrook's cognitive examination score, it's available at baseline, it's available at middle of therapy, it's available at end of therapy, and we're able to track progress. And for this, we have an electronic medical record. We've also invested heavily in an ERP system, which is built on the Zoho One platform. And what that helps us do is it's got something called customer relationship management. So we know who's doing what, where they are. We have something called people, which is our people who are working with the customers and who each person is working with. We have something called bookings, which is a whole scheduling platform. And we have something called books, which is the accounting platform. And all these are interlinked. So the dashboard, if I say, for example, that I'm the patient, Dr. Krishnamurthy is the patient, it will show the entire journey, where I am in my journey with regard to each one of these things. And it makes life remarkably simple. We've also got a whole range of checklists that we built in so that at every stage, we actually have checklists that people have to complete. And this is the way in which we've learned to work this program. Across 4 units, we are 60 people today, and we work with approximately 350 to 400 clients at any point in time. And so it's a very active program that we run. So what can you integrate when it comes to asking yourself that question? It's possible to integrate a whole range of non-pharmacological healing systems, including culturally acceptable and available local traditions. This is very, very important to remember. And why are culturally acceptable traditions important? Patients, people in general, accept them much better. Many of my older patients, can I stimulate your brain? No, doc, all that I don't want. Will you do Ayurveda? Super, doc, damn good. Thanks so much. Now the point is, it's a belief system. So rather than say, no, you must do this, I'm offering them a healthcare marketplace. I call Buddhi Clinic the McDonald's of healthcare. You can come in, you can say, I want to have only fries. You can say, I want to have a meal. Or you can say, curate a meal for me. But the bottom line is that we have many things on offer. At this point in time, 17 different treatments on offer that people can choose from, but it is guided choice, and we help them make those choices. This is extremely important according to me. It's very important for us to build seamless models of care. There is no point in living in silos and creating models of care that are exclusionary and saying that only this works and nothing else works. That doesn't help at all. Everything has a role to play. We need to know the best ways of synthesizing the best things that we have available. We can bring together. My mission is to prove that you can bring together the best of modern science and the wisdom of ancient healthcare traditions. You can blend them together. Who said you can't? It is eminently possible. And I take pride in the fact that people can go to one floor in my clinic, have their brain stimulated, go to another floor, do a yoga session, go to a third floor, have a chat with a psychologist, and leave, all on the same day. And I think that that's how we need to think about chronic disease management. It's not either or. It is the ones that I need and how I engage with those things. And most importantly, we need to be able to track your outcome in healthcare. That's extremely important. So the qualities of integrative health practice are 360-degree assessment and diagnosis. We need to know our patients well. Multidisciplinary approaches to therapy. We need to be able to make holistic impact. We need to be able to track and monitor outcomes. And if you look at technology, technology provides you a huge opportunity to do all this on the go. And also remotely. So for example, what we are building now, we have a hard copy workbook where people write down their progress in therapy. It's already organized so that they report their progress in therapy. Now, what we are doing is digitizing it and converting it into an app. And our intent is to give the parent or the child, the primary caregiver of the patient, access to that app. So I know that my father went in today and had his session of Ayurveda. I know that my father had a meeting with the doctor today and these were his scores. I know that his blood pressure is being tracked. And I, as a child sitting somewhere else, which is the reality of modern life, is feeling very, very comfortable. So being able to adapt technology is very, very important. Now here's what we did for one of our patients. It's with Alzheimer's disease. It's an intensive therapy program that includes physiotherapy. He had gait difficulties due to palmar fasciitis, which we took care of. Psychology, mainly cognitive training, retraining, and reminiscence. In him, how we personalized it, he loves old Hindi movies and old Hindi music. So we use that. He collects watches and calligraphs. So we use that. And we use that to work with him in cognitive retraining. We gave him sessions of TDCS and normobaric oxygen, 30 sessions actually, each year for 2 years. And he has been regularly on our holistic care program. We've used things like acupressure, reflexology, chanting and prayer, and he's a very spiritual and religious person. So we use chanting and prayer and yogasanas. We managed to improve his score, ACE score from 62 to 73, and we maintained it for 24 months. Until he got influenza and got really badly hit. And unfortunately for him, that was the step down. He's not recovered from there. So 73% of our patients have shown an improvement in their MMSE scores at 8 weeks interval. This is sample data from our own team. Very interestingly, our integrative medicine alone group improved its ACE scores, and our integrative medicine plus TDCS group also improved its ACE scores. They both improved significantly. The interesting thing is the baseline ACE score was lower in our integrative medicine group than it was in the integrative medicine plus TDCS group. So we've got probably a selection bias when we are prescribing TDCS. That's quite possible. We are looking at people with early cognitive impairment or not so far gone when we are prescribing TDCS. And very interestingly, if you see many of the behaviors in the neuropsychiatric inventory improved significantly at the end of each of our programs. And this is collective data across patients, again at 8 weeks interval. So combining modern tech with ancient treatments is helpful. A multidisciplinary team is really useful. Being process-driven and rigorous is extremely important. We take therapy home. Many of our patients cannot come to clinic, so about 30% of our patients are actually treated at home, at their doorstep. And we do regular assessments to track their progress. And I believe that this is extremely important if you want to develop a program, including one that uses technology. So we encourage harmony in medical care. Traditional systems and modern science must come together to help people enhance their human potential. And I think that's the whole purpose of why all of us are here. So please embrace technology, is what I will say. And please don't forget your very, very rich heritage of Ayurveda and yoga. It's gold, it's magic, it's got the power to change the world. Thank you so much.
So I think while we are still left to check whether the 60 minutes of a head massage will increase our brain metabolism, but I think the last 25 minutes, our neuronal firing has increased a lot to get to thinking what Sir has just spoken to. Thank you, Sir. I would now like to invite Dr. Joshi Sir, who is the Secretary of ARDSI Mysore Chapter and Principal of Sarada Vilas College of Pharmacy. Again, it is a very challenging topic for him being into the field of pharmacology and to talk about non-pharmacological management of dementia.
And rightly said by the anchor that it's very challenging to talk about non-pharmacological treatment when I'm myself a pharmacologist. But we know the issue behind. We have been talking about medicines, we have been talking about therapy. At the end of the day, we don't have any good medicine which can authentically say that there can be some kind of a possible cure. Of course, we don't have, we know very well, there is no cure for it. So we have heard a lot from past 2 days, what is dementia, what are the symptoms, and what are the challenges ahead. And more than anything, it is very vital to identify whether it is really Alzheimer's or not. Because many a times people, especially normal people, get confused what is Alzheimer's and dementia. That is very important, number one. And are there any reversible symptoms? Right? And we know very well there are no reversible symptoms. Very few are there, and it's to be understood. Do you have any specific treatment? These are the questions in the mind of the people when we talk about the management of dementia. And educate and support carer and family. This is one critical point. And treat the symptoms as they arise is very crucial. And treat incurrent problems. So this is the overall management of dementia. And I had few slides, but after listening to some of the talks, I have just deleted them. It will become a repetition. And now what we have to understand, being a pharmacy person, acquainted with the drugs, both from allopathy, Ayurveda, and all sorts of systems of medicine, with the identical view that we have to do something for dementia. We have to understand something, that there are some drugs which can cause cognitive impairment. When we talk about medications, which can definitely helpful for the cognitive symptoms, reversing the cognitive symptoms if possible. There are few drugs, I think it's battery is getting down. Battery, yeah. So first of all, we have to very clearly tell the people there are some drugs which can really induce amnesia. And a second is which can treat memory loss like Alzheimer's or other types of dementia, which can treat the symptom and which can prevent the symptom. And we know very well all symptoms cannot be prevented, but it's maybe possible in vascular dementia. Maybe our friends who are practicing can throw some light on that. So before they reconnect it, I feel my talk is mainly for the patient caregivers. Okay, before they connect, we will talk a little about the drugs which are already being used. Dr. Matthew and Dr. Krishnamurthy and all people have been emphasizing that we have few drugs in the market. Mainly acetylcholinesterase inhibitors. And we have medical doctors, we have nurses and all people around here. And we know very well there are few neurotransmitters in the brain. And brain is a very complex organ. Leave not only Alzheimer's, but there are so many other complications also associated with Alzheimer's. Especially acetylcholine, which is the major neurotransmitter in the brain, which maintains memory intact. If it is an imbalance, what will happen? There will be some symptoms which can mimic the mild cognitive impairment, and as well as in future it will lead to Alzheimer's also. And for that, there are some drugs called acetylcholinesterase inhibitors. For information to especially other people, there are some drugs called as acetylcholinesterase inhibitors which can inhibit the acetylcholinesterase enzyme. If the enzyme is inhibited, what will happen? The concentration of choline will be okay in the brain. Fine. Then what is the problem? The problem is side effects, right? We'll be understanding one by one, in the next slide. And these are few of the drugs which can cause cognitive impairment. One are patients or any type of dementia patients are having some kind of, there are issues with their behavior and all. They have to be, permitted to sleep, right? We have to give some sedative. For example, diazepam, which are called as benzodiazepine agonists, right? But the same diazepam in the longer run leads to dementia. In preclinical trials, in which we are expertised, right? We have a model called as diazepam-induced amnesia. We give diazepam to the animals to induce amnesia in the animal so that we can check the drugs. Antidepressants, analgesics in the longer run, they leads to dementia, and anti-epileptics very well, right? Because they will be decreasing the concentration of acetylcholine in the brain, whereas we need choline concentration in the brain, so it is it will lead to cognitive impairment. Like digoxin, cimetidine, and lithium, they also lead to dementia in future. And how do we treat memory? We have been talking about it since 2 days. Cholinergic drugs like donepezil, ribostigmine, galantamine, right? And there are a few drugs in the flow also. But the major side effects is the uncontrolled micturition and as well as passing the stool. I think there are a few patient caregivers here. When ACH drugs are administered, the major problem they face is they will start passing the stools and as well as urine in the bed. It is a difficult condition. Number one, the person is not able to remember, and the second one is managing the day-to-day activities. Estrogen therapy, right? It's always it's well known. Vitamin E, selegiline. These are some of the drugs which are really used for treating the symptoms. Now, what are the other things? So, for example, we already talked about pharmacological treatments, and we know very well we don't have a very authentic drug which can completely be very useful for all sorts of dementia, right? There are few drugs which can be useful for managing Alzheimer, but at the same time there are a lot of challenges. Now that's why we have the doctor sitting here. Number one is treating the family, right? So treating the patient, yeah, there are challenges. Now what is to be done is treating the family. How? With various other things. Next one is non-pharmacological, antipsychotics, benzodiazepine, and antidepressants whenever it is required. And yeah, so what is expected from any types of treatment? Number one is which can cure the disease, and we know the answer, right? There is no cure for it. And prevent the disease or delay the onset of action. That's what Dr. Krishnamurthy tried to say. With accumulated therapy, it will be quite possible, but not immediately, but in near future. And slow the progression of the disease, and treat the symptoms like memory, but it cannot be done always with the drugs which are available now. And these are the side effects which are well known, like nausea, vomiting, muscle cramps, and insomnia, right? See, when drugs like donepezil is given, maybe people would have observed in the practice, right? They always have a problem in sleeping. And when they have a problem in sleeping, then you have to give benzodiazepines, right? So this leads to, the condition will be aggravated in future. So the people has to be, very judicious in prescribing some drugs. And there are few the drugs which are commonly prescribed. Cimetidine, ranitidine, right? Prednisolone, and depending upon, the patient to patient. But the point is, some of the drugs themselves cause amnesia in longer duration. Now, comprehensive approach, and rightly said by Dr. Krishnamurthy that we have to go back to the basics once again, that is Ayurveda. But there is a lot of confusions in the mind. But if you look at that, there is something called as Dinacharya and Ritucharya. I am not going to the entire the points about the Ayurveda, but Dinacharya, right? Yesterday I was listening to Jaspreet Kaur, right? And she was really expressing the challenges what she had with her parent over dementia, was a dementia patient. So actually down the line we are going with the newer things, and we are forgetting our Dinacharya and Rutucharya. As far as Rutucharya are concerned, there are few drugs, or I can say there are few plants, I can say. There are few vegetables or medicinal plants which were used since long time, which can really help us, right? I'll be coming to that point later. But this is, the decade-wise aging and prevention as per Ayurvedic texts. I'll bring your notice to the point number 9, right? A person is expected to have some problem with cognition, or loss of cognition takes place in between 81 to 90 as per Ayurveda, and the drugs prescribed by them is Brahmi and Mandukaparni, right? And in many the parts of the country, whether it is South India or North India, and especially in my part, there are some leaves called as Vandelaga, means a single leaf. That is nothing but the Brahmi, which is very widely used throughout the country, which we are not able to do that. But when we listen to the doctors, it's very alarming that people with 60, 65, they are developing the symptoms of dementia. Now, what are the non-pharmacological treatments, right? Normally in any treatment, there are 4 things, which is not, which is mentioned by the doctors a very long time back, 5,000 years ago. Number 1 is ahara. In one of the slide, Dr. Krishnamurthy was saying, that we have to start very early, not at the very later stage, right? The food is very, very important, and the ahara is very important. Not after getting dementia, not after getting diabetes, but in the beginning itself. So when a disease cannot be managed by ahara, when we talk about disease, let us not limit ourselves only for dementia. It can be any other thing, right? Maybe diabetes, hypertension and all, because all of them are associated. And if it is not possible to manage with ahara, next one is vihara, which we call as picnic, right? In our customs or in our systems, right? Once in a year, a person has to go out of his house. Not only once, but more than that, it is expected. Maybe to a temple, or maybe to any other religious place, where they will have some calmness. And when we talk about calmness, it is neurotransmitters in the brain. There is optimum secretion of 5-HT, 5-hydroxytryptamine, acetylcholine, and as well as the other neurotransmitters, which will really help in managing the issue. When it is not possible to control with ahara and vihara, the next one is vichara. Vichara is nothing but thinking, right? Optimism plays a very, very important role, not only in the management and as well as the treatment of these diseases. And when you are not able to manage with ahara, vihara and vichara, next is aushada, right? This was coined by Sushruta a very long time back. But unfortunately, what we are doing nowadays is, we are directly going towards, the aushadha. And whenever we take our aushadha, like, the painkillers and all, right, on long-term therapy, it leads to many a complication, including dementia. And as part of the non-pharmacological treatment, I am not saying anything new. We always feel that, we know it, but we don't practice it. That is a challenge, right? So the expected thing is we should try to practice it in our daily life. Okay, so there are a lot of anti-aging measures, right, like autophagy, right? That is, doing, what I can say, langhanam, nothing but, doing ekadashi. I think many people are aware, right? We should starve for some time, which will really help, the body. And yeah. And when we speak about Ayurveda and when we speak about, the non-pharmacological treatment, it was coined very long time back. I think all of you would have heard about Chanakya, right? So almost, for a quite, a long time, before a long time, he coined one small shloka. Acharah kulamakyati deshamakyati bhashanam sambrama snehamakyati vapurakyati bhojanam. I believe it is very relevant because, acharah kulamakyati, right? Normally, our behavior reflects or, gives, an idea, about our background. Especially many of you, when you were students, right? Maybe whenever you did some mischief, the teacher will ask you, is it the same thing your parents have taught you? Yahi sikhaya tha kya aapko? Isn't it? And the same thing will be asked, as far as teachers are concerned. Is it the same thing your teachers have taught you? So the kula is nothing concerned to any caste or anything. It is your background. So our behavior should mimic, what exactly we are. Deshamakhyati bhashanam. It is a part of the shloka I'm just explaining because all people may not understand Sanskrit. Deshamakhyati bhashanam. Any person he has to be patriotic. Whenever we speak to some people, they should always mention their country and they should be patriotic. Sambrama sneha makyati. When friends join together, they should, celebrate to the maximum. But nowadays, what is happening? Other speakers were talking like WhatsApp, Facebook, and all. We are not putting our brain into, exact work, right? We are not using our brain very properly. And there are no games, there are no traditional games. We have become completely modern nowadays. Only once in a while we see it on TV, like some traditional games are being played. Right? We should go back to the basics because themselves it's a non-pharmacological treatment. And very important is Vapura Khyati Bhojanam. Our body reflects the type of food we are eating. When we talk about the food, it should be good with the Ritucharya. What is Ritucharya? There are some Rutus in our traditional calendar, right? Like autumn season, you take this food, you try to ignore another food. There must be some kind of scientific basis which we are not able to prove it, but when it comes to taking proper food, this shloka plays a very, very important role, right? This is what I mentioned earlier. Okay, hitakara and the rasayanas, right? When doing all tries, right, by all doctors or scientists, everyone, even now after identifying Alzheimer's disease by a doctor called as Alzheimer, even after 100 years, we are now not able to find a proper solution to that. We have some symptomatic treatments, right? But they are, I don't think they have completely failed, but there are, having a lot of highly challenges. And now what is the prevention? It has already been told by other people, exercise the brain. But when we talk about exercise the brain means, we have been doing, I think, but otherwise, number one, how do we do that, right? There are some games, need not be on YouTube. It can be, even in your newspaper, like Sudoku, right? In Hindi mein padaband bolte hai, isn't it? And doing some games, we should practice little early. Exercise the body, we are doing it, right? And keeping socially active is very, very important because as a pharmacologist, what I feel, whatever we are, that is because of the brain, right? Maybe our body language, maybe the way we talk to other people, maybe our behavior, everything is the brain. Okay, see all these 4 neurotransmitters have to be intact in the brain. I told you about acetylcholine. There is another one is, the dopamine. Dopamine is a rewarding chemical. Whenever you are happy, the concentration is more of dopamine in the brain. And what will happen if dopa levels are less? It leads to Parkinson. Then what we have to do is we have to again replenish it by giving some drugs like carbidopa, levodopa, right? So why to do that? Let us make our brain active. That is quite possible by using these techniques. And when we talk about keeping socially active, we have started a small process in Mysore. I am from Mysore. We have started something called as hugging your parents. Hug your parents. In Kannada we call it as parents jatega, hugging your parents. Down the lane after a systematic survey, we understood that nowadays many people are not embracing their parents. The touch therapy, the doctor was saying. There is some social taboo in between. And it has been observed that, the girl childs, they can easily, hug their mother, but not father, vice versa. And especially the sons, SON, they do not hug their father, right? And when they do embracing, what will happen? Some neurotransmitters will be secreted in the brain, right? And it will definitely help, the person, both the people. And we do this, we have come to a condition that we have to arrange a program, right? So every year in Mysore, we arrange this program, and believe me, both are in tears. Not very younger generation, or people maybe, the people who are sitting at least on the stage. Okay, so this is very much required. And when we talk about socially active, I know that we should encourage the children to meet their grandparents. Nowadays there are nuclear families, and it's philosophy I'm talking, but otherwise it is very, very important. Quit smoking, right? And alcohol in moderation, right? And people have already spoken about it. And wear a helmet, very well, because many of the amnesia, dementia are because of, some head injuries. That has to be understood. A healthy diet, typical South Indian diet if you are a South Indian, right? And if you are, from North India, take the regular food. It is always there. And omega fatty acids. So these are few of, the treatments without drugs when pharmacology has failed, right? Yeah. Now, this you know very well because all people are well acquainted with, the issues concerned with the brain. What is that? Exercise the brain. It is understood that education is neuroprotective. When we talk about education, it is not required that a person should do an M.Pharm or PhD or MBBS or MD, right? What is education? It is regular, spontaneous education, right? It is understood that a person should read at least 4 pages every day. And they should change the book every once in 2 weeks in a new novel, right? We have to keep our brain active, then only it could be possible. Brain trainers, there are trainers nowadays available, and puzzles, games, sensory stimulation, right? And it is definitely useful. And very important thing is use it or lose it. We have to use the brain, otherwise we are going to lose the brain. Socialization I already mentioned, right? And it will be definitely helpful in managing some symptoms. Yeah, as far as stress is concerned, antidepressants only when it is required. Aromatherapy, the other doctors have already mentioned. And aromatherapy is already part of our, tradition already. We have to use it regularly whenever it is required. And meditation is quite important. Meditation need not, we should always practice yoga. Practicing yoga is definitely helpful, but any sort of, keeping silent is meditation. And music therapy, the doctor was saying, and we are very happy. One information to you, we do, something called as Music for Memory every year. On 13th of September, we conducted Music for Memory in Mysore. We keep on doing it every year. And some people will always feel that what is new in this, right? See, there are some ragas, right? I feel everything is scientific. Only thing is we have to find some scientific evidence for it. But if you look at that, there are some ragas, especially in Karnataka music. There is a raga called as Bhairavi, right? Similarly, there are some ragas on Hindustani also. It has been clinically proved, right? And it has been, we also heard that many surgeons play music during doing surgeries also. But we normally call singers who are from the technical background. They explain what kind of raga can be used for what kind of it's not exactly for Alzheimer, but for the associated complication. So they can stimulate some discrete regions of the brain. That is what the understanding is. So music therapy plays a very, very important role. And when we talk about music therapy, it is not mandatory that everyone should listen to Karnataka music, right? Even old Hindustani music is also definitely useful. The only thing is we have to keep our brain calm and very resourceful. And art therapy, we should, when I was listening to Jasprit Bumrah, the art therapy is also very important. We should encourage, everyone should learn something, some art, even though we need not become experts. When we talk about music therapy, it is not necessary that I should come and, do the kacheri here, right? I will learn some Hindustani music, because my name is Joshi, right? And Bhimsen Joshi, I should not think I am Bhimsen Joshi, isn't it? So the only thing is I should be in a position to, put myself out, and it will be really useful. And dancing has been proved to be very much useful, right? Especially calming the brain. So these are, some non-pharmacological treatments. And I didn't say it's a treatment, it's a therapy, we can say. I had some more slides, but they were repetitive. And finally, it's social engagement, visiting the friends and relatives, joining the clubs. We should join the clubs, right? It may be Rotary, it may be Lions, or whatever it may be. We have to be among society, among people. Senior centers, we have to visit centers, right? It may be a dementia care center, it can be any other senior centers, because one day all people are going to be aged, isn't it? So that we have to remember. And volunteering is also very much required, because it is really helpful, and it will be easy for the patients, to console themselves. So this is what I wanted to share with you, and thanks to the organizers for the opportunity. And I think I have not taken more time. I have kept, extra time for the other speaker. Thank you so much.
So we'll first pass it in the audience and then take the chairperson closing remark.
My question is for Dr. Krishnamurthy sir. He talked about that non-invasive therapies like TDCS, RTMS, neurofeedback, biofeedback. My question is, what is the role of electroconvulsive therapy in case of BPSD?
Please introduce yourself before asking the question.
Myself, Dr. Jitendra Dongre. I am Assistant Director Health Services at Chhatrapati Sambhaji Nagar, and I am psychiatrist too.
Thank you. A very good question. I don't think ECT in dementia has kind of featured either in a clinical trial or in the Royal College report. So I don't think it's been attempted for BPSD in particular, as far as I recall, because I also wrote the Royal College of Psychiatrists report on ECT, so second edition about 4 years ago. Until then, there was nothing published. ECT has been used in Parkinson's disease, but that is to improve the motor symptoms, no comment on the behavioral symptoms. But I'm not aware of ECT use in PPSD of dementia. Having said that, I think with the new technologies, the general use of ECT actually is coming down, because RTMS in some ways is the new ECT. Especially when you use effective, and because it doesn't require sedation, because it's, the patient just walks in, does it and walks out. Except that it's repeated visits, it has become very, very effective when the technology is good. So there's also decreased use of ECT. I find even in units of both RTMS and ECT, the preference for RTMS is growing rather than ECT.
I think in extremely belligerent, agitated people where nothing has helped, they have used ECT. I know in my unit at NIMHANS. I think there are a couple of case reports probably, but there's really no trials. But somewhat modified bifrontal ECTs have been used. I know there are some reports, but it's not something that is recommended as first line, second line, or third line. It's really something that's to be done only if somebody is really desperate. If you, rather than tying down a patient, ECT has known to reduce agitation and belligerence.
Hello. Yeah. Recently, a paper was published in the medical journal that IIT Delhi aims experiment with MRI of patient during Yog Nidra. And it produced unique neuroimaging mechanism in the areas of brain which controlled emotions, such as anxiety, aggression, etc. This therapy, could you be used for dementia as well?
Are you talking about it as a research study that looked at what impact yoga has? Oh, yes.
I'm talking about Yog Nidra.
Yes. So, as you know, Yog Nidra is one of the many specific practices. And of course, when we do clinical trials, we prefer to choose a particular practice and then study its impact. There's quite a bit of published evidence, including from NIMHANS, to show that yoga practices in general have an impact on your brain. And in functional MRI studies, there is a change that is observed as you go through yoga practice. There's quite a bit of research today available. So yes, there is no doubt that specific practices like Yoga Nidra, which is oriented to improving sleep, those specific practices can be used, and there is biological evidence that they work, yes. Or rather, there's biological evidence that they bring about change. Yeah.
And also another thing on music, for Dr. Joshi, one of our patient was a professor in college, a very learned person, and he developed Alzheimer's. His wife was a singer, a classical singer, and she says whenever she used to practice music every morning and evening, that was the calmest time he had. So this is another thing, especially live music. I'm talking about not recorded music. So she told me, this is what I do every day, and he's very calm during that day. So that probably is one of the evidence. Thank you.
No, you have already given the answer in your question, but at the same time, some research is going on, especially Vishweshwaraya Technological University in Mysore, and there are some music schools. There is a instrument called a Star Stem, some company, right? It will give you, the signals, what's happening in the brain into the system, and how it is useful. For example, it can be sleep, right? It can be what are the regions of the brain get stimulated, It is not only a classical or any different type of some certain music, even sitting quietly, chanting some mantras. And there are some projects going on how Vishnu Sahasranama can be useful, for the acquisition and retention, because it is quite common, especially elderly people. They must be forgetting something, but the episodic memory will be intact, especially when they're chanting something and all. So it is already having a a very, what you can say, it is clinically significant, and there are some proofs are also available that music can definitely calm the mind. And when I talk like a pharmaceutical researcher, the neurotransmitter levels, right, especially dopa level, they are very good. One example, see, normally whenever you are happy, what do you do normally? Either we eat very good food or we start singing, any kind of singing, isn't it? Or maybe whistling comes out. So all of them are interrelated, and music therapy is going to play a very, very important role. It has already been proved, but there are a lot of research are yet to happen. But we are into that, it is already doing. And there is one organization from which Mr. Ganesh has come, Vatsalya. It's a group of senior citizens, where every Saturday they meet. Among there are some people who are not completely, Alzheimer patients, but they are going towards that. So sitting together, chanting some mantras or maybe some music, it is definitely going to be useful. And we keep on hearing that when they go back, next 3 days, they are very fine. And another one, any mental state examination. So whenever there is a gathering like that, right, we regularly conduct many mental status examination, others also, and it is observed that it is really useful. So I think music therapy is going to play a very, very important role in the absence of suitable drugs. Thank you.
Thank you.
Hi everybody, I am Alia. I'm a neuroscientist. I'm doing research in clinical neuroscience and also pursuing my PhD. So I have a couple of questions for Dr. Krishnamurthy. Your talk was very curative and informative. Thank you so much. My question to you is, can AI ever truly understand the subjective experience of dementia? And how might that understanding impact treatment strategies? This is one. And the second would be, can AI eventually replace human care givers for dementia patients? And what are the considerations that arise from this potential shift? Thank you.
Thank you, great questions. I think the first thing is that I'm not a technologist, so I don't understand AI more than any other ordinary lay person. But if you saw that slide from China, one of the things that they are doing is actively tracking the experience of dementia with people using technology. Right? And the moment you start active tracking, I think pattern recognition will happen. And I think AI is going to be extremely useful in identifying pattern recognition. To give you an example, we've been talking so much over the past couple of days about how things change. A person can seem perfectly all right one moment, and then suddenly they are exhibiting behavior that is very difficult to manage. Now, that pattern recognition, what seems to happen before the behavior comes out is, for example, maybe sleep is getting disturbed. For example, maybe the day rhythms are getting disturbed. For example, maybe the eating pattern. Now, when things are tracked constantly, then I think we are going to get this kind of information from AI. So I think that AI will be very useful as pointing us in the direction as to where we should be looking for a problem. And this is especially true because more and more people with early dementia, considering the way we live in this world, are living on their own. Or they are an elderly couple living together, and the children are somewhere else and so on. So this is one part. The second, can AI replace caregiving? I think that's what the robots they are trying to do with. So yes, you might have a robo that actually gives you extremely appropriate responses, much better responses than a paid caregiver, much better responses perhaps than even a professional, because it has that ability to, no matter how you are, to give you the right response based on what you said. Which we as humans may not always succeed. Like if a patient is getting aggressive with us, we will get defensive, or it's a natural human instinct. So it eliminates that. But then does that qualify as caregiving? Is it possible to have a relationship? I think that's going to be some kind of a sort of a new age sci-fi movie in the future as to what will happen when people start having relationships. But I think there is a possibility of these things being helpful. I don't think anything ever replaces the human completely. At least at this point, the way I see the world, I don't believe anything will replace it completely.
Thank you so much, sir. I know we
I
have
would like
a lot
to add one point to your second part as far as caregiving is concerned. And yeah, rightly said by Dr. Krishnamurthy. We recently got a idea patented, design patented. It is AI, along with AI, basis of the medication dispenser, AI-enabled dispenser. Because one of the small, it can be a small, but it's a very important problem the people face. A patient caregiver is there, but in their absence, it is very difficult for any people, need not be only Alzheimer's, even elderly people to remember the medicines and take it. Either they take it twice or they skip it. Now we have medication dispensers which are traditional, the boxes, the days are written, there are slots, people take it. But there are some nuclear families, right? And when the people are alone, right? They will not remember when they have to fill the stock, isn't it? So now we have developed a device through the AI. I was just trying to tell how AI is going to be useful. So this device will inform the patient caregiver, maybe son or maybe anyone, before 1 week, that medicines are getting exhausted, number one. And number two, if the medicine is not taken, right, within 1 minute, it will start, giving an alarm and voice also. And we are thinking to now, to have one small monitor also. We are trying to think about dementia patient also, if they can read it at least, right? They can read, it's a medication time and all. So it can be definitely useful, but as rightly said by Dr. Krishnamurthy, AI and healthcare has to go a very long way.
Hello.
This is the last question.
My name is Dr. Prasanna Futane, working as psychiatrist in Telemanas Regional Mental Hospital, Yervada, Pune. I have thank you for excellent presentation from all the speakers. It was very insightful. I have two questions. First is for Dr. Krishnamurthy, sir. Sir, you have mentioned that gamification, indulging in games and puzzles and crosswords, they are really helpful in the cognitive improvement. So I want to know what is there in the time duration mentioned, how much time is your experience with this gamification of treating many patients, and are there any case reports which mentions about any time duration that really helps for cognitive improvement? And second question for Dr. Joshi sir, that you mentioned in the prevention slide that alcohol use in moderation helps in the in what context we have to take that point, and alcohol in moderation helps in preventing the dementia. That's two questions. Thank you.
Okay, thank you, doctor. Now he want me to go first. Because all of our most of the people are concerned with the brain. You have been studying about it, and from my side, let me tell you, from a pharmacological side. So when we start working on new drugs, right? We have some models, right? Preclinical trials, right? There is a model called as alcohol-induced amnesia. Just like I said, diazepam-induced amnesia. We have a model called as alcohol-induced amnesia. Ethanol, after giving it to the group of mice, they develop amnesia, right? So because it is understood when we talk about the etiology and other things also, it leads to a neurodegeneration after a long time. So it is very well known that ethanol is a CNS depressant, and on long-term usage, it is going to have some problems on the neurons, evident. And when we talk about your domain, right? See, for example, very well, it's a CNS depressant, and what will happen to the brain, especially in the depression, right? Depression is also an associated complication of Alzheimer's. It is not only memory, it's a big umbrella, there are so many other things. So with this context, I just mentioned alcohol in moderation for people who are compulsorily alcoholics, who cannot survive without alcohol. It is not a call for other people who are not alcoholics, they should start now, that I can take some alcohol. So that was the intention. But definitely, yes, there is a model called ethanol-induced amnesia. You can please refer our papers also, and a lot of research is going on. So definitely, yes, ethanol definitely will induce amnesia. but maybe in a lower quantity, because I think maybe some people who can challenge me later outside, right? There are some people who are 70 years, 90 years, regularly taking alcohol, but they are wonderful. Now the brain is a complex organ. You never know, how it takes care of people, differently. Yes, there is a model, ethanol-induced amnesia.
On gamification, I don't think we are using gamification actively at this point in time. We are using digital diagnostics. We do use some available online tools, including one actually that comes from a Pune company, a Pune startup, which is simple games that you can play online which help improve various specific cognitive tasks. But this is all very early phase. What Dr. Kandaya is trying to do is build an end-to-end cognitive solution in Singapore. So this is a partnership between National University of Singapore and various agencies. Their effort is to build an end-to-end solution which will include gamification in quite a big way. So I think that's exciting space. I don't think we are there yet.
Thank you so much, sir. I know we have a lot of questions, but we can catch our speakers over the short tea break after this segment. I request the chair and the co-chair for a quick closing comment on this segment, please.
So I would like to thank all the speakers here for the really informative session. Dr. Matthew with BPST, Dr. Krishnamurthy with technology, and Dr. Hanumantha Joshi with the non-pharmacological interventions. Thank you once again for everything. So we would now like to bring the session to a close.
I request the chairperson and the co-chair to please felicitate our speakers. Dr. Matthew, sir. We have a special guest amidst us today, so I request all of you to wait back before going for the tea break. Dr. Krishnamurthy, sir. Dr. Joshi, sir. I would like to request Dr. Ronnie, sir, to please give a token of appreciation to our chairperson and the co-chair for this session. We'll just take a picture together. Thank you, sir, for chairing the session. And it gives me extreme happiness to announce that we have amidst us today Dr. Swapnil Lale, sir, Director of Health Services and CEO, State Mental Health Authority. Sir missed it to the inaugural yesterday, but it is extremely kind of him to come over. It's really encouraging to have you amidst us, sir. I invite you on stage. I request you to kindly address the gathering.
Thank you very much. I am very much thankful to Alzheimer's and related disorders conference for inviting me and giving me this honor. I am very much thankful to Pune Psychiatrist Association. Thanks are especially due for Chaitanya Mental Health Institute for organizing such a beautiful conference and giving care to mentally ill patients for over 25 years. Amongst us, there are medical superintendents of regional mental hospitals. Regional mental hospitals in Maharashtra they are providing services for mentally ill patients for more than a century. They are centuries old hospitals, and they have catered to needs of mentally ill patients for more than for millions of patients in this last century. Then there are personnel from National Mental Health Program. This is an ambitious initiative from central government, which is implemented in the form of district mental health program. This programs gives care to patients at a community level. We have established Manashakti clinics. Those provide positive mental health care services to communities and needy people at the level of primary health centers, besides providing specialized medical care at district hospitals. Then thanks are due to State Mental Health Authority, which is chaired by Honorable Additional Chief Secretary of Public Health Department of Maharashtra. It is instrumental in implementing Mental Health Care Act 2017 across the state of Maharashtra. In that process, we have established 8 mental health review boards. These review boards are chaired by Honorable Principal District Judges, and they help to protect the rights of all the patients of suffering from mental illnesses. They provide services for providing nominated representatives, as well as giving advance directives and all sorts of complaints regarding lacunae in provision of care will be addressed at the level of mental health review boards. So another thing is that we are, with the help of NIMHANS and the government of Karnataka, we are rolling out e-Manas software, which is useful for private psychiatric nursing homes to register themselves in the online form. They will get the downloadable registration certificate in that portal, together with online payment gateway facility. Another module, which is the patient care module, is also rolled out, which is not in Karnataka, but in Maharashtra we are rolling out the patient care module so that the patient can place their complaints to MHRB through this portal. So with this brief introduction, I again thank you very much for everybody and all esteemed guests and researchers and psychiatrists from all over the country. Thank you very much.
Thank you, sir. Your presence here today really means a lot to us. I request Dr. Ronnie, sir, to please felicitate. Thank you, sir. We quickly break for tea and come back in 10 minutes. Thank you.
After an invigorating tea, it is my pleasure to welcome you back to the second session of today. May I invite Madam Chairperson for the session, Ms. Renu Vora, onto the stage. She is very well known and needs no introduction for us, as she is the ARDSI National Office Chairperson. Welcome, ma'am. Can we please welcome ma'am with a hearty round of applause? It is a pleasure, ma'am, to have you in our midst. Now, to progress with the session, let me call our speakers. First of all, we have Mr. Sailesh Mishra. Sir, can we please have you up here on stage? Can we please greet sir with a round of hearty applause? The second speaker of the session is Mr. Greg Kuriakos Jacob. Sir, are you here with us? Please welcome we'd like to welcome on stage Mr. Jacob with a hearty round of applause. Thank you, sir, for joining us. The third speaker of the session is Mr. R. Narendra, who's our very own executive director. So are you here with us? So please come up on stage. Can we please welcome sir with a round of hearty applause? I think we can applaud better than this. You all have just had tea, right? Okay. Thank you, respected chairperson, madam, and respected speakers for joining me on stage. The first topic of the session will be delivered to you by none other than Mr. Sailesh Mishra. He's a renowned international social activist and entrepreneur. An economist by education, sir has been working tirelessly since 2005 when he left the corporate world and established Silver Innings, a now famous platform for geriatric support and advocacy. Sir has also established A1 Snehanjali in collaboration with the MMRDA of Mumbai, which is a 24/7 assistant care center for living for the elderly. For all of Sir's amazing efforts, he's been awarded International Spark of Life Practitioner in Australia in 2013, National Karamveer in 2008, and Karamveer Jyoti Karamveer Jyoti in 2016. He even represented India at the UN in 2019 for the elderly care and rights. And Sir has also made a splash onto media platforms with his TED Talks. Sir, it is a great pleasure to welcome you for this session where Sir will be educating us about setting up dementia care units. Please welcome Sir.
Good afternoon, everybody. I thank ARDSI and Chaitanya for giving me opportunity. And I am dedicating my today's talk on three Murti who have trained me, Dr. Jacob Roy, Dr. Charles Pinto, and Dr. Sarachand Gokhale, who are mentor for me. And what I am today, I'm standing before you because of them. And I'm going to talk about challenges of setting up dementia care unit. We have heard about what is dementia, how we can handle, but when I started my journey, and I'm not a trained psychiatrist or doctor, I don't have any academic background. It's just a passion and just an entrepreneurship what I've started. So when we provided care for people for dementia at home, and then there was a need for people to set up a specialized home. And while doing this, I found there are some challenges. And there are some people already here, Prasad Bhede, Anjali Deshpande, who already have done this centers. So also want to tell you that we are part of Commonwealth, first Commonwealth dementia report, which was published 7 September, and we are on the front page. Our home is projected, and I've written an article in this. Let me tell you about my project, A1 Snehanjali. Silver Innings is a social enterprise started in 2008, working towards creating an elder and dementia-friendly world where aging becomes positive and rewarding experience. And I started A1 Snehanjali first social enterprise in Mumbai area to have a dedicated assisted living care home for dementia. And we were very clear that it will not have people who will have constant medical requirement. It is not an old age home and it is not a clinic. It is a home. Apla ghar ahe. Ghara sarka mahol. This is kind of thing I thought we should do, because when I work with seniors and dementia people, they were looking for home. They were not looking for old age home. And even Snanjali, our mission is to mitigate loneliness, helplessness, and boredom. I think 3 important problems in aging and dementia. If we handle loneliness, helplessness, and boredom, we can tackle and handle dementia. So we made principles. What are important part of characteristic of home for dementia? Holistic care. Everybody talk about non-pharmacological approach. Person-centered care. Every person is different. He has talent. He has background. So we have to make project and program according to the person. We have to give dignity and respect. Communication is very important. Language is not a barrier. We have Tamilian, we have people speaking Urdu, we have people in Gujarati, Marathi, Hindi, but language is not a problem. Because it's a emotion, it's a passion, it's a body language, it's an eye-to-eye contact. Here I am speaking to her with eye contact. And safety, these are important characteristics. So here we created home-like environment. Everybody eats food in the group. We do group prayers. We do singing. We do dancing. We do all exercise in group. Because we felt people isolated, living alone, is difficult to handle. But when we started taking them in the group, they perform well and they live longer with stabilized condition. This is admission procedure. We get calls or emails, and we phone calls. We ask them, why you want to admit your dad or mom or wife or husband? We discourage them because people are trying to dump also people. So we try to handle calls or emails. Details. We ask them to come our center and see who are we. Some people want to just send their parents without knowing what we are doing actually. Then we do home visit. We find out the background of the person, the family, and what kind of stage the person is. Whether he can walk, whether he can perform his activity, whether he can speak. We try to do that. And then we submit a report to a medical officer in our home, and she or he decides whether the person can come in. And then we complete the procedure. And we do full 12, 15 page black and white form, which has a consent, which has all the details, background check of the person, what time he sleeps or what time she eats, what are the habits, everything is written there. So that we can provide good services. And we take refundable deposit. We take non-refundable deposits also, small amount, where we do a lot of activity in the local village, in the school, in the church, or in the premises where people require services. And we have monthly maintenance, which includes food and doctor services, plus actual medicine, diapers, and toiletries. While doing this, I found there are a lot of challenges. And I'm just not going to talk about challenges, I'm also going to speak how we could handle this. So first, I think, was the mindset. In India, still, we consider seniors very respected. They are supposed to be at home. And there is a stigma where you are sending your parents at old age home or sending away from home. How can you do that? Your family, your relative, your neighbors will, ask questions. I think that was the biggest barrier for us. How we'll get client, how we'll get a resident. So that was the biggest barrier for us. And senior citizens also feel it's a responsibility of children to look after me. Why they want to throw me out? So there was this dilemma we are facing. Initially 2008, when I started Silver Inning, I was also of the same mindset. We don't need old age home. Why we need old age home? But then I realized after working with senior citizens, dementia people, some people require specialized home, specialized care. It might be dementia, Parkinson, schizophrenia, bipolar, autism. So they require special places. Then I thought, let's do something. And here I felt there's a need. In 2013, we started A1 Snanjali. The mindset was the first problem. Second was the location. Mumbai, Pune, Delhi, Bangalore, we are such a big city. Where to start a thing? Because if I start in Borivali, how can Chembur person can come? If I start something Yashada, how can people from other place can come? So location was very difficult. And lands are costly, rental are costly. So that's the biggest challenge we face, traveling, how to travel. So many of the homes or many of the places are outskirts, outside the city. It's very because of other issues also. And I think seniors should not be isolated. They should not be sent out of the town. It should be inside the town. I was looking for the place which is in the middle of the town, middle of the place where you can see the bus, you can see the vegetable wala, you can have children, everybody is surrounded to you. And we found this place in Nala Supara West at Nalagaon, where the village is around you, and it's the middle of the village. And we took on 10-year lease. And we could not, this is one learning I thought. If you're investing more money, if you're buying a property, you invest more money, and the break-even doesn't happen. So my people who are supporting me told me, you should have break-even in 3 years. If you don't break even in 3 years, you're a loss-making company. So I thought that is one way. So we took a place for 10 years lease. Then I think again the problem was finance. सपना है, passion है, ख्वाब है, पैसे नहीं है, pocket खाली है. What to do? I went to bank. What is dementia home? What is care home? What is old age home? They don't want to fund. If I was a builder, I was making a building, they could have funded me. So nobody was ready to fund. They did not understand there's a need. I'm talking 2013, where dementia and other things were not very approachable. So we tried to explain them. We told them this is how we can do, how can we earn money, how we'll pay you back. But they were not ready to listen. If there was a developer making a one building, they could have funded him. Then I went back to my family and friends, and we have some money, so I could start. So finance is a big challenge. So can government support us? Can CSR support us? Can company or philanthropist people can support us, giving us land or money? Human resource. Sab kuch kar liya, but who are the people to work? I think Greg will speak about it. So finding people to work in old age home, elder care, dementia home is the biggest challenge. That's what I faced. We might get people who are there to work, very educated, very intelligent, very skilled, but they will not stay with you for a long time. They will fly or they will go somewhere out. So here, to have people, to train people is very difficult. So what we did, we trained Adivasi people. There were people from Adivasi, Vikramgarh, Wada, Jawar. We trained them. We trained local ayabai, maushis to cook and make dementia-friendly food. And we try to employ the local staff. When we employ people, we don't see education. We see attitude. Can you handle your grandparents? So we ask them stories about your grandparents. How did you handle your grandmother, mom? What is the relation with your dad? What you do with the children? So we see the attitude, whether they have this. And I found local traditional Adivasi indigenous people are very caring. Whether they are from Jharkhand, whether they are Orissa, I have people who already explained yesterday. They are very caring. City people, I don't know, somehow not very. They have 9-to-5 job. Here they do extra performance. They take care of people as their grandparents. And we employ people. The problem is retention. How to retain staff? That again becomes challenge because they want to jump. So like there was a pandemic. We gave them ration. We give them some quantity, this thing also. We pay their marriages, for the marriage, the childbirth. We have Ganesh, an Adivasi kid who came in 10th standard. Today he is doing MA. We are funding his studies. It is not because it's my caregiver, he should not study. Why he should not? I'm thinking of employing him in some government department if he does MA. So we should help them. So when we help our staff, our caregiver, make them part of our family, then we can retain them. So retention is again a problem. You have dream and everything, but what is the motive? A lot of people come to me, I want to make dementia home, I want to make old age home. Well, what is the motive? Do you want to earn money? Do you want to do seva? Or you want to do both? So if your motive is clear, I think what you are going to do is be meaningful. So if you are not for profit organization, So you're operating old retirement home, care home, or your NGO or social enterprise. So if you're clear what you're going to do, then things fall in line. So, but what I feel, many people make a lot of homes. A lot of builders have come up with township in Pune. There are so many townships. But human touch is not there. When you're making homes, it is not dementia friendly or elder friendly. It's just a building. There are hardly any ramps, there are hardly any grab bars, there are non-skid tiles are not there. What kind of lighting should be there? How much, where the light should be there? The motive is not clear. So they're just made to earn money. So you can earn money. Of course, everybody want to earn money. But as a elder industry, senior industry, dementia industry need human touch. It can't be just infrastructure, building. Then come marketing. I made a book, I made a bungalow, I made everything. But where are the people? Where I should go? For me, I was lucky, I was using social media. I use Facebook, Instagram, Twitter, and all kind of YouTube to talk about our home services, because we already working with silver lining for a long time. People knew us. So people want to admit their parents or for dementia or old people where they trust you. They're going to leave the parents with you. They think how you are going to care for them. So marketing was a problem. But what happens many times, many builders, many big homes, they will do a lot of advertisement. And people fall in trap seeing they don't go and they don't have any feedback where to go and where to ask. So if you have testimonials, if you have your parents or people who can tell ki this is what home is good for you. So we went to the doctors also. And some people told me, don't pay the doctor. So we have not paid any doctor for referring patient to us, because I don't think this is a business for me. It's a passion. Of course, I want to earn money, but I'm also doing some seva. So here we did marketing, word of mouth. We're using social media. I think that was good for us. Then now we started in 2013. In Nala Sopara, where I'm working, there were 2-3 homes about assisted living. Today there are 50 homes, old age home, Vruddha Ashram. Abhi Vruddha Ashram can be started by anybody. In 1 room, 2 room, if there is 1 hall, there are 20 people admitted there. So when family comes to admit their parents, they come to us by email or by social media or word of mouth. But when they see charges, they don't want to pay. Aapka to NGO hai na? What do you mean? NGO है तो क्या हम charge नहीं करेंगे, free देंगे? There is no government funding. Sir is sitting here, sir knows. There is no funding from nowhere. Nobody want to fund. तो हमको तो rent देना है 45,000, salary देना 15,000 रुपया, light का bill, पानी का bill, बाजी and everything. So where is the money? So here other old age have come. They are providing 70% less money, and they will offer home at 10,000 rupees, 15,000 rupees. But there is no care. There is no dementia training. They have only Maushi who will come and clean jhadu pocha. He'll have tiffin service, and doctor or nurse who will run the facility. And people admit and they run away. They just send money. They're not bothered about caring. In our home, compulsory 1 month, every month visit. If you're not there, relative has to come, or Facebook call or WhatsApp call. So here, competition, I'm not able to fill my facility, because there are other options available. So here we have to talk about what kind of care you're giving, what kind of trained people you're having. So we need to educate people where you're admitting your parents. We're having the two-day conference and we're talking about non-pharmacological approach, therapies, so many things. These homes will give you sedative, make people sleep. Go there. You can find the smell, the food, the torture they give to people. Then it is easier to start. You have money, you have got friends, you've got loan, suppose. But to run continuously is very difficult. You have to generate income every month. Then you have to have your stakeholders. Every month you should have 10 new people as the people who are the customer. You maintain the quality of food and services. Maintaining the staff, keep the staff happy. Because staff is not happy, their things are not going to work. Reduce expenses, unnecessary expenses. Keeping resident and family happy. And this is all continuous process. We can't just start, sit down, abhi mera kaam ho gaya. Every month, every week, there's something happening. And it's a continuous process. We have to do that. Then food. I think here, I never realized, I just started. But I found, in our country, we have so many religions, so many communities, eating habits is different, cuisine is different. North Indian, South Indian, Marathi, and there's somebody from Muslim community, there's somebody from Christian community. What kind of food they're going to have in breakfast, what kind of food they are going to have in dinner. So, breakfast kitne baje karna hai, doodh pina hai ki chai pina hai, it's all different. Here we are having people, 10 different people, how to manage, how to have different kind of cuisine for the food. So we went to SNDT college, diet department, nutrition department, they design a package for us. So every 6 months we refer there, and then we have vegetarian food. We have started egg once a week, and then we give like morning breakfast, which is different, one day idli, one day paratha, one day, kind of different thing. Then we have dal, bhaji, roti in lunch, and then every day there's a different thing. But making dietary preference to make dementia person have this food is becoming very great challenge. And this, if you're going to start something, what I'm listing here is for you to learn and experience, you have to be prepared what is going to come. Then diversity. People wear different kind of clothes. We have different culture, different tradition. What time you get up, you have tea or coffee. You have people from South India, they will only wear lungi, they don't wear shirt. I found we were not aware of this. Some people, they felt offended, other people, why he is not wearing shirt, or why she is wearing sari, why she is wearing gown. So there are different kind of culture, traditional we have. And India is such a vast country to integrate everybody. But dementia is good, one way. It forgets. It forgets the religion. It forgets the caste. I have seen there is love happening there. Love is not love. People get friends, new people. They get comfortable. Oh, I'm secured. Somebody providing me love. I will become their son. Somebody will become the sister-in-law. Somebody will become mother. Somebody will become father. So there is a good relationship. And from each resident also, they have good kind of communication and rapport building. So diversity is there. But dementia helps them to connect to other people because they feel secured in the secure environment. So I have talked about challenges, but there are good learnings also. Some rewards, impact we have made. So what we did when we started this facility, we have some challenges. We wanted to do something for dementia person. So we did something for dementia person and as a human being. So they are human, so we have to do something, not treat them as a patient, but our resident. We don't call them patient, we call them resident. We don't call them inmates, we call them resident. That's very important. And immediate relief for the family. The family, nobody comes and dumps in our place. The family must be working in US or Australia, somebody in Bangalore. So we look after the parent and they are happy. They can concentrate in a study, they can concentrate in a job, and we take care of the parent. Employment. We provide employment to 25 people. Local people. We train Adivasi people. We do community work in healthcare. We do health camps. We make government of Maharashtra ID card. We have adopted school, Jilla Parishad school. We do education materials and train them also. And we provide financial and social support for nearby people. We do advocacy and networking with different departments. And we empower young students, do hands-on training. There are a lot of people coming to us. We do summer camps for children who come to our home for 1 month and do a lot of creativity activities. And also promotion of non-formal approach. So this is the impact we made, and this is what we carry. Reward is interacting with satisfied resident, happy faces, family who bless us. So that is our reward. We go home, I can sleep. In fact, when I was working in corporate, I had a lot of stress. I had a heart attack in 2009. And after that, till today, I can sleep properly. Because I'm blessed, I'm happy doing happy work. So if you do volunteering, if you work of course everybody has to survive. If you help people, if you work with people, if you work with old people, if you work dementia people are beautiful people. Let me tell you, of course we saw a lot of things here, but they are very loving. If you love them, they will love you so much. So this is what we got, this is our reward. Conclusion is, dementia, like any other mental health problem, is neglected. Mental health already regulated, but we have a state policy now. All the state will have. But dementia still is the last. But now the status has changed. And it is not only national, but the international, global, and state. It is a local problem now. It is a Gram Panchayat problem. It's a Nagar Palika problem. It's not a only state and national problem. So as the entrepreneur, business house, and social activists, we should try to make difference to people with dementia and their family. It's a government responsibility to make a national plan. I urge in this conference, and ARDSI, to state policy, sir is here, to make Kerala is the first state in India to make senior citizen policy and dementia policy. So Maharashtra state can make dementia policy, state policy. I think that is what we can start, and we can be torchbearer on this, because Maharashtra has such a beautiful mental hospitals and mental act place. So we can do state, national plan. So here, if you make a plan, so everybody participate. School, colleges, seniors, CSR, government, everybody participate, and we can make a beautiful world. So CSR company, they are ready to fund, but we have to give them the idea. Tell them to come to elder care and help us to do something. I wrote a book called Remember Me, is on Amazon, and it talks about stories of people who are suffering with dementia. Also, what is dementia, what is insomnia, how to eat, how to take bath is available. So in the end, we need love, we need care. I don't need medicine. Look at me as a person. I'm your wife, I'm your husband, I'm your daughter, I'm your grandparents. If you just look at me that way now, you won't run outside. Problem is in the home. If you are there, present, take support, ask for support, things will be better. Thank you.
Thank you, sir, for that very educating and pragmatic talk on the nitty-gritties of the dementia care units that we need to set up. It was enlightening. For our next talk, I would love to call on Mr. Greg Kuriakos Jacob. He is the Chief Operating Officer of Caremark Care Services, which is a UK-based, home-based healthcare organization. Sir has a Master's of Engineering from the University of Manchester. But however, after only 3 years of working as an engineering professional, he has transitioned to healthcare. Now, fantastically, sir has been translating his UK model to Kerala, bringing a new and unprecedented comprehensive care system for geriatric care, both for neuropsychiatry and even more, like cancer. So, sir will educate us now on the paradigm shift in elderly care, how to set up home healthcare organizations. Thank you, sir. We wait to hear from you.
Good afternoon, all. Thank you for that introduction. I'm still in the learning process. That's too much of an introduction, I would say. Before I go ahead with the presentation, I would like to thank Dr. Roni and Pune chapter for having invited me and my mother. I'm Dr. Jacob Roy, late Dr. Jacob Roy's son, and it's a great honor, to have giving away the awards yesterday. So thanks very much for that. I mean, I wouldn't be, none without this great person, and he has left a great gap. I still continue to miss him. It's a great, shoes I have to fill. He was my mentor. He was my great friend, my guide, everything. I've been seeing him. Every breath of him was about dementia. He has even spent time in disability. He was a pediatrician by profession, by the way, and I'm sure he would be really proud to seeing this conference happening here. Just a couple of pictures that I've picked up for this presentation to share. The first seminar that happened in 1991, he handing over a report to late Dr. APJ Abdul Kalam, and this conference would be very special to him. The first ADI conference that happened in '98 in Cochin. I would say that was the first international conference to have ever happened in Kerala. And that you're seeing there was the last conference he attended I think it was a few months before his demise and happened in CUSAT in Cochin. Now, coming to where I belong, now it's a company as introduced Caremark. It's a UK-based company, started by Mr. Kevin Lewis. And he started his journey by starting an institutional care in the UK. He then later on realized there's a huge potential in caring the elderly at home, and then started Caremark as a home healthcare company in 2005 in the UK. I've not seen a person like him, with a similar energy like my father. Of course, it is through my father, with great pride and honor, I can say that I was introduced to Mr. Kevin back in 2015 when I was working in an engineering company, and that's how I got introduced to Kevin. He was successful enough to have franchised this business all across UK. With over 150 offices right now. Unfortunately, we lost him 2 years back, but his vision and his energy still continues through his successors. As I said, though I come from a mechanical engineering background, it is only through through Kevin that I got exposed to this huge world of home healthcare, and it was a life-changing opportunity that Kevin gave. As you see in this picture, it's during my training in the UK. My dad just visited in 2015 in the UK just to check if I'm doing all my training fine and good, as usual. So Kevin's vision after he successfully launched Caremark after almost 25 years, his vision was to implement the same model in India, and that's how he decided to start a pilot office in Cochin in 2015. And that's a point when we hardly had, probably 2 or 3 professional home healthcare companies. When I say professional, we could easily, if you look around, we have a lot of unorganized sectors doing the same job of taking care of elderly at home. When I say unorganized, it could be home nursing agencies, maybe 50 or 50 plus agencies in and around Cochin. And that's a time when it required a lot of awareness, a lot of education, awareness to the public, the need for a professional company to deliver care, and that too, it came at a price. From then till date, we were able to successfully deliver over 3,000 plus clients, both short-term and long-term cares. And currently, we have around 150 plus clients in Cochin. And now, as I speak, it's a very stiff competition in Cochin. Cochin, as you know, it's a city in Kerala with over maybe 3 million population. And now, as I speak, we have almost 10, 15 companies, competing in this same field. It's a good thing that more professional players are coming, but at the same time, it's also a challenge because Kerala, as compared to anywhere else, we don't have much regulations. So that's where we stand apart, because we follow a same system as in the UK. So we have certain guidelines and systems and process in place which is proven. I'm sorry. I wouldn't want to repeat. I'm sure by now these statistics would have taken rounds. It's just that aging, yes, of course, it is a matter of concern in India, and the numbers are quite alarming. And people with dementia, yes, it is also on the rise. But Kerala specifically is quite unique in many ways. As you can see, it's one of the fastest aging state when compared to other states. Kerala has, in a lot of ways, it is different, as you might realize. If you can see that in terms of healthcare, Cochin, as I just mentioned earlier, just being a city with 3 million population, we have almost close to 7 or 8 super specialty hospitals. Education or literacy on the higher side, and this definitely is keeping life expectancy going up, and thus aging is definitely is on the higher side when compared to a lot of other states. And definitely it is going to rise, as you can see, by 2036 to 22.8%. Some of the issues that is faced by elderly, medical issues, financial issues, and social issues. From my experience of running a home healthcare company, it is quite common to see clients approaching us with medical issues. It's very rare that we have clients who ask for just companionship care. It is very common in the UK. You have clients having domiciliary care. There are staffs who, healthcare assistants supporting clients for just few hours to just check on the client and they come back. But in Kerala, from my experience, most of the clients have got pre-existing medical conditions such as diabetes, hypertension, or they have a serious medical condition like dementia, cancer, or Parkinson's, etc. So, which means there's definitely a need for trained healthcare assistants or professional home healthcare companies like us. And of course, social issues are quite common. Since they're all vulnerable people that we are dealing with, we do have physical. When you talk about abuses, you have physical abuse, financial abuse, sexual abuse, even emotional abuse. When you talk, when you experience caregiving, even the way a caregiver speaks with the client, it can even cause emotional abuse with the client. So these are things that I'm sure an elderly person would be facing. We have systems in place which we ensure that to foresee that these issues doesn't takes place in our client's place. Now, there's definitely a change in the care scenario setting. Now, life expectancy change, as I have already explained, but there's this new thing that we have been seeing from the past, which is the migration of younger generation. In the recent times, probably in the last 2 to 3 years, this has probably doubled. I'm sure you all agree with me. There's this huge traveling of people, especially from Kerala to the Gulf. That was a norm from before. But in the recent times, there's been a huge flow of people to European countries and other Western countries. It's not just Gulf. And this has caused isolation, isolating parents at home, especially senior citizens. There was an article in BBC which I've come across, as a village called Kumbanad, that is in Tiruvalla in Pathanamthitta district. Almost 15% of the homes are locked up. Majority of the homes, massive homes, we're not just talking about small homes, a two-storied building with just, a couple, maybe an old, husband and wife staying alone. And the children, they're working abroad. So this is a common scenario which we are coming across, I'm sure, and this is going to be a common thing we're going to come across in Kerala. And this is probably due to the higher literacy state in Kerala, because children, once they're getting educated, they want a better quality of life, and they move abroad. So for this reason, once the aged parent, they need a support system, they definitely would approach a home healthcare company or even an assisted living center. And the receptiveness to this setup is much more when compared to before, because they don't have anyone to bang on, and I'm sure the children who are more educated now, they have probably more understanding about such professional companies. As you can see, even hospitals have now started entering into this high competitive field of home healthcare. Most of the hospitals have started setting up home healthcare units. Though they are operating within a small radius, they have their own home healthcare setups. It's a huge market that we are talking about. It's a $6.2 billion market, was into 2020, and it is going to rise up to $21.3 billion by 27. Though we are talking about a huge potential in terms of business, I'm sure, yes, you can make a lot of money out of it, but as quite rightly how Sailesh sir has mentioned, it is not just about making money, because from my experience, you need a lot of passion towards this, kind of, yes, I call it business. Yes, you need passion as well, commitment. Because every day is going to be quite very challenging. Every day is going to be different. It was especially during the time of COVID that people saw a lot of demand for such business. Maybe this was one business that thrived a lot during COVID, and people started to see a lot more potential. We started seeing a lot more players coming into the market. As I've said before to one of my colleagues, everyone has a space in this market. You don't have to be too aggressive because there's enough and more clients out there. But the only thing is we have to be working in a more structured manner. We have to be following a process, and that is quite needed. Otherwise, you're going to be, there wouldn't be any clarity in the way you're functioning. And in this manner, you will be able to bring in a structure to this whole unorganized sector, which is caregiving in general, which I'm sure it is happening in this process. Let me just give a brief background about how we operate in Caremark. Basically, we have a team of consisting of a care manager who will oversee the operations. We have a care coordinator who is supporting the system, a nursing trainer who will be training our healthcare assistants. And healthcare assistants are basically the ones who being sent out to the field to take care of our clients. And of course, we have our field care supervisors who are the backbone of everything. They are the ones who takes feedback and takes care of our clients in the field. In terms of the kind of services we provide, the most common service that we find is stay-at-home care, what we call. That's basically the staff, they have to live with the client. The other services are day support. The staff, they go in the morning and they come back by evening. There's something called as hourly care, which is quite similar to the domiciliary care in the UK. Now this is something which is now becoming more popular, day support and hourly care. When we started off, it was not. This is taken by clients who, for example, if they need only personal care, they can opt for this service, or someone undergoing physiotherapy and need more assistance, our staff can go and help out, or they need help because the family members are probably not available during the daytime, they can opt for this service. There's something called as night support service. So, clients who have got sleep issues, they can opt for, night support. There's again a popular service now is the short stay care at hospitals. Now there are plenty of, clients who getting admitted in hospitals and do not have bystanders. For this, they approach us and we give service for as short as 7 days. It's getting, as I said, more popular. This is a new service that we are trying to push, and I feel there is more demand for this in our city. It's called Nanmark. Again, it's an initiative taken up by Caremark. It's basically our trained staffs would be accompanying a client from home to the hospital for OP consultations. So it could be for a few hours even. It could be for a day procedure. Basically they'll be throughout with the client for the consultation. So the client need not queue up for getting the medicine from the pharmacy. They can, get everything done so the client can be at ease, they'll get make sure that the client is, got back home safe. So this is something that we have recently launched. The process, I'm sure we just heard from the previous speaker. It is, of course, from the outset, it's almost the same. We start off with an inquiry. We have an assessment done, which we call as an individual needs assessment, in which we try to understand the needs of the client, where we try to understand every aspect, the background, the medical condition of the client. We even try to understand a bit more about the person, as everyone has been speaking about person-centered care. So in order to deliver a proper care plan, it's quite important to understand the background and medical condition. Then we try to understand each aspect, the mobility of the client, the medication that the person is on, how he would like to support, etc., etc. After which we try to allocate a right healthcare assistant, and then we try to then we go on with the introduction of the healthcare assistant. Once the introduction is done, we have what we give a lot of importance is the quality assurance. Now this is where this is where the game starts, where once the care is on, we have our field care supervisors going periodically to take feedback from the client and also to do the supervision of the staff. Now, one thing we vouch for is to do permanent allocation of healthcare assistance. So a lot of these, care that we're giving is very sensitive, the personal care, because we're handling vulnerable clients, so we don't want staffs to be changed quite very often. It's getting quite challenging these days, but we try to keep the staffs permanent. So yes, so for these reasons, we have been able to make this a successful model. We have from our I can easily recollect clients who have been with us for more than 6 years. Of course, there has been a few changes of staffs in between, but the reason they've been sticking on with us is for the quality of care that we've been able to deliver. So continuity of care is very important. And it is also the rapport we built with the client's bystander, so that they have the trust with us. And as I mentioned earlier, we try our best to permanently allocate a healthcare assistant, monitoring of the care. So taking feedback as well as monitoring, the supervision of the staff is also important, because they are the ones who are in the front line, taking, delivering the care. So there's always a high chance of they getting worn out, stress. So we try to ensure that all practices are put in place to ensure that all priorities are given to ensure that they are able to give the best of care. This is just one of an activity we have done during Christmas time. This is one of the time when we visit all our clients, because it's an annual visit we try to do. We cover most of the clients by giving, sharing joy and happiness. It's an emotional time as well, because there's a lot of clients who are bed-bound and they wouldn't be able to come out to, to see this happiness. So it is something which we cherish a moment, and we try to do a lot of other activities. This is just one activity I would like to share. So in general, yes, there's more receptiveness to home healthcare right now as I speak. From a Kerala perspective, if I say this mind block is gone from where we started off in 2015, I would say it is more of a convenience now as before. Even a working class couple, as a husband and wife who are working, they would want to employ a healthcare assistant or approach a home healthcare company to have a professional trained healthcare worker to take care of their loved ones, to ensure that they are at peace of mind. So it is though there are a lot of challenges, but I'm sure that it is in the right track, and I'm quite confident that in the coming years this will take up in its full shape. Some of the advantages of being in approaching a home healthcare setup is basically the client can remain in a familiar surrounding. They don't have to move out. The freedom of that particular client we try to encourage, and of course we try to customize the kind of care that we are delivering. There is a light domestic task that we try to deliver to the client, pertaining to the client alone, not the entire domestic task. There is this family's involvement as well when we try to deliver care. So it is not just the caregiver and the client alone. There's always the family around. So that, I'm sure, will give an impact in the client's development, in the client's progress. There's a comprehensive range of medical and non-medical services when you talk about home healthcare. There are even companies out there who are giving almost ICU sort of care at home. So as I said, it's an evolving industry, and much more. As I say, there's goodness in both institutional care and home care. There's, as Sir's already covered this, I don't want to go in depth. There's just few points that I've mentioned. And institutional care is, you see there's the round-the-clock care, social interaction, and of course, the family caregiver can offer a best alternative when you talk about or they pay for a facility in these in these centers, as well as keep their home, as well as stay in their home, so that at a time comes they go to these centers if they fall ill, etc. And once they recover, they come back home. So this is also a common thing now. For a dementia patient, yes, of course, from my experience, it is always good for a dementia patient to be at home because they are at a familiar surrounding. I've heard from one of the previous speakers talking about this. And also one thing we have noticed is our healthcare assistant is always interacting with this patient, so that any change that this patient is exhibiting in terms of behavior or health-wise, they can always address this to our field care supervisor, and we can take it up with the family or with the doctor. So that's an advantage we feel it is. And the family has also got the flexibility of taking up the kind of service they want. They can either choose for a full-time or even part-time service. And as I always say, there's this family involvement which can make a huge impact. I would like to play this small video.
അവരെ നമ്മൾ വീട്ടിലുള്ള പോലെ നമ്മൾ എങ്ങനെ നോക്കുന്നോ അതുപോലെ തന്നെ നോക്കാൻ കഴിയും കമ്പാഷനേറ്റ് ആയിട്ടുള്ള കെയർ വർക്കേഴ്സിനെ കിട്ടുക എന്ന് പറയുന്ന ഒരു ഭാഗ്യമാണ്. അത് നമുക്ക് കെയർ മാർക്കിനോട് അസോസിയേറ്റ് ചെയ്തതിന് ശേഷം നമുക്ക് കിട്ടിയിട്ടുള്ള ഓരോ കെയർ വർക്കറും, അവർ തന്നിട്ടുള്ള ഓരോ കെയർ വർക്കറും ഇതുപോലെയുള്ള കെയർ വർക്കേഴ്സിന് മാത്രമാണ്. അത് വളരെ അപൂർവം സംഭവിക്കുന്ന കാര്യങ്ങളാണ്. കെയർ മാർക്കിനോട് ഞങ്ങൾക്കുള്ള നന്ദി.
My apologies, that was in Malayalam. I'm not sure, was it really audible? She was, in fact, we lost her. She was a dementia patient. I'm not a medical person to actually describe her. She was not a very aggressive dementia patient, a less mild dementia patient. She had a problem with repetitiveness and giving personal care. She's got a bit of sleep issues. But a very lovable person. Whenever we went, there was this warmthness whenever we went to see her. Now, one thing that I wanted to highlight here is that it was a son who was actually talking and about the care we delivered. He's from a middle-class family, and he was very particular that the best of care was delivered to his mother. We were able to deliver care for almost I'm sure it was almost close to 5 years, 5 to 6 years, I believe. And it was the healthcare assistants who have done a brilliant job in delivering care. So in general, it is almost the same thing that the dementia care that some of which, at least the UK model, what they have said, we've been able to make care plans, which we've been able to do regular inspections. That's basically the quality checks. But in the UK, of course, it is slightly different because they have what is called as a CQC, which is called as a Care Quality Commission, as UK is highly regulated, which unfortunately we don't have any regulatory bodies here. And of course, the qualified care assistants, after training, they are able to take care of dementia patients well, because we have a separate topic on dementia, the best possible way we are able to train them. And in dementia, one thing in the UK I've noticed, the franchisees and the head office, they make sure that all the local offices, they're connected with the dementia groups and the support networks, which is I'm sure it's an added advantage, which we are trying to develop. I'm sure organizations like ARDSI and much more can work on this. Challenges, of course, healthcare assistance is becoming a great challenge. Attrition rate is on the higher side, as I mentioned. earlier, people have been going abroad recently in the last, I would say, 3 to 4 years. We've been seeing a high peak in people going to European countries as there was this change in the visa regulation in the UK and other countries. People could easily, migrate. And this had caused, a cause of concern for us in the late times. But we are trying to work our ways around to attract them. We being a UK-based company, we've been able to attract our staffs with a lot of other things. I'm going to wind up, yeah. Of course, this is something which I would like to say is that ours is a price, we have a price quoted for the care we deliver, and I'm mindful that there are a lot of elderly people out there in the rural areas which we have not addressed, and that is something which we need to look into. To address these things, of course, we need to have strong training programs. I'm sure for the caregivers would retain them. Promoting home care as a job, as an attractive career, I'm sure that would help. There should be more awareness on caregiving at school level. This is more important because they don't see this as a career. A lot of people don't look this as a career path. If we are able to showcase this as at least as a career path to nursing, and from there on, that would create a change. And standardizing quality and delivery of care is much important. As I said, since there is no regulation, this is quite important. And finally, all the healthcare organizations, personally would want to work hand in hand, because in the long run, it's the same ecosystem. We all need to work hand in hand. Before I wind up, this is a proven model which I believe we can implement in a lot of other, in the rest of the parts of India, which is already happening. We have a lot of other home care companies in India, and this is going to continue. And our journey in Caremark, it continues to deliver higher standards of care. And my dream project would be to set up assisted living. It is not just mine, it is my father's as well. I'm sure God has a plan for to have put me up here, and one day this is going to come up. So thanks once again for this opportunity. Thank you.
Thank you, sir, for that very lucid yet systematic breakdown of what it takes to translate elderly care into a home-based system. You are filling a much-needed gap in our healthcare system. May your tribe grow. Now, last but not the least for this session, we have our very own Mr. R. Narendra, who's the Executive Director of ARDSI. Welcome, sir. He's the founding member and Vice Chair of Indian Alliance for Patient Groups, SARD Vice President, an NGO for Sustainable Education, NEG Fire for Tribal Children Education, and that is not all. The latest the latest feather, sorry, I had a bit of hypoglycemia. The latest feather in Sir's cap is the most effort that Sir has made for now, government support secured for the Dementia India strategy, which Sir will be illuminating us on the ARDSI efforts in putting together Dementia India strategy. Welcome, sir.
Thank you. So, yeah, I am going to talk on a little important topic. But then, yeah, for time limitation, I would try to curtail it as much as I could. But then I would just leave you with some of my key messages, like what is this all effort like we have been doing. And yeah, without much success, but then we have made an effort and we need to follow up. Like I think most of you got a window of what is this, because yesterday our Vice Chair of ADI and President Emeritus of ARDSI had given a window of what this entails, and she also mentioned my name that I don't want to elaborate much. Narendra would take over. Yeah, so now I am here. See, we had Guru Mantras of two good models. One is how to set up a old age or like a dementia care center. Another one is a absolute business model. So now we need to talk about those people who can't afford this kind of thing. Because health sector, if you see, it is divided in two parts. 20% is with the government, stake is with the government, and 80% is stake is with the private sector. And if you see, and you have to divide the population into 1/3 and 2/3. 1/3 is basically the people who can afford paid care. 2/3 are still people who live in rural areas or maybe in suburban areas and heavily depend on government care, which is the 20%. So now, unless and until we do effective policy advocacy, like yesterday we were talking and I have been telling, we all run through this syndrome, like unless and until this affects somebody in our family, we always think dementia is not a big concern, but the numbers tell. So now we can go ahead with my presentation. So this is my outline of my presentation. I am talking about the background. I am also talking about the ARDSI efforts towards strategy, and I will also be talking about the national strategy excerpts, and then what is the follow-up we have done, and a brief little, because all of the time you have been hearing like Alzheimer's related disorder Society of India. I just want to just brush you through that what do we do really, so that I want to take through. So these are all figures, but here I just want to quote about the Lassie report, which I have tried to go a little beyond and make it threadbare. Like you see, if you take India's population, it is 1.4 million, and the 7.4% is the Indian prevalence. If you take the Indian prevalence into account and extrapolate into 1.4 billion, so you get 8.8 million people, or maybe close to 8.9 million people. So, and if you see gender, out of like, if you take 100 people with dementia, 100 women, normal elderly women, you get 9 women affected with dementia. But in men it is slightly better. So if you take 100 elderly people, so you get 5.8 people. So that way women are more vulnerable. So if you take rural and urban, here once again, rural people are more vulnerable and urban people are less vulnerable, but the numbers are quite daunting. And once again, education, we have already spoken. And as you all know, that age has been a big risk for getting this thing. And future projections, this is very, very important for us, and we need to be much aware about this, that by 2036, we are likely to touch around 16.9 million or close to 17 million, which is going to be very, very alarming. And you can just think about the care burden that we might have to face, and what is that going to cost our exchequer, we need to be mindful about. So here, just to make it contextual, I just have delved and I just culled out some of the figures. If you see this Lassie report, it talks about the prevalence, and Delhi ironically is on the lowest end, and Jammu and Kashmir is on the highest end. The prevalence is 4.5% in Delhi and 11% in Kashmir. And if you see the 2016 figures, the elderly affected with dementia are around 0.7 lakhs. And there, if you see by 2036, in Delhi it is likely to go up to 1.7 lakhs. And 2016, we have an elderly population of 14.96 lakhs in Delhi. So similarly, in Jammu and Kashmir, you can see. So down under, I just wanted to make it contextual. As I said, Maharashtra has a prevalence of 7.61%. Our close young friend here, yesterday she was very interested in knowing the figures. So I just thought this figure would be much more relevant for you to do advocacy in a much focused way. And these are the figures. Like 2016, we had close to 9.7 lakh people living with dementia, and it is likely to go up to 17.80 lakhs in 2036. And you already have 1 crore and 27 lakh population, elderly population living here, and this is also going to likely go up in 2036. So these were the efforts made by National Office of making it strategy. We had regional consultative meetings held in 4 distinct places. We had all kind of stakeholders attending that, and these stakeholders came together and then contributed their knowledge, might, and everything, and we had documented all those things, and we juxtaposed that with the WHO's Global Action Plan, and we also juxtaposed it with existing pro policies, and we laid the foundation for the new one. Then we hired PHFI, that is Population Health Foundation of India, from Bangalore to help us, because policy language is quite difficult and it is not an NGO's game. So we need to be very serious about that. So we took their help and they guided us in framing the whole thing. And our asks were very clearly put up as per the Global Action Plan. There were 7 priority areas, but for India, we readjusted those 7 priorities and put up certain priorities up again the order. And the draft policy document, once we made it, we used the occasion of this kind of a conference where the health minister himself, J.P. Nadda, came in Bangalore, and Madam Meera Pattabhiraman and Paula were there, and this was unveiled and handed over to him. And he had promised so many things, but then nothing has happened. So that's why I said, yeah, we have done our effort, but then we didn't much succeed. But then we are not deterred by that. We are undeterred. You can see, this was the release where you can see J.P. Nadda and also the local health Karnataka minister. And you can see on the corner, Paula. So this was the outline of the document. Yeah, so I have just again run through the same thing. We have poor diagnostic facilities. Hardly 10% of the people get right kind of diagnosis, so which we need to address. And there is a lack of professional knowledge among people who are into the care business. And there is no specific care support at all levels. And more importantly, no social security benefits are attached to any form of dementia. Then there is a very high kind of care burden. So if you see current state of dementia care, so these are the things, 3 major things: access to care, financial barriers, and limited support is there. And in this slide you can see that the same thing, but then I want you to focus on the second point, where approximate care cost per annum per person, this is a 2010 figure. Today it must be anyway close to 60,000 rupees. So it is 43,285, because this is a very verified data which came from Niman. So I didn't want to alter the figures, and I just wanted to quote this figure that this is a scientifically done study, and we have evidence of spending 43,285 rupees. And this is for an urban location. For rural location, we found it to be less by around 6,000 rupees. And the third thing is much, much important, where we have to look at the health-seeking behavior is very, very poor. I would just cite a small example deviating from my presentation. I had a friend, even now he is there, like, he was a geriatrician. Maybe this story may be repeat to some of them, some of the people whom know me. But then I want to stress upon that the story gives the exact habit of Indian mindset. So this man, he went to Germany. He is a what you call orthopedician. He wanted to have some advanced studies. He was an exponent in total knee replacement surgery. This guy went there and he learned some kind of course, and it was a 10-15 day course. And he had befriended a German who agreed to basically drop him and pick him up. So one day the German friend said that today I'm not going to come to pick you up. So this man, out of curiosity, asked, why are you not going to come and pick me up? He said, I have an appointment with my psychiatrist, so I'm going to take consultancy from him, so I may not be able to come to pick you up. He said, yeah, today my classes gets winded up by 3:30, and if your appointment is after that, please let me know. And he said, yeah, my appointment is by 5 o'clock, so that is a normal time when I come and pick you up. But if it is 3:30, then I can pick you up. Then he, out of curiosity, asked him, is it possible that I can also accompany you? And he said, yeah, you can come. So when both of them went there, he was sitting beside the guy, and then this man, who also was a doctor, he narrated to the psychiatrist saying that he is a friend who has come from India, and I have promised him to daily pick him up and drop him at a place. 2 days earlier, when I just originated from my place to the place where I had to drop him, I involuntarily took another route. And when I was thinking to figure out why did I do that, I couldn't find a reason. So I just wanted to check myself, am I okay or not? Am I into some kind of stress? Or am I into some kind of you can see the level of basically even a small kind of mismanagement of activity leads them to go and seek some kind of health care. So that is the kind of healthcare knowledge and awareness which is there in Germany, in developed countries. Here, we live on that, we aggravate that situation, we just worsen our status, and then we always look for one pill wonder. We go across a chemist and give some kind of money, 10 rupees, 5 rupees, 1 rupee, so whatever is there. If we get a pill, we need to get rid of this problem. This is what our attitude is. So we need to be mindful about our health-seeking behavior, and the statistics is very, very alarming. You can see only 5% of the people access government care, and 33% of people so 33% of people don't avail any kind of care, and private doctors have a big share of 56% of people coming to them. And because the down under cause is there already, it is lack of awareness and stigma. Like I was telling you the story, when this man said that I want to go to a psychiatrist, this Indian doctor said, psychiatrist, why? So that was the reaction. So you can just imagine what a big taboo for us to say that I have an appointment with a psychiatrist. So we are living in that kind of a world, so we need to change, and we need to grow up and come to real terms and understand that healthcare is much more important, because once we are okay, then we can also have a much better future, because given the kind of alarming statistics, so we are going to live alone in our old age. So now, what is my Dementia India strategy wish list was all about? So this slide, you had seen a glimpse of it, but then Madam was very clever enough to run through it and allowed me the chance now to explain it. Yeah, dementia has to be a public health priority. This is according to Global Action Plan. And we had set a self-mandate of having 30% of states to have their own action plans by 2025. This mandate, why have I just highlighted 2025, is essentially because it is not too far away next year. But then this plan was originated by us in 2018. That time we thought, 2025 would be adequate time, but then nothing has moved, and in between we also had to face COVID. So that delayed the process more, and now we are geared up, and I'm really happy this conference at least has given a kind of a, this also has served as a very big platform for advocacy. I am thankful to Rooney ji because he has done a wonderful job. Yesterday afternoon, the proof of the pudding is basically one of your officers, he is instructing the care staff who have come from the state government to stay back till the last session and attend every session, so that, because this is a priority area for us. So that was sounding music to me for working for this cause for 15 years, like some government official telling that this is an important cause, please stay back and attend. So that was something, a very big success. That is the real success of this meeting. So most of us may be thinking conferences are waste, it is not going to help anybody. So just as very simple kind of a message, you can see how this can transform into real action. So now talking about the second point, dementia awareness and friendliness. So we had set a self-target of 50% of dementia friendliness and stakeholder-specific sensitization guides and manuals, and 80% increase in awareness where ARDSI has presence. And we also had kept dementia risk reduction as the third measure. If you see NCD, India is the only country which has a very good and a very telling NCD policy, NPCDCS policy. And in fact, you would all be surprised in 2018 when this policy was like 2017, they unveiled it. In 2018, JP Nadda, when he went to UN, India was awarded for having a very rugged and foolproof NCD policy, because they had made it so threadbare that they had a mandate of having the NCD burden by 2025. I don't know how much they have progressed, but then the papers were very promising then, and that emanated an award for India government. So dementia diagnosis, treatment, care and support. So we had kept 40% like coverage in diagnosis, because at this point, as I told, one of my slides very clearly said, once again, I don't have much evidence, but 10% has been a very off-the-cuff figure, which I have been hearing quite now and then in many conferences, so I have quoted that. But here, if you see, we had set a self-target of 40% in 30% of the states. And once again, the point number 5 is support for dementia carers. 40% of the states should have civil society organizations and other similar institutions which can basically look into the support systems for carers, because they have been a big neglected lot. Most of the time, whenever we talk about people living with dementia, we forget to talk about the carers. So here we had kept a provision and we had kept a kind of action plan for that. So dementia research and innovation, that is quite important. Like once again, I wanted to tell a story, but then for the kind of time limit, I don't want to say much. Yeah, so we had kept 30% of current levels to be, and also focus on person-centric care. And of course, last but not the least and most important is that data management, information systems for dementia. So we also were pitching in for a national registry. So these were the asks to the government very clearly when me and Madam Meera and Dr. Radhamurthy, when we went to meet the ministers. So we had put a wish list and we had put a very clear kind of a follow-up saying where we were asking for a kind of a formation of an expert committee, and we said that kindly ensure diagnosis so at primary care levels. So that could be a very easy way of handling things. And we also wanted to ensure convergence. Most of the people talk about so much about dementia, but they don't talk about these three kind of complementing policies already available. Like one is National Program on Health Care of Elderly, which is 2010 to 2010. This has a mandate of setting up of 100 geriatric units in 100 districts. And this is a very good program, but this has to be made dementia inclusive. And I know Dr. Matthew Varghese and myself and Dr. also part of 12th five-year plan thing, where we pitched in a lot, and Sujaya Krishnan was kind enough to include a big write-up on dementia care, but unfortunately, government didn't allocate any budget to that, and they were thinking of converging resources from Panchayati Raj and other places, but then that didn't come through, and it remained mere as a paper work. So then nothing could be done there. But yeah, we now seek that palliative care provisions for dementia should also be availed, and this, as I was talking to you, NCD is a very important kind of a thing where we need to basically tap those things, and also we should talk about Ayushman Bharat. And down under, if you see, I'm also talking about converging with Ministry of Social Justice and Empowerment. There is a very important program run by them. They provide support to dementia care homes. At this point, it has provision for all India kind of setup, but because of the very stringent kind of rules, hardly 2 or 3 NGOs have got the real support. Otherwise, and incidentally, they are all from Maharashtra. So otherwise, this whole fund has gone largely unutilized. So we need to tap on that, and we need to also build capacities of our medical and paramedical staff on dementia care management. So government action, investment in research, awareness and education, community support. These were our call for action for future. And you can see that this particular report was resubmitted by Madam Meera and Dr. Radha Murthy to then the subsequent Health Minister Harshvardhan in the year 2019, but then things couldn't move forward. So now I would talk about ARDSI, what we are doing. Yeah, so just to take you through in a very quick way. We are a 21 chapter organization. We have across the country, we have 21 chapters. And our roles are diverse in like it is put in two different distinct baskets. The primary basket is basically about the soft activities, and the secondary basket is about the action-based activities or hard activities. So if you see helpline and counseling, and then training and capacity building, these all form the kind of, even research and advocacy form some kind of soft activity, whereas community outreach and awareness, so these are all very hardcore activities, including training. So training, basically, we have a training center set up in Trivandrum, thanks to the support from NIIT and also for the support from Man Waterloo Foundation. So we have been able to set up a training center, and our trainer actually has been churning out many training, like many trained professionals. And at this point, on the day of my presenting this, we have almost trained 600 professionals, and this has been possible because of the grant that we got and also the kind of support Madam Meera and then Chair Radhamurthy and others gave to us. So this is what ARDSI does on the field, and if you see, put it on the same dementia, there's a global action plan. If you see, we have already been working under as a public health priority, and we have been creating dementia-friendly communities, and we have been working on risk reduction, and we have been also working on early diagnosis and treatment. So we also support dementia caregivers. So we try to increase our support, increase our training and education, and we also want to expand our long-term and respite care. So we have been advocating for that. So advocacy, predominantly people think that somebody going and asking something with the government. But for me, I need to also advocate with donors. My new donors, my corporate donors, they should also come forward and understand that, yeah, dementia is a problem and it is a health problem, and that needs also some kind of allocation and sustained allocation, and it needs a long-term support. Thank you.
Thank you, sir, for highlighting the strategies we can expect, hopefully, to come to fruits into reality. As much as we all love a good discussion, we are running severely short of time. So I regret to announce that we have only one question allowed per speaker. Yes, ma'am. Can we give ma'am the mic, please?
Thank you. My question is regarding the regulations in the caregiver market, and like Celestia and Greg both spoke about the competition that is coming in and the poor training of the caregivers. And being a caregiver myself and who had attendants at home, I've seen those challenges where the agencies are really not trained on providing this care, but they take obnoxious amount of money. So as a organization, ARDSI, as well as people who are already in the market, are we thinking that there should be some kind of a law or some kind of regulations and quality checks that should be followed? And if we are, then how are we taking it up with the government? Because I think that's something that really needs to be addressed, considering how we are moving in this population space.
Hello. So there is a maintenance act of citizen, and when the act was implemented, there were a lot of shortfall about caregiving, how to monitor. There are agencies who are working for senior, there are old age home, so there is no regulation. There is no criteria, what kind of old age home, what kind of dementia setup. So there is an amendment that is happening and already pending in the parliament, which has all the regulation. Who will be the agency? You have to register with the body, and this how we will provide caregiver, what kind of training, what are the wages you will give, and what kind of homes you will make. So infrastructure and everything is mentioned in that document. We hope so. So we will. We are still asking government to pass in the Lok Sabha. ARDS as a body, and this conference should actually submit a white paper on this. Regulation is important, but I think one more thing is more strict regulation also will be a problem. So we have to see, already Mental Health Act is already there, and there's a lot of regulation already into it. So we have to see where we are fit in, and not very strict regulation, but there should be some criteria, guidelines, what should be done.
I think it's more of standardizing the way you deliver care. As far as home healthcare companies are concerned, what to my knowledge, there's something called as QAI accreditation. If you want, you can approach, companies can approach for such accreditation, so that you're following a particular standard. And training, of course, it's quite a challenge. I agree with you, because your demand is outpassing your kind of resource what you have. But we try to match, but that's the kind of setting in which you're trying to operate. But what I stand on for is the kind of standardization you would like to have. You try to standardize the kind of care you want to deliver. Yeah. I hope it's answered.
Do we have something on those guidelines as a part of the dementia care policy that we are submitting to the government? That how should we regulate the influx of informal caregiving that is happening, right? The agencies who are not.
Well, we have been predominantly looking at this global action plan, and we try to basically take up only those measures at this point. Standardization definitely came to us, but as Sailesh ji said, see, standardization, once we talk about, it is basically based on, like, if I am some X foundation and I have certain standards, like for one patient, if I keep one caregiver as my standard, so I cannot just go and impose that to a very bare minimum standard where I manage with one caregiver and 5 patients. Okay. So we need to look at the non-negotiable and keep it bare minimum. So that one we have been advocating. So up to that extent we have been advocating, but we are not advocating beyond that, because we want to keep it bare minimum and not very stringent, so that its compliance becomes not a burden on us. So because once you just set a regulation, then you set a trap also. So you need to be careful about that. That's it.
Last question, please.
Hi. I have this question for Mr. Narendra as well as Mr. Jacob. For Mr. Narendra, since you spoke about a person in Germany who had, conversation, he or she must have also told you that even a psychiatric consultation is funded or is paid by the insurance company. As a result, it's also much easier for me as a customer to approach a doctor and not pay a bomb, because if in India, if I visit a psychiatrist, 1,000 rupees is consultation and 500 rupees must be the the medicines. So maybe I would suggest if you could also help, talk to insurance companies as well as to the government, that there is a public insurance, medical insurance, wherein, certain amount is paid by the insurance when it comes to a certain parameters they fulfill in the illness. I don't know if that's something you can take into perspective. Also from Mr. Jacobs, having you stayed in UK, I suppose, and me also having a little exposure in Germany for 5 years, haven't you come across the thought that to reduce the financial barriers for especially middle class people who want to get healthcare from a professional. This could also be one of the ways, tying up with private insurance companies so that, in the premium which they pay, certain amount gets a little discounted as well. Am I making sense a little bit?
Yeah, I will just answer the question thrown to me very simply. Like, yeah, you must have seen in one of my slides, I have already said about also advocating and bringing it, making it dementia inclusive under Ayushman Bharat. So I think that answers your question. Thank you.
Yeah, I mean, in the UK, you have the government.
You are admitted. But yes, with IRDA, we can talk to, as an organization, ARDSI, to include mental health and dementia as part of, actually, the state mental health also can help us to, because there's the biggest expense. Is not one-time hospitalization, is 45,000 per month is the expense. And I think in Western countries, they have social security. So national pension plan, if we start from the young age, your age, you will have a better finance to get all the services. So it's a society responsibility, government responsibility, and corporate responsibility to come. And there are insurance company. If we all can go there and tell them this is a requirement, there's a big market there, they might make a special plan for us. Thank you.
Thank you. Madam Chairperson, may I request you to deliver the closing remarks for this session?
Hello. Yeah. We are especially proud to have a TED speaker, Mr. Shailesh Mishra. Elderly care, especially high standard in home care, health care. And finally, to our Executive Director Narendra, who spoke about a very important aspect related to dementia awareness by putting together Dementia India strategy with juxtaposition on the global action plan. I thank all of you.
Thank you, ma'am, for the very wise words. Now may I request Renu ma'am to felicitate our speakers. Please, if we can have you all on stage. So a big thank you and hearty applause to Mr. Shailesh Mishra. Thank you, sir. Another big round of applause for Mr. Greg. Thank you, sir. And last but not the least, for our very own Mr. Narendra, please give a big round of applause. Thank you to our excellent speakers. Now may I request Dr. Swapnil Deshmukh to come on stage to felicitate our chairperson, ma'am. So thank you, Renu ma'am, for gracing us and bringing your wisdom to the session. It was a pleasure having you. Can we have a big round of applause for her? Thank you. Now we have filled our brains with knowledge, so we can fill our bellies with some delicious lunch. We will see you after lunch, after 30 minutes. Thank you.
There's two important announcements to make. Please let's respect the time and come back exactly after 30 minutes. And lunch today has been arranged for all of us participants in the basement itself. Today's lunch for all of us is in the basement itself. Thank you, everybody. And as we saw in the morning, the importance of holistic approach and cultural practices, our next speaker for the day is going to talk about role of Ayurveda in treatment of dementia. Our next speaker is Dr. Shinde. He is the professor and head of Department of Kaya Chikitsa at Bharatiya Vidyapeeth Medical College. Sir has a lot of research papers to his credit, and he has two patented publications on herbal formulations for diabetes mellitus and a medicine which can be used in dengue fever. I welcome Dr. Shinde for our next talk.
Good afternoon, everybody. I am myself Professor Dr. D.L. Shinde. I am working since last 31 years at Bharatiya Vidyapeeth, deemed to be university, as a professor in medicine department. In Ayurveda, we write it as an Kaya Chikitsa, that is internal medicine. Also, I am HOD there, and last like 31 years and more than that, in staying hospital only, I am serving the hospital over the years. Today we are going to see the Ayurveda management in one of the important diseases as an senile dementia. Rather, towards Ayurveda, we never see it as an alternative medicine. We are trying to prove it, to make it evidence-based as a first-line therapy, and the use of Ayurveda in the general population or common population. Just we are trying to make it very popular. Now regarding dementia, as the audience group is heterogeneous group, I would like to brief in short. Like dementia defined as an acquired deterioration in cognitive abilities. What are these cognitive abilities? That thinking process or analyzing it. So that is impaired. And as we know, like once the cognitive impairment is there, it affects the daily living or activities of daily living. So memory is the most common cognitive ability that is affected. In Ayurveda, specifically the Vardhakya-janya vikar or geriatric disease, they have been defined. And as we know that in geriatric or in geriatric persons, like 5 years impairment is there, like intelligence, immobility, inactivity, incontinence of bladder, bowel, then iatrogenic drug reactions. In all these areas, like specifically intelligence impairment and memory impairment, that leads to like this senile dementia. Like it is neurological disorder in global, which results in global cognitive impairment, personality changes, and functional impairment. As we know, it was first recognized by German psychiatrist Alois Alzheimer in the disease again defined as an Alzheimer disease, or we write it as an senile dementia. Like senility or geriatrics, we take the age more than 65 years. In Ayurveda, there are some classifications as age advances above 70. All these class people or age group is considered as an Jara Vyadhi or aged persons. Now, this disease is very common. It accounts for 60 to 80% in the elderly. In Ayurveda, the dementia we correlate it is an Smruti Bhransha, then Smruti Nash, particularly in this Vardhakya-janya vikar or geriatric disease. Now, Here, causes of dementia, I would like to discuss. Why I'm just discussing this? Because n number of conditions, they come under the dementia. So some causes, they are reversible, some causes are irreversible. As age advances, it becomes irreversible one. Still, dementia, Alzheimer disease, senile debility, dementia with Lewy bodies, frontotemporal dementia, Huntington disease, Parkinson disease, and I would like to say the neurodegenerative disorders, particularly Parkinson disease, then motor neuron disease like conditions, we are treating at Ayurveda with integrated approach. So this Ayurveda treatment or treatment modalities may be very effective in all these conditions. Whereas structural brain problems is our again specialty, sir. Like multi-infarct dementia, like stroke conditions, cerebral vasculitis, subdermal tumors, NPH, metabolic conditions, uremia, liver failure, particularly alcoholic patients, then toxic conditions, lead mercury poisoning, then common conditions we are knowing is vitamin B12 deficiency, thiamine deficiency, nicotinic acid, this is like pellagra, here the dementia is very common. Then in traumatic conditions like Boxer dementia, head injury conditions, infections like Creutzfeldt-Jakob disease, that is disease caused by the prions, is one of the very smallest microorganism. HIV infection, HIV dementia, HIV neuropsychosis, one of the critical conditions, and we have to treat such conditions also because HIV patients are crippled and particularly they present with dementia. Neurosyphilis, syphilis, gonorrhea, like conditions like tertiary stages, neurosyphilis is one of the commonest conditions. And no doubt endocrine disorders, they are very common in general population like hypothyroidism, hyperthyroidism, Cushing syndrome, then adrenal insufficiency or additional disorder, adrenal crisis sometimes is present with such conditions. Then most cases they are sporadic, like to find out the etiology and pathogenesis. No doubt I said the disease presents more with 65 years old. Then there are some mechanisms. Actually, I would not like to go into the details pathogenesis, but the why I'm going to say this, like microtubules, there are microtubules and they stabilize the neurons particularly, but when there are degenerative changes, the particular kind of protein like tau, it leads to neurofibrillary tangles and the microtubule disintegrate and the neural conduction affects. Ultimately, it leads to this Alzheimer disease or like senile dementia. Now, what important thing we have to remember and how to identify this condition is one of the important thing. Like sometimes the people are like, they are not accepting the things, like there is dementia or this forgetfulness, smriti bhransha or like conditions. Now, patient present with progressive memory loss, decline of other higher mental function, that is memory, intelligence, cognitive function impairment, decline in language function, it also manifests in difficulty in naming, then getting the memory. Patient may also present with apraxia, that is inability to carry out skilled motor activities. Skilled motor activities that comes like daily activities, like for example walking, going to bathrooms, eating habits. In advanced ages, patient cannot walk, feed themselves or do any other activity related to daily living. Then importantly, patient become incontinent, like bladder bowel incontinence, and the condition again worsens. Here the mini mental status examination we do, that in all the psychiatric people and psychological analysis, like 5-point analysis that is done and the patient is diagnosed. Like in Ayurveda, we simply remember man, buddhi, indriya, mastish, brain, and correlation, that ultimately the mind is affected and leads to memory impairment or decline in the cognitive functions. So mind, buddhi, indriya, mastish, ultimately mind is in the body. So one healthy mind in healthy body, that is what concept we are following. So simple investigations may be needed like blood test, complete blood count, thyroid function test, serum calcium, LFTs, importantly vitamin B folate or vitamin B9. No doubt, again vitamin B12, then thiamine, that assessment is important. CT scan, MRI may help as it may show the cerebral atrophy, and that may lead to impairment in the cognitive functions. Other examination may help like EEG, then CSF examination. Sometimes brain biopsy may help, and we may come to conclusion along with all this physical examination. Now, as in modern medicine, management comes mainly supportive, that is physical, mental, moral support. Rather in disability, it is named as an rehabilitation, like social, mental, physical kind of rehabilitation that helps. Treatment with antioxidants, that comes particularly vitamin C and vitamin E. No doubt in Ayurveda we have this good kind of antioxidant drugs and simple herbs which help or which helps rather as an antioxidant therapy also. Rather the cholinesterase inhibitors like donepezil, rivastigmine, galantamine, they may help to somewhat extent in improvement in the cognitive function. Also, the drug inhibit acetylcholine esterase, ultimately increasing the acetylcholine levels and thus improvement in the memory. And to some extent, the drugs may be helpful. Now, there is need for Ayurveda intervention. That what point I would like to stress today. Now, what general principle management comes in dementia, particularly with Ayurveda, how we look towards a disease. Basically, Jara Vyadhi or geriatric, we take it as an Swabhavik Vyadhi, that nobody is responsible for this. It is the aging process, one can't avoid it. So it is law of the inverse, that inheriting nature that cannot be changed. Still, early identifying this condition or prevention of aging or anti-aging medicines or anti-aging Ayurveda remedies that may halt the aging and the patients and the people are rejuvenated. That is what our approach in treating and dealing with such conditions. Now, here we see both the structural and functional changes. In Ayurveda, we write it as an Sharirik and Manashik Bhava. Sharirik, that is anatomical deformities, and functional, that comes physiological functions. When these two impairments are there, like the medicines particularly we use, they help in improving rather the functional changes, particularly in such conditions. Then we consider Vat as a particular dosh. Like as age advances, Ayurveda is three dosh Siddhanta theory, that is Vata, Pitta and Kapha. As age advances, it leads to increase in the Vat. So specifically Vata Nashak therapy or treatment that helps, and that particularly comes with mostly the oils and the ghee. Ghee is that is common cow ghee or the different kind of oils that we are using. Then also memory loss in illness, basically that mimics or that presents like two kinds of disease in modern medicine. One we write it as an unmat, so schizophrenia-like conditions, one side, and second as an apasmar, that comes as a generalized tonic-clonic seizure. So these two kind of disease presentation we may say in such disease or this dementia-like condition. Thus, administration of rasayan therapy that comes as a rejuvenating therapy, Medya Rasayan, which will improve or help in improving the brain functions, and Achar Rasayan. Achar Rasayan is what to do, what not to do. That is what we may say it is an ethics or code of conduct everybody has to follow, and rather not only old age persons, since our livelihood or since childhood we follow this. Rather in Ayurveda it comes as an Ashtang Yoga, Yama, Niyam, Asana, Pranayam, Pratyahar. Ultimately this will help for the longevity of life, and we think that a person may live for minimum 100 and more years. That in Ayurveda it comes as an Shatayushi Bhava, Dirghayushi Bhava. So to avoid dementia or process of aging, one should think since childhood or at earlier ages rather than to treat at the old age. That is our theme to understand this disease. That comes as an Achar Rasayan. Then to control Vata symptoms, what we have to do, we have to see the strength of the individual and strength of the disease. So here to control the Vata, simple Snehan therapy or massage therapy, that is simple application of oils, that may help to control the Vata, rather particularly Sharirik Bhava or anatomical way. Then few of other symptoms, as we know, like in geriatrics, a particular symptom, for example, a patient is presenting with cough, that may not be related with respiratory system. So cough may be a symptom of like other system. It might be related with other system. So these kind of symptoms, they may be treated rather with simple medications or Ayurveda therapies or Ayurveda modalities. This is what we define as an, in Ayurveda, it is simply mentioned as an Vata Vyadhi Chikitsa. So whatever the treatment they have given, that purely controls the Vata and help in halting the increase in the Vata dosh. Then next, Snehan in Vardhakya. Snehan is what? Increasing the Sneha Gun. Basically Ayurveda thinks that it is the Shirastha Tarpa Kapha. That Kapha is like simply, you may say, Kapha Guna. It is like sticky in nature, then it joins. So as advances, the Tarpa cup comes down, and rather it leads to impairment in the Sneha Gun. Sneha Gun is what? For example, I am talking very nicely with you, that is Sneha Gun. I am irritated, I am crying at you, that Sneha Gun has come down. Where the skin is dry, patient is complaining constipation, that Sneha Gun has come down. It is not only the 5 sense organs. What are sense organs? Ayurveda says it is an Pancha Jnanendriya. I am looking, I am thinking, then I am hearing. So there are 5 sense organs. If there is impairment in this function of these 5 sense organs, when the Sneha Gun comes down. So what do we think here? Just increase Sneha Gun. How will you increase it? By giving, for example, like that kind of drugs, Gruta, Taila, then just talking very nicely with patients or people, that Sneha Gun is increased. Thus, particularly the ghee of cow, that may help to increase the like power, then complexion, our sound, then the memory, smrti, medha, that is comes buddhi. Simply cognitive impairment in Ayurveda, it comes as an Dhi Dhruti Smrti. So Dhi Dhruti is thinking power. Ultimately that leads to smrti and buddhi and smrti. So that impairment, that can be corrected with simple therapies like giving the gruta. Then Brahan therapy we give, increasing the oj and Brahan therapy. What is Brahan therapy? For example, a person is cachetic, old age particularly, the patients are cachetic, they are unable to do the daily activities. So we do here, we give Mausa Rasa, that is non-vegetarian soup, if patients can take it. Then a Kshira, that is Dugdha, sugar, Guruta, and the food or the medicine which is sweet in taste, that is Madhur in Ras. So ultimately that helps in increasing the oj and will help in increasing this Sneha Guna, and thus there will be improvement in the cognitive functions or the function of the 5 sense organs. That what comes Gurta therapy. Then Abhyanga, Nivrutti, one mental pleasure. Let's say patient how he gets the happiness. That may be simple things. For example, moving in the nature. Sometimes he may say, like I want to see my village, or whatever the best things they come. And Harshan, what Harshan? We have to see that these people and these persons, they may remain happy always, whatever the kind of like not treatment but other activities needed, we have to do this. And importantly, here comes the Panchakarma therapy in Ayurveda. Panchakarma now it is very popular and most of people they are knowing this. But here particularly the Pratimarshan Nasya, that is oleation therapy. So 1 to 2 drops of oils or simply the medicated ghee. They come as an Brahmi Gruta, Panchagavya Gruta, Purana Gruta. Now there is tradition that we take, for example, ghee of cow, we keep it for 100 years. It is thought that today I keep it, it may be helpful for our next generations. And this to be used in all these conditions, which will help our memory, intelligence when we do the oleation therapy, that is putting these drops in the nostrils and taking it orally also. Then another one comes the Yapan Basti, that is medicated enemas. Medicated enema that comes with again simple therapies containing these enemas come with milk, then meat soup, or that helps to nourish the health or nourishing the people or the persons. So as old age persons, they may not tolerate the very, you may say, strong medications. The simple this may be very useful. Also Madhu Taila, that is simple medicated enemas. We are knowing the honey and Taila, that is Tila Taila, or any other kind of oils, sesame oil, or any other kind of number of oils and medications they come, but they may be used as a daily practice for medicated enema. That helps to low down the vat and increasing, as we think in Ayurveda, Sneha Gun, ultimately it nourishes the brain. Then particularly as in the beginning I said that there is 5 eyes impairment, and we say or we think this Vata dosh or Vayu, it remains with the Asti Dhatu or bones. So that kind of medicated enemas that associated with some particular medications and Gruta and Taila, that may help to halt the further deterioration. Then some kind of omitting or emetics we give, but in old age person or these persons it may not be possible. But still wherever necessary, what the theory here is, the avaran or we do simple the purification therapies prior to administering the rasayan or regenerating therapies. But in old age person this may not be possible to admit each and every like modality as the strength and memory of this patient is lost, but whatever best possible that can be adopted. Then Nasya, as I am showing this Pratimarshan Nasya, that is simply putting oil or ghee 1 to 2 drops only in each nostrils in the morning, in the afternoon, the as per our time schedule, and dosha samprapti. And this is Shurabasti. Shurabasti is simply we are doing in our stroke conditions, just putting the oil overhead for half hour, for 15 minutes. And our theory is likely, like in modern medicine, we are knowing the Valerian degeneration. We think these oils and Gruta, they may help to regenerate the neurons to some extent. This Valerian degeneration can be altered. This is our thought, and this therapy we are using in a number of other disease conditions along with dementia and geriatric patients. This is also Shirodhara, that is very common, which calms the mind, leads to good sleep, relieves the stress, and likely improve in the cognitive functions. But again and again, repeatedly, we have to do these procedures. Then Rasayan Chikitsa, this is what I want to stress. What is basically this? Ayurveda says, Yat Jara Vyadhin Vinashanam. What is the Rasayan Chikitsa? Which destroys the, like Jara Vyadhi, the disease they are associated with geriatrics, and they work as an anti-aging. So anti-aging means rejuvenation. They do the rejuvenation. How they do the rejuvenation? There is one theory in Ayurveda that whatever we eat, for example, today I had a dinner, lunch, whatever it is, or whatever I eat, that turns to good ras, then rakta, maus, med, asti, majja, and shukra. Shukra ultimately will turn to oj. Oj is, as we see, the divine aura. And in all old age conditions, we see this oj as oj comes down. So it rejuvenates this rasayan, ras iron, that ras comes the first element after diet. It rejuvenates all the these basic 7 elements. Ultimately, it leads to good oj, that is divine aura, and patients are recovered. That is our basic theory. Then how it helps? It helps to attain longevity, then memory, medha, arogya, tarunavaya, one feels like as a younger person. Prabha, Kanti, Ayurveda says like good complexion. Then it increases the sense organ functions and number of other things. Rather, at the terminal stage of life, these theories may help. One important thing I would like to stress here, that as old age is unavoidable situation, but the complications can be corrected with this rasayan therapy, one thing. Second, to prevent the complications and old age itself, we have to start this therapy at very earliest. For example, we should not wait that I will be at 70 and I will wait for the memory loss and then will think for this theory. So that may not be possible like this. As this comes true with number of modern medical diseases, as I would like to share one important disease like metabolic disorders like obesity, triglyceridemia, hypercholesterolemia, then pre-diabetes, diabetes, hypertension, which is nowadays killing the person, which is very risk for cardiac disease. So just prevention, and taking cognizance of all this, that what comes importantly with this rasayan therapy. Then there are a number of rasayan. Why I am like elaborating this? This may be very helpful for like to make it popular. The simple medicines we take it for a longer period, like with guidelines 1 year, 2 year. We advise like simple medicines. They can be given for a longer period, and it helps in halting the like aging or anti-aging. They work as an anti-aging. Then how it helps, benefits, there are some importance and benefits of this rasayan, and they are likely, it simply means, it all means, it it guarantees long life. Ayurveda says like Shatayushi Bhava and Dirghayushi Bhava. It is not only that we pray in, we pray for our longevity of life. That is what achieved by these kind of medicines. Then next comes the Medhya Rasayan. Medhya Rasayan that particularly works on the brain. That it emphasizes particularly on the psychological aspects. Then longevity of life, it augments intellect and nullify the disease. This one important thing like Rasayan and Medhya Rasayan. And there are 4 drugs I would like to elaborate here. One is the Shankapushpi, it is convolvulus pluricalis, St. Madhu, commonly we are knowing, Guduchi, Banduk Parni, Brahmi we are might be knowing, as some market preparations are also available, like Brahmi Gruta, Brahmi Swaras, Shankapushpi Swaras, Saraswatarishta, Swarna Saraswatarishta, number of other medicines that are available in the market, and we are on daily basis we are practicing this. Importantly, I would like to write about the Shankapushpi. It consists of acetylcholine. Thus, it consumption you have to increase the levels of acetylcholine in the brain. Now, all over the world, the research is going on the simple herbs. We are also trying to make it evidence-based while practicing in number of patients and making data of that so that it can be make more evidence-based. Then Brahmi, Vekhanda, we were knowing this Amalki, Avla, they are work as an best Medya Rasayanas. A number of Medya Rasayanas they are there. And one important thing I would like to present as an Achar Rasayan. Achar Rasayan is a simple thing like do and does not do, like. So do this, don't do this. That what comes as an ethics or code of conduct in our day-to-day life that helps to calm the mind, to have good memory, intelligence. That is our theory, and everybody should follow this. For example, not getting anger, being truthful, speaking only truth, abstinence from wine, sex, whatever the best theories come in Ashtanga Yoga like Yama, Niyam, Asana, Pranayam, Pratyahar, Ahimsa, whatever the best we have to find. Like. Then Sattvaja Chikitsa, that is again psycho-behavioral therapy, and in all psychological psychiatry disorders, the psycho-behavioral therapy is needed. Here we give the psycho-behavioral therapy, that is avoidance of anger, aswasan chikitsa, you will be right, don't worry, etc., etc., whatever the best assurance therapy. Like. As we know, this is very common that we assure someone he is happy with us and one can achieve the best goal. Harshan, then Vishampan, and whatever the best, like, yes. Okay. Then encouraging the OJ, I already told, Rasa, Rakta, Maus, Med, Asti, Majja, Shukra, and finally OJ. So that OJ can be corrected with simple medications like milk, ghee, then soups, and Madhur Rasatmak Dravya, that medicines which have this sweet kind of taste, and in Ayurveda we write it as an Vipak. So they can be administered on daily basis. One important thing or the concept I would like to give is this Kaya Kalpa. This Kaya Kalpa is basically referred to the body and metamorphosis. So it is ancient strategy to transmutation of the body rejuvenation. That comes again the simple theories using mineral medicines, rules, regulations of daily living, dietetic regulations. Basically, Ayurveda considers or relies on three things: ahar, whatever we eat. There is one good shlok: ahar sambhavam vastu rogasya ahar sambhava. Whatever we eat, that turns to a disease process, and that disease can be prevented with kind of particular diet. So that is our theory. Then behavioral modifications, living in accordance with the nature, purification, yogic practices. Ultimately, it will give us longer life. So finally, to conclude, in neurorehabilitation, particularly diseases like this dementia or Alzheimer disease, smrti bhransh, smrti nash, these panchakarma therapies will help, like in the form of giving sneha, doing panchakarma therapies, yoga, meditation. Then Ayurveda as a treatment, as nootropic drugs which will improve the cognitive functions, Medya Rasayan, brain exercises, simple intelligence memory, and simple panchakarma procedures. On preventive aspect, since our early life, we do adoption of good behavioral conducts, that is what Achar Rasayan. It should be taught in the schools and since childhood, just behave like this, follow this regimen. That will help in halting not only rather brain and related diseases, but a number of other diseases. Then timely intervention of lifestyle disease, periodic intake of Medhya Rasayan, that is the simple brain tonics, and active involvement in intellectually stimulating activities. Thank you, Raj. I would like to appeal, so let treat with Ayurveda medicines, come some, come all, treat with Ayurveda. Thank you very much.
Thanks a lot, Dr. Shinde. You mentioned about harsh, and that's exactly how we feel on listening to such innovative concepts that are available even in Ayurveda, and it will definitely be helpful in our practice. Thank you so much, sir.
Question answer?
We'll take the question answers after the next speaker.
Okay.
Yeah. I would now like to invite Professor Professor Vithoba, Associate Professor in Mental Health Department of Psychiatric Nursing, Goa. Sir is a prominent mental health professional with extensive qualifications in psychiatric nursing and in emotional intelligence.
Thank you, sir.
He has been recognized with awards like the India Prime Quality Education Award and the ASK-MI Innovation Award. He has studied extensively about emotional intelligence, and he shall share his insights with us today.
A very good evening to all of you. At the onset, I would like to thank ARDI conference for calling me over here. It's my proud privilege to be over here. And what I'll be dealing with, like the last session of the day, you might have a sigh of relief also, caring for dementia and emotional intelligence approach. Basically, what we'll be seeing in this half an hour is like how we can use emotions and emotional intelligence in caring for dementia. So as sir was rightly saying, dementia is a syndrome where there is a progressive deterioration of symptoms and all. And over a period of time, if you see the deterioration that is happening is in personal, family as well as societal life. And what happens? Give me a second, I'll just see. Then it becomes a daunting task to care for people with dementia. And we always focus on the 6C. We say like there should be care, compassion, courage, commitment, competence, and communication. So when we focus on this 6C, we have to identify that when we study emotional intelligence, they are the facets of emotional intelligence. So when we actually build upon that, emotional intelligence as a construct, what happens is like we are building on these attributes also. So what we have to see is like how we can build upon the EI. Now it is a bilateral thing. We also have to see the client and also ourselves. But primarily in this 30 minutes, I'll be focusing on what we can do, how we can be very effective in dealing with emotions, understanding our emotions as well as emotions of others, and how we can be effective caregivers also. So are emotions really important? The question is for the audience. Do you feel emotions are important? Everybody? Yes. And famously Carl Jung had said, there can be no transformation of darkness into light or of apathy into moment without emotions. In a nutshell, if I say, zindagi ka patta bhi nahi hil sakta hai emotions ke bina. So emotions are that important. So if emotions are that important, and if you are caring for a person who is losing on that front, okay, with his cognitive symptoms, memory and all, then the role of understanding that person, role of understanding yourself first becomes very, very important, okay. And let me put across some of the thoughts on emotions so that I can make my ground very clear and very strong. So if I say emotions, emotions are mostly internal as well as external, isn't it? And basically when we show outside what output that is there in our interaction or communication, that's emotional output. So we have to be very careful about that emotional output when we are caring, because that will give a lot of messages, isn't it? So basically we have to understand that there are various paradigms about, there are various thinking part about emotions, and that we have to clear. And what are those? Those are first and foremost when eventually emotional intelligence was evolving in the 1990s, when Daniel Goleman was studying about it, Peter Salovey, Mayers was studying about it. They were working on that and they found these paradigms. Okay, when I say this, you have to say either yes or no. Okay, first is the old paradigm, emotions get in the way. Yes or no? Yes or no? Time is precious, so we'll give responses very fast. You can say no also. We can have a clarification on that. Yes, emotions get in the way. So if you see, I will just give not related to the dementia sort of, but I'll give you a general example. If I'm in a relationship with somebody, okay, and it is going on toxic now, I want to leave that person, okay, and people are also advising me to leave her, okay, but then I'm recollecting the memories and saying like she has done that for me, that for me, that for me. How on earth can I leave her? So I stay in that toxic relationship. That means the emotion of care is overpowering your decision to take a decision, isn't it? That's the power of emotion. Second, emotions make you less effective. Yes or no? Can I get some water, please? Yeah. Emotions make you less effective. Yes or no? Here I can actually accept yes, no sometimes. It depends on how we take it. I'll stick to the same example. I was deeply in love with somebody. That girlfriend has ditched me. So it can make me less effective or more effective also. I can take a view and say, everything is lost, my life is gone, I should commit suicide. That is making you less effective. But I am saying like, oh, she has gone, but I'll make her repent one day that she has made a mistake of her life. That is making you stronger. That's the power of emotions. Third is, emotions have to be suppressed and rejected. Yes or no? Absolutely. A round of applause for that thing. Round of applause. Lovely. Emotions should never be suppressed or rejected. Why? Everybody might be doing rice, isn't it? You're having a pressure cooker at home. So how do you make rice? I know the recipe because I'm married, okay? So now, you take a pressure cooker, okay? Put some water in that, you put rice. Some people add salt also, isn't it? Then we put a lid to the pressure cooker, we put it in a gas stove. How do we know that the rice is done? Whistle, then it is a duplicate pressure cooker. Something else also has to come. The steam, isn't it? So the steam and the pressure has to come. We tell our children to count it, isn't it? They're telling mommy 1, 2, 3, 4, and the rice is done, isn't it? Now take this scenario. What if the whistle and the steam had not come? What would have happened? Burst is the last thing. First, the rice would have turned black, isn't it? And still, if the steam is not coming and the whistle is not coming, the cooker will blast. And this is the most precious cooker in the world, ladies and gentlemen. Most precious than Hawkins and Prestige. If you're not taking care of this, there is no steam and whistle coming, one fine day we'll have a psychological breakdown. That's how emotions are important. That's the importance of emotions. Okay? Next is, emotions make you weak. Yes, no, sometimes, isn't it? I can take that from you. Just an example, I'm having an only son. He has done something nasty. He has broken the pot or something and he's running, and I'm running behind him with a big stick. Immediately I recollect that he's my only son. If the stick falls on his head, I will not have my son. So I immediately change the decision and I hug him, isn't it? The emotion of anger was weakened by emotion of love, isn't it? That's the power of emotion. The take-home message from my session, because it's only half an hour, if you are today going with the sense that emotions are very important, I am successful. Last is, emotions interfere in your decision-making capacity. Yes or no? Yes. Whatever decision, if somebody said no, we can have a discussion afterwards because there's no time. But what I say is like, whatever decisions we have taken, it's on the basis of emotion. Coming over here for this conference also was an emotional decision. Maybe because you'll be meeting somebody, it's a get-together, it's after 1 year, it's multidisciplinary. Many things would be there, isn't it? So it's always an emotional decision. I'm not done as yet because I know you need more proof that emotions are important. So I'm going to the new paradigms now. The new paradigms over a period of time said emotions carry data and information. Yes or no? Yes or no? Everybody chatting now. Isn't it? We are having a mobile phone and we are chatting across 7 seas in USA and all. And suddenly from that side a red emoji is coming. Not the heart one, the other one. So what do you recollect? You recollect that Saat Samandar Par koi gussa ho gaya hai, isn't it? And immediately you say sorry or you wind up the conversation. You do that, isn't it? See how strong, that is a virtual communication, ladies and gentlemen. It's so powerful. Then we are along with people, then how vigilant we should be in our communication. That's the power of emotion. We have been taking it very casually over a period of time. I'm not saying you, but over a period of time, the general view is like, emotion chalta hai yaar, hota hai yaar, but we have to give due importance to that. Next is, emotion and learning can't be separated. If I ask you a simple example to give, sir, if I ask you a question that, tell me your favorite teacher, okay? And why is she or he your favorite? Immediately a name will pop up, isn't it? She will say X teacher. And why? Because she was loving, she was caring, her classes are wonderful, she was understanding. All these things she will tell. Then I'll come to you, ma'am, and I'll say like, tell me a name of teacher jisne zindagi haram kar di thi. Immediately a name will pop up, isn't it? She was very strict, she was like after my life. But I'll ask you, whether you learned over there, you learned over there also. Whether I ask you if you learned over there, you learned over there also. It's up to us what type of environment we want to create. A negative environment or positive. Positive will be sustaining for a longer period of time without symptoms. Next is, emotions are real in the form of neuropeptide. Just because I am shouting over here, emotions are important, that doesn't mean emotions are important. They are really in the form of neuropeptide. That's why we should be careful about it. Next is my personal favorite. Emotions are non-biodegradable. What does that mean? क्या होता है non-biodegradable? मैम क्या होता है non-biodegradable? Okay, इसको खारिज नहीं कर सकते. खारिज नहीं कर सकते. जिसका decay नहीं होता है, वो रहते हैं. Let me give an example. I am happily married and mine is a love marriage. It's 16 years for our marriage. Before marriage 8 years and after marriage 8 years. Now whenever we fight, the ladies have a photogenic memory, isn't it? So whenever we fight and I am having a good argument also, I cannot win the case. Because when I come with that Brahmastra, she's also coming with the Brahmastra. What she's saying? Same thing you had said to me 2 years back on a Tuesday at 2:30 p.m. I had said sorry that time, but that has not worked because it is in the subconscious mind. That's the power of emotions. They are non-biodegradable. And finally, the most wonderful statement of emotions, that is, emotions are contagious. They are more contagious than coronavirus. For corona, we had taken n amount of precautions, isn't it? But are we taking up with our dealings with people? That's the dodgy question, isn't it? See, if I had come over here and I was standing over here and saying like, emotional intelligence होता है, ऐसा कुछ होता है, emotional, आप सब बोलते मन में मन, इसको भगा दो यार, किसने लाया इसको, isn't it? See, immediately a perception has been made, basically on your look, the output that you are giving. See how vigilant we have to be in our day-to-day life. I'm coming over and saying, good morning everybody. Then soye hue bhi jaag rahi hai, kya ho gaya idhar, isn't it? That's the power of transfer of emotions. That's why we should be focusing on emotional intelligence. I'll be making my case more stronger also with as the slides are passing on. Next is, then what is emotional intelligence? What is EQ? Emotional intelligence, the ability, capacity, or skill to pursue, assess, and manage emotions of oneself, others, and group. So basically, primarily you are understanding yourself, and then you are understanding others. So as a healthcare professional, you should be understanding yourself, and then we can put our foot across and say like, okay, let me handle the case. Without understanding myself, I cannot do that, isn't it? So basically, self-care comes into forefront. Self-care is important. So as caregivers or professionals, we have to be understanding ourselves first. If you see philosophically the statement says, EQ is to the heart what IQ is to the brain. Okay? हिंदी में बोलते हैं हम दिल से सोचो यार, वो दिल से सोचना ही मतलब EQ होता है. Rationality होना चाहिए, नहीं होना चाहिए ऐसा नहीं है, but then there should be a touch of emotion to that, whatever we are doing. So basically, why I'm talking about emotional intelligence approach, because these are the models which are talking about it, the scientific way. This is the ability model of emotional intelligence, which was given by Salovey and Mayers, where they had given these 4 quadrants, and they say like, you should be perceiving the emotions correctly, okay? Then you should be using emotion to facilitate your thought process in aligning way, then understanding emotions, and then managing emotions, both yourself and others. Wonderful model. I cannot explain in detail over here because of time constraint, but what I'll say is like, these 4 facets are wonderfully explained as to why we should be caring for our emotion as to give great care to others. The next model, which is very fascinating, is the Goleman models of emotional intelligence. Daniel Goleman is said to be the father of emotional intelligence. I would suggest you all to read one book if you have read, well and good, Why EQ Matters More Than IQ. That's his book, okay, one of the best sellers. Okay, this model is also very convincing. It is also in 4 quadrants, where he talks about self-awareness, he talks about social awareness, he talks about self-management, and he talks about social skills. And then he is given the sub-classification also. In that, one of the very fascinating fact is like when you work on your self-awareness, you work on empathy, you work on communication, you work on anger management, your emotional hijack and all, that is how you can deal upon. So basically what I can say is like how I have developed a program called as EMOVAC. Now EMOVAC, it's a registered trademark program. The full form of EMOVAC is emotional vaccination. We are talking about DPT, polio and everything, isn't it? But we are not talking about vaccinating the mind. So what we can do is like we can vaccinate that. And it's a registered trademark structured program based on these models which I have developed. So similar way, small intervention, emotional intelligence based interventions you all can develop, where you can focus primarily on empathy, compassion, self-esteem, communication. These are the areas as far as dementia is concerned where we need an expertise, where we have to understand them, where we should be giving them the support which is needed. Okay, so this is about the model. Now basically why emotional intelligence is very important, because there are two fronts how it is useful. First, to build trust and support, and second will be ensure the people feel understood and valued. Do you feel that dementic over a period of time feel less valued? Isn't it? Over a period of time they feel हमें किसी की ज़रूरत नहीं, वो भी हो सकता है, memory loss भी हो सकता है. They feel like whatever the decision they were taking or activities they were doing, they are not able to do right now. So that raising the self-esteem is up to us. What we can do when we work with empathy, with social skills, with self-awareness, with self-regulation, and a lot of motivation, because it's a progressive illness, isn't it? So what we have to do is like a lot of patience has to be there, and when we develop on these qualities, we can actually give the best amount of care. Now the million-dollar question is, can emotional intelligence be enhanced? Yes or no? Do you feel it can be enhanced? That's the best part. If it was IQ and all, then we would have struggled because it's something static. Emotional intelligence over a period of time can be enhanced. And how it can be enhanced? There are 4 ways how it can be enhanced. First and foremost, do you feel it increases with age? Do you feel your parents are emotionally intelligent than you? Yes. You took some example from them. Why? Because we are giving due respect to their age, isn't it? Whenever they tell you something and when we say no, they come with that million-dollar dialogue. What is that? हमने तुमसे ज़्यादा क्या देखे हैं? ज़्यादा दुनिया देखी है. That's what is over a period of time we learn, isn't it? Second is experience. Whatever experience it might be, bitter or sweet, it helps us to raise our emotional intelligence. Similarly, what example I was giving, I'm having a bad breakup, okay? And after 6 months or 1 year, I'm going into another relationship, I'm having a manual ready. What should be done and what should be not done in a relationship, isn't it? So that's the power of emotion. See, you are over a period of time with experience, you tend to learn also. Education, now this beautiful gathering which is there, okay? A round of applause for the gathering and for the organizer for this beautiful conference, lovely. I love the fact that it is interdisciplinary, okay? Education. And one very important thing which I am working all over India, and that is training. Through training we can enhance it. Whatever we do is like evaluation based, then we see like how we do assessment, and then the program is given, and over a period of time there are over a period of time 1, 2, 3 post tests we'll be doing, and we see like whether it has worked or not. And over a period of time, my master's research, my MPhil research, as well as my PhD research has been in the area of emotional intelligence, and I can tell you the statistics says that it's been effective in enhancing emotional intelligence. Okay, so this is about the 4 facets how emotional intelligence can be increased. Now what are the benefits when you become emotionally literate? See, educationally we are all literate, isn't it? Now we have to become emotionally literate, and when we rise our emotional intelligence, it's better, it helps us in handling stress. Because as caregivers, a lot of research suggests that caregivers go through burnouts. The professionals also have a tough time dealing with them. So then, handling stress, communication, how to improve communication, a peculiar communication where your words will be therapeutic to the patient, okay? So that also can be improved. Group dynamics, we are working with a diverse team, but if you are high on emotional intelligence, you can negotiate better. Then conflict resolution. See, being humans, it's bound to be there are misunderstandings, but how you will resolve it? It will be with the help of emotional intelligence. Managing feelings, both of yours and the output that is coming from outside. How you will be managing that? That also can be helpful if you are emotionally literate. Then decision making. Emotionally intelligent people tend to make better decisions. That's what research suggests. Then self-awareness, the most important facet of emotional intelligence, where you become aware of yourself first, And finally, it gives you a sense of identity. That's the benefit of it. Now, let me discuss some two strategies because time is less. Two strategies which I think if you are doing it well and good, but if you implement, it will be a sea change in your approach towards life. First and foremost, we have to work on self-awareness. That's what Daniel Goleman's model also is saying, okay? Because as Aristotle said, knowing yourself is the beginning of all wisdom. So if I ask you, do you know yourself? You might be in a dilemma, isn't it? अरे मैंने अपने आप पर कभी काम ही नहीं किया. Patient तो मैं 100 देखती हूँ दिन में, लेकिन अपने आप पर काम नहीं किया है. That means we are not focusing on the most important area, that is us. So self-awareness becomes very important. Now self-awareness, what is it? It is like understanding your likes, dislikes, your strengths and weaknesses, how your decision is being influenced by your emotions. Are you in control of your emotions? All these things come together and they are called as emotional self-awareness. So basically what happens when you are self-aware? The primary thing is when you are self-aware, when you know about your strengths and weaknesses and when you know what are your likes and dislikes, it is helpful in a multiple ways. First, when you start working on self-awareness, it will make you, it will help you identify your strength and your weaknesses. अरे मैं इसमें अच्छा हूँ, मैं इसमें अच्छा नहीं हूँ. Okay, I'm good in coordinating, I'm good in leading, but my anger management is not good. My stress management is not good. So you are identifying the factors and then you are consciously working on that. And your negatives or weaknesses which are there, over a period of time, they become your strong point. That is how, if I'm getting angry now and then, I realize that I'm getting angry, anger is my issue. Then I work on that, meditation, okay, time out, I will not react to situation, but I'll respond. All these strategies when I implement, then after 2 months or 6 months, I'm okay with managing my anger. That means I'm consciously working on self. So second, it will help us to set up realistic goals. Most of the unhappiness in life is because we are not setting realistic goals. If I stand over here today and I proudly announce, in the month of December, I am buying Burj Khalifa, see the reaction. I knew this reaction would come. Why that reaction is coming? Because they know what salary I am getting, what my forefathers might have given, isn't it? And he's dreaming about Burj Khalifa. Then by October, I am getting impulsive. By November, I am getting depressed. By December, I am having a total breakdown. Why? Because that goals were not realistic. So if you are self-aware, see, our yesteryear generations were very smart. सबके लिए कहावत बना के रखी है उन्होंने. इसके लिए भी कहावत बना के रखी है. जितनी चद्दर उतने ही क्या करने चाहिए? That is being self-aware. They are not telling you don't be ambitious, but जितनी चद्दर है उतना पैर फैलाओ, पहले relax रहो अपने में. Okay. Third is help to shed all the inhibitions. Most of the time we are not able to perform because we are in a dilemma whether I'll be able to do or I'll be able not to do. Because you are not worked on yourself. If I worked on myself, even if you tell me to dance over here, I'll dance. Because I know I'm a bad dancer, but people will laugh. I've come to terms. That is important. Working on yourself. And age is just a number. We can start from any point. Okay? Help understand own behavior. Many times we are not understanding what we are doing. So basically we have to realize whether I'm going in a correct way, my emotional responses are okay or not. That will come when we become self-aware. Then help recognize other people's needs and feelings. Again, just because we are healthcare providers, healthcare professional, our major role is understanding the client also and the family also who will be going through a tough time. It might be a consultation of 1 hour or 2 hours for us at the most, but they have to stay with that client for a lifetime, isn't it? So when that happens, we also have to tell them, okay, this self-awareness will definitely help you. Why I'm telling you this? Because we can also implement, we can also tell the caregivers of patient also to follow that. Now how to do that? This is one way we can actually enhance self-awareness, which is called as SWOT analysis. Everybody might be knowing. This is not related to any company now. It is related to you, the best company in the world. Okay? Work on your strength, work on your weaknesses, work on your opportunities that you have, work on the threats that you are having, and see how you are growing. Just take a piece of paper, make it into 4 quadrants and write down what are my strengths, what are my weaknesses, and you'll be surprised to know that you never recognize that this is my strength. Oh, that's my weakness. This enlightenment happens when you start working on yourself. Other things would be like keeping a journal or something. Okay? When you write down, you know where you've gone right, when you've gone wrong, and over a period of time you can change yourself. So the diary itself can be a life-changing thing for you because you know what should be done, what shouldn't be done. Write down your goals and prioritize them because emotionally intelligent person will always have a plan. That plan is very important because that will not give you stressors. That backups are also there. Perform self-reflection or self-talk. That is another way where we can ventilate. Some people are there, जिनकी CT भी नहीं आ रही है और STIM भी नहीं आ रहा है, isn't it? And they don't rely on other people also. They'll say like, Band mutti lakh ki, khuli to khak ki. They might say that. So for them, this self-reflection is very important. You go in a closed room, see yourself in the mirror, and narrate whatever has happened throughout the day. क्या अच्छा हुआ, क्या बुरा हुआ, सब narrate करो. उसमें क्या हो जाता है कि आपका ventilation हो जाता है. जो आपका pressure बढ़ रहा था, उसमें CT भी आ रही है और उसमें steam भी आ रहा है. So that would happen. A powerful technique called as self-talk. And finally, if you want to improve over a period of time, professionally and personally, always have feedbacks from your near and dear one. And that too, I would say, I would highlight the thing, trusted ones. So what do you mean trusted one? Trusted मतलब क्या? विश्वासु, isn't it? जिसपे हम blind faith रख सकते हैं. Who will call a spade a spade? That is their peculiar quality. आपने ये अच्छा किया, that's good, you have done. But that was not good. I was not hoping from you that you will do that. Such people we need. And ऐसे लाइफ में हमारे 2 या 3 होते हैं, वो आइडेंटिफाई करना पड़ेगा. वो फेसबुक वाले भी सब वर्चुअल है, वो सच्चे फ्रेंड नहीं है. हमको अच्छे दोस्त जो 4-5 है या रिलेटिव है, वो हमको ढूंढने पड़ेंगे लाइफ टाइम में. Because that they will really help us to grow. But do we really like them who call a spade a spade? We are at times we are reluctant to meet them. अरे ये criticize करता है मुझे, ये अच्छा नहीं कहता. We like people who are roaming behind us with butter, Amul butter, isn't it? ये अच्छा किया, ये किया, तुम खाई में भी गिर गए, ये भी अच्छा किया. So then your improvement will not happen. We have to identify the trustworthy people, 2-3 people or 4 people in our life. I don't have, actually I do an exercise for this, but I don't have time. I ask for trusted people and then there's activity for that. But let's hope to see you sometime else whenever we meet, okay? And this is how we can actually, I'm more bothered about that 5 minutes, the reverse score which is going on, okay? Because I wanted to give a lot of things, but then sir, I understand you are tight, no regrets. Why self-awareness is the first important thing? Because it will give you the much needed clarity in life. Whenever I ask a question, especially for a young lot of people and all, life कैसे कट रही है? Sir, कुछ पता ही नहीं, life सब धुंधला नजर आ रहा है, आगे का कुछ पता ही नहीं. Why that is happening? Because you have not worked on self-awareness. You start working on self-awareness, you will definitely have a backup. You will have a plan. You will not get boggled down by simple things that are happening in life. That's the power of emotional intelligence. Start working on that. That's precisely what is very, very important. Self-awareness. Second, one more facet I will discuss and I'll stop. Second is open communication. See, listen to that word. I'm not saying communication. I'm saying open communication. It's not like 50% communication or 60% communication. It's like a communication where you are giving the message correctly, you are an active listener, and you are listening also correctly. That's a trait of emotionally intelligent person. We are not only saying. So this is an approach which I want to give you, which is called as a ruler approach. Now what ruler stands for? R stands for recognize. Recognize emotions in oneself and others. मेरे कोई भावना नहीं है, सब दूसरे लोगों को भी है, isn't it? So we have to understand that I also have emotions and others also have. Okay, second, understand the cause and consequences of emotion. अगर मुझे गुस्सा आ रहा है तो understand करो वो क्यों आ रहा है. बात करने से पहले, if I'm getting irritated by something, label that. Third thing is labeling. Label that emotion that I'm getting irritated and the cause and consequences of it. When you understand this, what happens is like you will be expressing emotions in accordance to the need of the hour. You will not get impulsive about things. And once you know that that is the correct way, then regulate it. You know in such a situation, this reaction is apt for that. So this ruler approach becomes a powerful medium to regulate your communication. So when you actually work on communication, you are actually positive about yourself. Your highs and lows you can handle. You can take better decisions to be proud of. You will be devoid of your anxieties, okay? And even if anxiety is there, you know how to manage that because you are a good communicator. Now in a nutshell, how emotionally intelligent person will communicate? First and foremost, listen to respond rather than react. What is the difference between response and reaction? What is the difference? Reaction is impulsive. Absolutely, that's great. Yeah, what happens is like over a period of time we have become human bombs. In the morning we get up and we tie that bomb to our belly and we go out, isn't it? Then somebody comes and wishes her, we are with that bomb. इसने कुछ कहा इधर फट गया, boom. उधर उसने कुछ कहा उधर फट गया, boom. दिन में 10 बार फटते रहते हैं. इसका who is having the trouble? Who is getting the consequences of it? You are getting, isn't it? If you are regulating your emotions in the proper way, you would have controlled that. as ma'am was rightly saying, even if situation is there where you are right, but the decision to respond is with you, isn't it? Right now I should be telling him or I should take a time out. अभी आप मैं तुमसे बात नहीं करना चाहता हूँ, 4 बजे मिलते हैं और उस पर बात करते हैं. You're walking out from that, isn't it? So that strategy still remains with you. When you lose our control, the end product of that would be guilt feeling. So basically, let's understand that we have to respond to situation rather than reacting. Second, recognize emotions and ventilate to the trusted one. So city आनी चाहिए और steam भी आनी चाहिए. Takeaway message today is like city and steam has to come. Understand the emotions in others also. And very, very important thing, why a lot of short circuits are happening, why miscommunications are happening, because we are not doing one thing, and that is clarifying. So whenever in doubt, see that you clarify. That is important. So basically, this is how we can communicate effectively. I think so, time is up, no? So this was another thing, okay. Yeah, I would like to tell about mood meter, okay. How much time do I have? This is reverse count is going on, isn't it? So mood meter. In COVID, we were dealing with lot of meters. उंगली को लगाए थे, क्या लेते pulse oximeter. बगल में डाल रहे थे हम thermometer. BP ले रहे थे sphygmomanometer. Today I am giving free of cost mood meter. Okay. This mood meter is a powerful choice. Okay, powerful choice in the sense like anything that is there. See this, there is a red quadrant, there is a yellow quadrant, there is a blue quadrant and green quadrant. If you see this side, it is negative emotions. Okay, if you see that side, those are positive emotions. Now any problem that you are incorporating or you are facing, you sit down and apply this mood meter. For example, just for the sake of example, if I am having an audit tomorrow and I am the chief presenter, okay, and I am getting all impulsive, I am not getting sleep. Now in the morning, okay, just sit with yourself and identify. Ruler approach bola tha maine. Identify what emotions you are going through right now. So let us identify. I might be feeling worried. Okay, एक emotion लेके चलते हैं because of the audit. ऐसा अच्छा होगा या नहीं होगा. And I am also feeling down. Okay, I'm feeling down about it and I'm feeling worried about it. ये दो emotions मैं बहुत worried हो रहा हूँ और मुझे down feel हो रहा है. बैठे हुए आप सोच रहे हो. Then you start asking question to yourself. ये पहली बार है क्या मैं audit present कर रहा हूँ? The answer will come as no. जितने भी ऑडिट प्रेजेंट किए कितने सक्सेसफुल है? अरे मेजॉरिटी तो सक्सेसफुल हुए. मेरे पास प्रेजेंटेशन रेडी है क्या? अरे पीपीटी रेडी है, मेरी टीम भी है, मैं क्यों टेंशन ले रहा हूँ? See now what is happening is like you're sitting, you're getting answers to the problems which are there. And when you know that अरे प्रेजेंटेशन भी है, मैंने पहले भी किया है, प्रेजेंटेशन तो मैं करता हूँ, मुझे स्टेज फियर नहीं है. Then from down and worried, you're starting a day to worried से तुम क्या हो जाते हो? Optimistic हो जाते हो. And from down, you're feeling restful. Tell me one thing, if you start a day like this, worried and down is better, or optimistic and restful is better? Which is better? Optimistic and restful. So give that time to yourself. Start working on yourself and start a day on a positive note. Every possible emotion that comes to you, you can just focus on that. With that, I would like to wind up. This is a nutshell how emotional intelligence can help us in giving good care, because we'll be good communicator, we'll build trust and rapport, because we'll ideally we believe in empathy, then being supportive, then help maintain social relationship, be aware of our body language, because as I told you, emotions are contagious. Take care of yourself, because self-care, self-awareness also is very, very important. Okay, with that, this is my conclusion, that we should be having, as we are taking care of the 4 R's in dementia, that is reassurance, routine, redirect, and reminiscence, we should be focusing on giving this small intervention. As I told you, I have developed EMOVAC. You all also can focus on different things and develop intervention and give caregivers. Know yourself better, talk with a trusted one, communication is the key, emotional hijacking is not the key. We have to respond to situation, work on your skills and hobby, be mindful, stay connected and share happiness. Lot of inputs can come when you stay as a team, okay? And finally, Akbar and Birbal were having a chat. And Akbar asked Birbal, what is that one statement that gives you happiness and sadness at the same time? Birbal thought for some time. And Birbal said, that particular statement is, these too shall pass. Ye waqt guzar jayega. So, 2 दिन आपने आज मजा किया, isn't it? You came over here and you had a ball of a time, isn't it? Remember, these too shall pass. And if you are sad today, down and out, want to give up on life, stay over there, because this too shall pass, ladies and gentlemen. Thank you very much for giving me time. God bless you. Thank you, sir, for inviting me over here. Had a nice time. Thank you.
Thank you for the energy.
Thank you. I'm still regretting 30 minutes.
So that brings us to the end of the last session. Quick questions, anybody?
Should I go down?
Let me. Thank you, Professor Vithoba, for such an emotionally powerful lecture. And thank you, Dr. Shinde, also, about how Ayurveda can have a holistic approach towards preventing and treatment of dementia. So now session is open for question and answer.
Can I take the liberty of asking one question myself?
Yes, yes.
For Dr. Shinde, sir, you mentioned about enemas, daily enemas. Can you just talk?
See, medicated enemas, basically that comes in Panchakarma therapy. Panchakarma. So Panchakarma comes like 5 kinds of procedures. We define it as an purification therapies, like Vaman, emetics, then Basti. Basti comes like, then oleation therapy. Basti comes again 2, like Astapan, Niroha, and like Anuvasan. So there are some other procedures. And Raktamokshan, the blood-letting therapy. So particularly in old age persons, these purification therapies or strong medications may not help. Particularly women is strictly contraindicated. So there are some guidelines, the indication and contraindication that we follow. But in old age persons, simple medicated enemas like with milk, for example, maunsaras or mutton soup like, then grutha, so they can be admitted on daily basis or simply oils. So that will be very useful. What is our basic therapy? That from the medicated enema, there will be good absorption from the lower intestine, and ultimately that will nourish all the sapta dhatu or the 7 elements in the human body, ultimately which will nourish the oj and the mind. It will come and will give us good kind of results. That is what the medicated enema on daily basis.
Thank you, sir.
My question to Dr. Shinde. We come across so many bed sores patients, in dementia, because patients are bedridden, bed sores are very common. So, I have come across one method where they are using banana leaves, dressing, what we call it, in healing chronic bed sores, which was not responding well to our routine dressings and all. Can you please add?
Sir, thank you very much, sir. I am working in hospital and disability area also. I myself spinal cord injured person. So bed sore is very common element, and in Ayurveda we write it as an Shaya Vrana. So bed sores. So simple medicated oils, they come as an Zatyadi Taila, then dressing with honey. Then there are some good medicines which will help in healing of the wound. So that we are likely admitting, and no doubt the banana leaves now people are using, and that is helping to heal the wounds along with some Ayurvedic medications.
Sir, good afternoon. My question is, allopathic medicine is used from the time of a person shows up to old age. Is Ayurveda is effective for dementia in such a person?
Please repeat the question.
Allopathic medicine is used from the time a person shows up to old age. Is Ayurveda is effective for dementia in such a person?
Yeah, surely. So what I told, so that comes more of preventive aspect, and rather we should not wait for dementia and likely old age. As we, for example, were working since childhood, we try to keep money in the banks, we take preventive aspect. Likewise, health-wise also we should have some preventive aspects and take care so that we should not be affected. That what comes intermittently, these panchakarma therapies, intermittent administration of these rasayan therapies, medya therapies, as this sir said, brain exercises, mental exercises, and these things help absolutely in every kind of patient.
Hi, I have a question for Mr. Professor Vithoba. Can you be highly emotionally intelligent and still struggle with mental health condition even when you have an illness? Or to put it in a different way, does improving EQ directly improve mental health, or is it the other way around?
Hello. Can you repeat the question?
Can you be highly emotionally intelligent and still struggle with a mental health condition, especially when you have an illness? To put it in a different word, does improving EQ directly improve mental health, or is it the other way around?
Okay, there's a research evidence which shows like improvement in EQ is directly correlated to improvement in mental health. As far as the first part is concerned, see, suppose you are having some physical illness or something and it is not getting healed. Over a period of time, there is something called as burnout. There is something called as a threshold. So if the threshold has reached, okay, you are using for example, to be emotionally intelligent, we are saying like you have to manage self, and you also should have a supportive group, isn't it? Or supportive family members. So if you are not having it, over a period of time when the illness is also not curable and you are getting pent up with it, you might have that. Breakdown also is there. But then when support system comes, the person will surely fight back and come back because that innate ability is there. He only needs that support from outside to understand that and come out. So that is the fact. Basically, if you see in a nutshell, being emotionally intelligent definitely helps. But it depends also on the stressors in life. For example, if I'm emotionally intelligent and your near and dear one, I lose that person. Okay, suddenly I get this news. Now that is a shocker for me, isn't it? So it depends on how fast I come out of that grief. If the grief process elongates, that means I'll be having mental ailment, isn't it? So that's possible.
Thank you, sir. Thank you, everybody. I request our chairpersons to please give a closing comment.
To conclude, Dr. Shinde has given insights about how Ayurveda can be utilized in treatment of dementia. Our own ancient modality of treatment, we can say our grandmother's treasure trove, purse full of treasure trove, or in Marathi we say Ajitsa Batwa. So it was enlightening for us to know that yes, Ayurveda does have role when it comes to treatment of dementia. On behalf of organizers, I also thank Professor Vithoba for very energetic speech and for giving a lot of tips about emotional regulations. And that will definitely come handy when it comes to treating dementia. Thank you.
I request our chairpersons to please felicitate the speakers. Thank you, Dr. Shinde, for coming here today. Vithoba, sir. I would like to call upon Dr. Joshi, sir, to please give a token of appreciation to our chairperson and the co-chair. So that brings us to the last few minutes before it's time to say goodbye. We would now like to quickly begin our valedictory function. Saranna, help. Thank you, sir. I would like to invite Dr. Ronnie George, sir, Dr. Sandeep Mahamuni, sir, Mrs. Renu Vora, ma'am, and Dr. Joshi, sir, for the valedictory function. Kindly come on stage, please. So, dar, fear, and bhay. Imagine that lady lying in the dustbin, what we saw yesterday in Antarnad. Imagine hearing words like being reduced to a figment of the former self. Listening to all this definitely makes us fearful. So are we going back carrying this fear and dar in us? No. Let us hold our hands together and say कि आँख से उसकी आँख मिला के भिड़ जाने का नाम है प्यारे दंगल. So this dangal against dementia, let us all join hands and go back with complete energy and enthusiasm to learn more and do more towards dementia. Say yes? Thank you. We begin with our valedictory function. I invite Dr. Ronnie, sir, to kindly address the gathering.
Good evening, everyone. I think the last session by Professor Vitoba, we all go with a lot of mixed emotions from this conference, ARDSICON 2024. I'm sure that so many months of hard work has ultimately paid off. And you know, since the time, of course, we did not have much time, but still, within few months, we had a teamwork of the staff at Chaitanya Institute for Mental Health, ARDSI National Office, Pune Psychiatric Association, and moreover, the guidance from Dr. Vidyadhar Vatve Saab, Agashe Saab, Davale Saab, and I knew that this conference is going to be a successful one because of one simple reason, that there were people behind us like Dr. Vatve and Dr. Agashe Saab and also Dr. Davale. If you remember the last meeting that we had at C-Secret, you know, we had an organizing committee meeting, and one person's presence made a lot of changes. That was a master of all, I would say all conferences, especially scientific committee member, Dr. Davale. That gave us the exact guidance how we are going to approach this conference, and we have executed that. Now, when you talk about Chaitanya family, you know, as a staff, we are 250 plus. And this conference, you know, I have attended many conferences in many places. I have always seen the organizers are hiring event managers, or event management company is given that responsibility. But I think with this conference, we have also proved that we can manage an event without you know, hiring anyone. And this conference also have opened new avenues for many people. For example, Dr. Sainab jo comparing karti thi idhar, wo chupa Rustam nigli. And I'm sure that many people have taken her number yesterday itself. You know, there is a West Zone conference coming up in Mumbai. I'm 100% sure that you are going to be called there. And not only Dr. Sainab, but Dr. Anurag from Chaitanya, Dr. Brigadier Sudarshan from Chaitanya, Dr. Sapna Sheikh from Chaitanya, Dr. Saindini Mukherjee. All of them proved that they can be good comparers. I'm very happy for that. Dear friends, we had many people coming from different parts of country. starting with, Dr. Manjari Tripathi, Sanjay Kumawat, Meera Pattabhiraman Madam, Sheba Nainan, Avinash D'Souza, Rohan Jagirdar, Ambika Singh, Jaspreet Kaur, Amit Dayas from Goa, Neelanjana Maulik attending from Kolkata, Asim Sarode from Pune, Dr. Matthew Varghese, Bangalore, E.S. Krishnamurthy, Chennai, Hanumandarja Joshi, family member from Mysore, Monita Tongcham, Bharati Vidyapith, Dr. Anurag Borade, Gautam Vincent from Kerala, young musician, Mr. Sailesh Misra, Greg Kuriakos, Mr. Narendra, Emily, ADI member, and Kusum Devi, Sindhu N from Thiruvananthapuram, Dr. D.L. Shinde, and make everyone very energetic at the end, Vitoba from Goa. This showed how important this conference was, and the selection of the topic, I must appreciate the organizing committee, scientific committee rather, for choosing this subject, and you have got appropriate persons for this. It was again a proof for public-private partnership, which we need to promote further, because the person who was there in the morning, Dr. Swapnil Lale, see, I'm here for 25 years working in the field of mental health. I have come across many directors in the Directorate of Health Services, Mumbai. But when I approached Dr. Swapnil Lale, he said, we are having an SMHA meeting next week. I'm going to give you 5 minutes to make a presentation. And I went to Mumbai, and he, it was online. He requested if you could come in person. I went there, and the same day itself, they decided that we are going to participate in large number. The success of this conference, what we have witnessed. We have mental health professionals from across Maharashtra attending this. And they are all grassroots workers. They are having day-to-day interaction with the public. And I'm sure that this conference must have given a lot of insight to each participant, especially from MHRB of Maharashtra. सिर्फ ताली बजाने से काम नहीं होगा, वापस जाके, it should reflect in your work, and the government, and your deputy director, and the people who are sitting in Mumbai should realize that, yes, this was a right decision, and they should come forward for programs in future too. So, it was a golden opportunity for you. Whenever we had various people addressing, many people congratulated me calling my name. It is not my achievement. Yes, I was instrumental in gathering people, but I too have a large number of team who are present here, and when they are present here, there are people who are taking care of their responsibilities as added one back home, that is in Chaitanya. Joby and Pooja. Joby hai ke idhar? Joby and Pooja. Jara haath uthao aap, See, these were the people given the responsibility of organizing this entire conference, and to help them. Ando, since has come all the way from Kerala Center, Angela, Jinu from Goa Center, Ramya, Blassi, Naneshwar, Tinsi, Prince, Rahul, Reena, and Rekha Mosi, Vishwanath, Vishwas, and Somnath as our drivers, Mahesh, Prem, and so many other staff who have worked for this successful conference. So, I must appreciate you for being a part of us, and it has really proved that, yes, I'm going to give you more responsibilities now because you have proved this to be correct. Support from ARDSI National Office, I cannot forget. Meera ma'am, Renu Vora ma'am, Narendra, Joshi Saab, Major Saab, and Dr. Reggie Paul, you all have helped us to make it successful. When I met Dr. Swapnil Deshmukh and Sandeep Mahamuni in one of the PPA meeting, I requested their support for this ARDSI conference, which they have happily agreed. Dr. Swapnil was there entire day yesterday, and he joined here today also, because they are already having a conference running about just 5-6 kilometers away from this venue, and it is also Pune Psychiatric Association ka hai, but you know, Swapnil has given his time, and Sandeep Mahamuni Sahab was there right from the beginning. He is here. One person that we missed in this entire conference was Mr. Tojo, one of our staff members, whose father is seriously admitted in the hospital. Every time he would call up and ask, "Kaise hai? Kab tak hua? Is time acha karne ka?" You know, that is what he used to say. Tojo, we really miss you. And I have two friends who have taken off from their office and come for this program to help us. That is, one is Debjani and one is Joyda. Thank you for that. You had excellent dinner. Those who attended the dinner, I'm sure that you must have enjoyed that. Without the help of Sabu, who is managing that facility, and Rajiv, who is assisting him, it would not have been possible. And we also had two fantastic movies. Rather, you know, whenever you think about ARDSICON or ARDSI or persons with the dementia and Alzheimer's, I'm sure that until you have dementia, which I pray it should not be there, you will never forget these two movies, you know, Partha and Dr. Mohan Agashe. You know, we had a detailed discussion yesterday, and all these were some of the highlights of this conference. And thank you so much. And I would like to welcome Renu Vora Madam, our President, Joshi Saab, our General Secretary of ARDSI, and Sandeep Mahamuni Saab, our PPA President, for this valedictory function. Thank you.
May I call upon Dr. Sandeep Mahamuni, sir?
At the outset, I feel privileged and humbled to be standing here in front of you as chief guest of this valedictory function. So, to begin with, I must congratulate ARDSI Pune chapter for organizing such a wonderful conference on dementia, and I'm sure the topics which are discussed in this conference will be fruitful. It's like a Pandora's box filled with a lot of difficulties as well as solutions to circumvent. So this conference, like a Pandora's box, discussed a lot of difficulties which are associated with dementia, but along with that, it has given a lot of solutions, how to circumvent, how to navigate these problems which are part of dementia management. So this conference gives hope. You know, there is hope that patients with dementia will fare better in years to come, and they will live life of dignity. And I think that is what is more important. So during last 2 days, when many speakers were delivering their lectures, I selected or jotted down few lines which I felt are very important. So I will read out these lines by various speakers. So if you are diagnosed with dementia, that doesn't mean that you cease to exist. So I found this statement so profound. So just because somebody is diagnosed with dementia does not mean that it is end of it all. Whatever remaining years that patient has, he has right to live that life with dignity and happiness and with contentment. Another line which touched my heart is that we better to under promise and over deliver. So that is something which I really loved about that speaker. And there was a lot of talk about healthy aging and delaying this onset of dementia, and so many suggestions were given by various speakers, and that was something which will be beneficial to everyone sitting out here. So the very thing that we are sitting here, we are gathering here and having communication itself is one step towards prevention of dementia. And last line by Dr. Agashe was, we should appeal to the human in ourselves, to be generous, to be gentle, and to be patient with this specific population suffering from dementia. And those two movies also portrayed the importance of having patience when we are taking care of these patients. So I will conclude my speech by saying few lines. So what if patient suffering from dementia says about his condition in a poetic way? So the title is Fading Threads. So I once knew the stories, few with joy, few with pain. Now they slip out of my mind like whispers in the rain. A door stands open, but where does it lead? I try to remember, but forget what I need. Your face is familiar, a soft, distant glow, but your name evades me like footprints in the snow. I search for echoes of laughter and light. They flicker and vanish like stars in the night. Some days I'm here, some days I'm gone. Gone in the memories of the era that is bygone. But hold me close, I still feel the love. It anchors me softly like wings of dove. Though my mind may wander and memories may stray, my heart remembers in its own special way, in its own special way. Thank you.
Thank you very, very much, sir. May I now call upon Mrs. Renu Vora, ma'am, to please give an evaluation of the entire two-day conference.
Good evening, everyone. I want to extend my heartful gratitude for the extraordinary effort and dedication that Ronnie George and ARDSI Pune team put together in organizing such a successful and impactful conference on dementia under the aegis of Alzheimer's and Related Disorders Society of India. This event was not only well planned, but executed with marked pivotal moment in advancing our understanding of dementia care, caregiving, public policy, and innovations in the field. The conference began with an auspicious note, inaugurated by the soulful bhajan performed by the residents of Geriatric and Dementia Care Unit of the Pune chapter, setting the tone for a meaningful event. Dr. Mohan Agase, the chief patron, delivered a brilliant keynote address emphasizing the importance of evaluating conditional decline emotional decline alongside cognitive decline in the dementia patient. His insights on this often overlooked aspect promise to reshape the caregiving approaches, making it a more compassionate and holistic. The sessions were truly remarkable, beginning with Paula's comprehensive overview of the global dementia scenario, followed by Mira's call for country-specific plans to the conference. And the conference also had the honor of instituting 2 new awards in the name of Dr. Jacob Roy, ARDSI founder, for the contribution to dementia care, Mr. Sailesh Mishra of the Silver Innings received the award for the best individual in dementia care services, while Dr. Hanumanchar Joshi from the Mysuru chapter was recognized for his institutional contribution to dementia awareness and services. Dr. Manjari Tripathi from AIMS started the discussion on innovations of dementia care, focusing on the emerging treatments and accessibility and affordability, and the new biomarkers in early diagnosis. Dr. Shiba provided valuable insights into prevalence and the incidence of dementia, and Dr. Avinash D'Souza stirred up minds with his thought-provoking session on managing unusual sexual behavior with persons living with dementia. Dr. Amit Dias shed light on modifiable risk factors and ways to reduce them, followed by a session of Nilanjana Malik from Kolkata, which delved into the nuances of efficient and effective caregiving. Dr. Mohan Agase took a special moment to appreciate the young director's work, adding to the evening's impact. The second day saw further exploration of neurological aspects, more innovations on care, and continued discussions on policy advocacy. In particular, Mr. Gregg made an excellent presentation on care services he's heading, and Mr. Sailesh Mishra shared his valuable experiences that resonated with the audience. I cannot thank Ronnie George enough for his dynamic leadership and dedication to this cause. His book, based on his 25 years experience of serving geriatric and dementia patients, stand as a testament to his deep commitment. I also extend my sincere thanks to the scientific committee headed by Dr. Joshi and all the contributors who worked tirelessly to bring this conference to life. The presence of Drs. Roy family in distributing the awards made the occasion even more special. In conclusion, the conferences not only highlighted the latest research and innovation approaches, but also created a platform for collaboration and discussion, knowledge sharing, and it was heartening to witness such dedication and passion towards improving dementia care. And I salute to the entire team for the tireless efforts in making this event a resounding success. Your work is making a significant difference in the fight against Alzheimer's and related disorders, and I'm grateful for this opportunity to have been a part of this important event. Thank you very much.
Thank you, ma'am. And before we go ahead with the vote of thanks, our team has picked up one member from the audience just randomly to talk about the experience that they had over the past 2 days. May I request Dr. Neha Jain, founder and CEO of the Nile Health Services, to kindly do the needful.
Good evening, everybody. Thank you for the opportunity, ARDSI and Mr. Ronnie. This is my first time attending ARDSI, the national conference. And when I had registered for this conference, I probably hadn't known that what an academic treat it is going to be. I have been working in the space of dementia and researching on this for about an year now. But I think these 2 days have enhanced my understanding of the topic manifold. And a lot has been said, right from prevention, like healthy aging, to the latest trends and everything. But what has been most hard-hitting lines that I'm going to carry, back home were two things. Both of them were by Dr. Mohan Agashe. I actually wrote them, and I went back and I made it a point that I go and tell my husband. One was that, that emotions, they are an individual function, and what we all have, now have been exhibiting our emotions as a part of the social functions. Like, we all have time to go out in gatherings, marches and everything, but we probably do not find time to hug our parents. As somebody from us rightly mentioned that, they have a special exercise that, oh, you should hug your father, you should hug your mother. That is something that probably we all know we should do, but we have of late forgotten that how important it is. The second thing is that what aging is, how we look at old people when we are young is very, very different from how we would look at them when we ourselves grow old. And that's actually so spot on, ladies and gentlemen. I can't agree more. It's like, it reminds us of what our parents who used to say when we were not married is that, abhi nahi samjhoge, jab maa baap ban jaoge, tab khud samjhoge ki, how parents feel and all that. So I really dread aging now, but yeah, I think I'm going to age a little more wiser, little more empathetic and compassionate. So that's my biggest takeaway. And last, I think we all have been shaken up like by Dr. Vithoba when he said emotions are non-biodegradable as well as emotions are contagious. So in our own little ways, small ways, everybody who is sitting in the audience, the biggest emotion we are carrying from here is dementia. Time to take action on dementia and let it be the most contagious emotion we carry forward back home in our workplace as well as in our lives. So last but not the least, one very important thing that yesterday we learned about how we can bring in prevention against Alzheimer right at the school level. Dr. Amit, I can't thank you more for emphasizing on this. I have a patient of dementia at home, and I always tell my daughters, "Bete dadi se अच्छे से बात करो, dadi se bas, this is all." But yesterday I went back home and I kind of narrated both the movies to my daughter, the elder one. She kept listening, and I told her, what, Diya, I'm going to come to your school. I think I really need to meet your class, and we are going to sensitize, your. And then she said, "Why, Mama?" I said, "Bete, आजकल हम nuclear families में रहते हैं ना, पता ही नहीं होते दादा दादी कहाँ हैं, how important they are for us. I think I really need to go and kind of bring back those relationships into your lives." So this is what I'm certainly going to do, Dr. Amit. Thank you very, very much. Thank you, Ronnie. Thank you, ARDSI, for this wonderful, and I look forward to attending it next year again. Thank you so much.
Thank you very much. A feedback form has been given at the reception desk, and I request everybody to kindly fill that so that we also know where to improve and how we can get more better. I request Dr. Joshi sir to please come and deliver the vote of thanks, following which we will all stand up for the national anthem.
Good evening to everyone. And Thanksgiving is one of the most difficult part because it will be concluding, the excellent fellowship what we had and the interaction also. Nevertheless, and all of will agree that the conference has met the purpose. The planning which was executed excellently. He is telling that he is not the only one person, but we know because our leader is always a leader, and a leader is a person who can take people together. And especially last 2 days we have observed his excellent, energetic and young team have prepared, and they were also looking very well as if they were in a marriage function. There was only one absence. There was no groom and as well as a bride. Otherwise, it was just like a marriage or like a festival. And before I come to the vote of thanks, I would like to express few things here. We have been participating in many of the conferences. Definitely, Mrs. Meera will accept it. Many international, national conferences. This personal touch, we never found. Whether it is, receiving, whether it is talking to the people, I can see this gentleman. I can understand. We have also done a lot of conferences. The stress what you will have, bringing the people, like, the father of a bride or maybe nowadays groom, right? So receiving the people and, whether they will have some kind of difficulty. My heartfelt appreciation to him, starting from the airport till now, in future also, the personal touch, not only that, because normally what we do, especially in dinners and all, maybe in fellowship, we say hello, hi and sit. This gentleman have such an energy that himself, he's serving the people. What else you require? And let me tell you, Roni, I told you yesterday also, the respect towards you has, multiplied now. Number one, you are always my brother. We always keep on talking. This kind of personal touch we never, saw in our entire conferences, whatever we participated. A big round of applause to him. And these young girls and boys, of course you are young, definitely younger to me. Wonderful, they were always smiling. I did not find any kind of difficulty while organizing this, and we also can see our gentlemen here, right? So it was a wonderful atmosphere here, and we are definitely carrying the memories here. And now, ARDSI Pune has set a benchmark for all the ARDSI chapters in the entire country that how to organize a conference. Now we have to be very careful when we start planning for a conference. So thanks to Roni and team, and there are no words to express, the thanks to you. And thanks to our chairperson Renuji, and our President Emeritus Meera, and our chief guest today, Dr. Mahamuni. And all, the keynote speakers, the people who have been speaking from last 2 days. Not only that, excellent audience. And I have one more word of appreciation here. You please consider as thanks only, okay? See, in many of the conferences, even including, Alzheimer conferences abroad, we don't find more than 20 in a hall, especially in the valedictory session. And I could observe yesterday in almost all the sessions, and today also, the audience are of quality, right? It is not only quantity, the quality is also very much important. That I could make it from, words of, one of our delegate here. If someone takes, a message from the conference, I think, the purpose is met. So thanks to everyone, and thanks to all, and few committees I would like to express here. Especially, number one, it's not like rating, but, from, first is, the paid puja, isn't it? So heartiest, appreciation and thanks to the committee which is involved in, hospitality and as well as catering. And the Scientific Services Committee have done an excellent work, especially in this short span of time. When we discussed with Roni that we want, the planning is to have it in September, it was told only somewhere in August, maybe in the end of July. He was telling we will do it in November, but we had some other issues, so we could do it in September. Excellent, and you did very well. And the speakers also, you could call speakers from across the country, the other countries also, especially in a short span of time. And your HR, your approach, your contacts, excellent. So it's a benchmark for everyone. It's an some kind of a sign for us also. So thanks to all, and thanks to everyone. We have made this really successful, and we will carry the memory. And let us not have any kind of amnesia. Let us keep on meeting each other, regularly. And before I wind up, with the permission of the chair, let me announce that next conference is going to be in Mysore. I welcome you all. On behalf of the team Mysuru, and of course from ARDSI National Office, I welcome you all to the city of Palace of Mysore. And Mysore is an excellent city. There are wonderful palaces, and there are beautiful places to come around. Please come with your family. And I am not very sure whether I can talk before Roni, that definitely we will make your stay very happy and more. Thank you so much, and good day. God bless you.
में जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत। भक्तभावि